to start these hearings off, the study committee, with really looking at the data. And they have done an amazing job of compiling a lot of statistics and data. So we kind of get a full picture of what we're looking at and looking at the metrics that we would like to see changed in the state. So thank you. And if y'all go ahead.
Oh, it helps if the microphone is on. Hello, I'm Heather Hanna. I'm an assistant research professor at the Social Science Research Center. And we are a research institution that was established at Mississippi State University in 1950. And we continue to serve the state through data collection and analysis today. And my work over the past 20 years has really focused on improving systems for children and families in Mississippi. And so I'm just so pleased to talk about the status of women and children in the state. And I'm really looking forward in the subsequent days to hearing about some of the policy recommendations that we hope can really do a number of things for us. Number one is ensure children are able to fulfill their promise. As we know, the early years are so critical for brain development, that families are able to reach their civic potential, and that the state saves valuable dollars by addressing problems before they become too difficult to handle. And I just want to thank the senators. I want to thank y'all so much for everything that you have already done to these ends. As our group was preparing the data for this presentation, we all started sharing our personal stories as women about how we have been impacted by these issues. And I just really wanted to set the tone today by starting off with my own personal story of a time in my life when I was younger. And I really saw my ex-husband as the primary breadwinner, and I had a job, but I saw it as supplemental. And I really felt like my main role was going to be to raise our kids. But when our son was 2, our marriage fell apart, and I found myself really unable to make ends meet. And I wound up having to move another family into our home, which was a modest home, to help cover the bills. And this really caused a lot of psychological stress for me, my son, and the other family as well. And so I was so overwhelmed trying to take care of my son at that time. I did not have the resources, and the energy, to be honest, and the resources to buy the clothes and the makeup and everything that it took to really do and get that kind of job I knew I needed to take care of my son. I was very lucky, and my mother hired me to work in her insurance company. Now, I know that not everyone has those types of resources and supports. And this left me with such a profound, really empathy and understanding of how quickly women in Mississippi can fall through the cracks and how so many are born under the cracks with no way to rise up. And I knew for the rest of my life, I wanted to devote myself to improving the systems that allow women and children to thrive. So today represents a tremendous opportunity to do just that. And I thank you so much for your willingness to explore these data with us and to think about how to strengthen the systems in Mississippi for women and children. Okay, so we've been asked to present a picture of the status of women and young children in Mississippi. So what is the state of the state in Mississippi? If we look at rankings from the U.S. News and World Report for last year, we see that we're last overall in quality of life. Last in healthcare, almost last in overall quality of life in the economy, and toward the bottom in opportunity. We all know that Mississippi is a place of caring, genuine people, no matter who you interact with. To a T, this almost fits our description. So what are the structures and the systems that are behind these rankings that pertain to maternal and child well-being? So we know that access to high-quality healthcare, childcare, adoption, and foster care services and early intervention services are critical to improving lives of mothers and families of young children. And while these are not the only issues that matter, they are very important, and they're the ones that we're going to be covering in the hearings over the next several days. And having strong services like these ensures children reach their potential, families can engage in the workforce, and the Mississippi economy is stable and strong. So let's take a minute to look at employment and wages. So despite a low unemployment rate, Mississippi has a labor force participation rate that is quite low. It's just 55%, which is the lowest in the nation. And this means that 39% of children are born to households with no full-time working parent. So let's take a look at why this may be the case. So as you can see, there are a number of barriers to workforce participation that mothers and families of young children may face. And these barriers often interact with one another, and they compound, often making it very difficult or not economically feasible to work outside the home. So today, we're going to be looking at the data behind some of these barriers, including wages, housing, healthcare access, childcare, early intervention services, and food security. So first, we're going to look at wages. We know that children in Mississippi face the highest poverty rates in the nation. 43% of Black children in Mississippi live in poverty. Barriers such as housing policies and practices and community disinvestment over time means fewer opportunities and resources for Black families. And we know that growing up in poverty or experiencing inconsistent income has significant implications on children's outcome, both in the short term and the long term. And it greatly contributes to parental stress and ability to consistently participate in the workforce. And we know that the poverty rate really does not capture the full picture of family struggles. Many parents fall between what is considered a benefits-eligible poverty line and a livable wage, with women raising children on their own making just half what is considered a living wage. So let's take a look at a basic budget, including food, childcare, medical care, housing, transportation, and annual taxes for one adult and two children. We quickly see that the amount needed is 5 times our state's minimum wage. And this does not include costs like children's school clothes or haircuts. There are a host of anti-poverty strategies that other states have adopted that could help Mississippi. So participating in the workforce helps people support their families and is critical for those experiencing poverty. And while everybody should be able to participate in the workforce if they are able, Black and Hispanic families are more likely to face the barriers that we've been talking about, such as low wages and access to affordable childcare. So to ensure that everyone can have enough money to support the health and well-being of their family, we can incentivize employers to offer supports like access to childcare that make it easier for workers to work and earn enough income. So here in this map, we see high levels of poverty in dark green and lower levels in light green. And this map helps us to understand that children may have access to different resources or supports depending on where they grow up. Areas with low resources represent untapped potential, indicating that investment in these families and these communities can yield strong returns for our state. And no matter where children live, they deserve the opportunity to have the same resources. that help them thrive. This graph shows us that examining poverty by county doesn't even tell the full story. While Madison County has our lowest rate of child poverty at 15%, there are still much higher rates of poverty within the county among Black and Hispanic children, indicating that issues such as low wages and access to affordable childcare impact Black and Hispanic women and families, even in our most prosperous counties. And that strategies to explore the specific needs of Black and Hispanic families in a given area should be used to ensure children thrive regardless of their neighborhood. So I'm just going to read the slide title. Women in Mississippi have higher rates of educational attainment than men, yet earn less. So let's just take that in for a second. So women in Mississippi are more likely to go to college, and yet men consistently earn more across the education spectrum. So women as a group face wage disparities and often must sideline their careers to take care of children. And so policies such as improved family leave and sick leave and affordable childcare can directly benefit women's ability to participate and thrive in the workforce. So here on this slide, we see that having only one adult in the household can often make time management and economic barriers even more challenging. Clearly, if you cannot afford reliable transportation and childcare based on your wages, then your workforce participation will be limited. We know many families experience these issues just as I did, since 46% of children in Mississippi live in single-parent families that could benefit from strong policies and system-level supports to ensure that children fulfill their promise, families reach their civic potential, and the state benefits by addressing these issues early on before they multiply and become too difficult to handle. That concludes my part, and I'm going to turn it over to our SSRC, Social Science Research Center Director, Dr. Devin Brenner.
Good morning, I'm Devin Brenner. I've been the director at the Social Science Research Center for about a year now. My background is in teacher education, in elementary education, working particularly on the rural teacher workforce in my own scholarship. But as director, I get to support these teams of research like Heather and Callie, who are doing work to address a variety of social challenges at in the state and across the nation. So we're excited to be able to be here today and share some of our work and the data that we have compiled from state and national sources. And I want to start out with a little bit of story of my own, like Heather. When I was in grad school at Michigan State University, I unexpectedly first became a parent and then became a single parent. And the support that really made a difference for me was childcare vouchers. So I was able to continue my PhD and to continue a really stressful but interesting graduate assistantship that gave me so many opportunities. And then in 1999, I got to come to Mississippi and bring all those skills that I had built, and I've been here ever since. So really grateful for those supports that I had available to me. We're gonna first figure out where the pointer is. Here it is. First thinking a few little pieces of data about housing in the state of Mississippi and how we know that access to safe, available, affordable housing can make a big difference about whether people can participate in the workforce. The Joint Center on Housing estimates that it would be best if housing costs were less than 30% of a person's income. That 30% is sort of that cutoff for whether or not housing is affordable. And across the nation, there are 21 million people for whom housing costs are much more than 30% of their income, and that can be a real burden for them. And the National Low Income Housing Coalition calculated the cost of average rent in the state of Mississippi, which is $540, which in Starkville is really just the cost of one bedroom in a 4-bedroom apartment. But across the state, it's about $540. If you make a minimum wage, you have to work 72 hours to be able to afford a 1-bedroom house in the state of Mississippi. And so we know that housing is not affordable for many of our residents, and well more than above 1/3 of their income. Our official figures, see, did I do it too many times? Our official figures related to homelessness suggest that we have low rates of homelessness in the state of Mississippi, but we know that over 7,000 school children are really receiving services under federal homeless programs. So we know that there are homeless people in the state of Mississippi, but what we also know is that we are a very rural state. And so our homeless statistics are definitely undercounted in that we have lots of kids who are living in multi-generational families, who are living, like Heather did, who are living in crowded homes, who may be moving from friends to friends to friends. And so they officially have a place to stay, but it doesn't last very long, or they're sleeping on a couch or the living room floor. And so our homelessness statistics may not represent the full picture. And we also know that across the state, you were so much better at this. There it is. Okay. Across the state, about 1 in 10 Mississippi children is living in crowded conditions. And that is calculated by the Kids Count Data Center. And that means that that is calculated based on the number of people living in a house divided by the number of rooms in a house, not number of bedrooms, but rooms. So if you have a 1-bedroom house with a living room, a kitchen, and a bedroom, there's probably 7 people living there if you're among these 1 in 10. 7 or more people. And if you live in crowded conditions, that is particularly stressful. Crowded conditions are linked to low birth weight and poor physical and mental health and low school performance. And so housing affordability is definitely a factor in the lives of women and families. We also know that access to nutritious food is a health issue, and that if you have consistent, stable access to nutritious food and enough food, that can prevent a lot of chronic health issues, including mental health, prenatal health, infant birth weight, child growth and development, and even have outcomes for academic achievement. Hunger, both short-term and long-term, has impacts for kids and for moms. The term food insecure refers to whether or not over a period of a year you have consistent, you know for sure that you're going to be able to feed your family. And in Mississippi, our trends are going down, but our kids experience hunger more than the national average. And so in the most recent data, about 1 in 5 kids experience food insecurity over the last year. And that is about 5% more than the national average. So they're not sure, moms are not sure they're going to be able to feed their kids consistently across a year. So too many kids experience hunger. And this map, the darker areas, show areas that have the least amount of access to food security in our state. And food security is calculated based on wages and whether wages are sufficient to purchase food, whether there's access to stores that are selling nutritious food on a consistent basis, and whether there's transportation to get to those stores. Yeah. And we know that the Supplemental Nutrition SNAP Assistance Program, it has multiple benefits, both for families and for communities. So for families, participation in SNAP can reduce food insecurity by almost 20%. But for children, it's particularly powerful if families are consistently receiving SNAP benefits for at least 6 months. Then food insecurity goes down by about 1/3. And SNAP benefit also benefit communities. So SNAP is one of those programs where the benefits to the families immediately turn around and benefit the community. And so the US Department of Agriculture Economic Research Service estimates that every dollar invested in the SNAP program returns $1.79 to the local economy. It's good for retailers, it's good for farmers in our state. So the next set of slides I wanted to share has to do with access to healthcare, and then we'll take a look at sort of health outcomes for moms and children in our state. So Mississippi has a high rate of uninsured individuals, and on this map, the darker areas are the places with the fewest number of adults who have health insurance. So 26% of adults in those darker counties do not have health insurance. The lighter counties, it's more like 13%. When we look beyond adults, we know that about 1 in 6 women who are of childbearing age do not have health insurance. And programs like CHIP are making a difference, but we still have 4.4% of kids under the age of 18 who were uninsured in 2021, according to the Kaiser Family Foundation. So our rate of uninsured adults and children has us the 7th lowest in the nation. And access to health insurance can determine whether you get preventative care. It can determine whether you seek care for problems before they become expensive emergencies. We also know that in our state, we have disparities in access to primary care physicians. We have sort of a patchy network of systems for primary care physicians. The dark areas have over 100 primary care physicians per 100,000 people, but the light areas have 0 primary care physicians in those counties per 100,000 people. So maybe they have, 1 and they have 200,000 people and that rounds to 0. But some of our counties have no full-time doctors in them. And so even if you have insurance, if you don't have a doctor to go to, that can be a real challenge. And it's not consistent across our state. And we know that many of our moms are suffering from underlying health conditions such as obesity or diabetes or hypertension, and that access to primary care is incredibly important. And then that is compounded. This is a map generated by a project at the SSRC. It's a set of resources for moms and kids related to early childhood and early intervention. And this map is a map of the locations of obstetricians and gynecologists and women's clinics in the state. And specialty care can be particularly important for moms who have underlying health conditions or who are high risk, and we don't have specialized care for childbearing women across all of the parts of our state. And if transportation is an issue and your obstetrician is a ways away, or you experience emergency during your pregnancy and you don't have access to somebody who knows how to help you, that can be a real problem. So these factors, access to healthcare, as well as poverty and housing and hunger, these add up to low outcomes for moms and for babies in our state. Per the Center for Disease Control and the Mississippi Department of Health, in Mississippi, about 12% of babies overall are born at low birth weight, which is defined as weighing 5.5 pounds when you're born. And that's the green. The yellow is for non-white families and the orange is for white families. And so it's even, we have disparities in that figure. The second bar graph from the left is preterm births. A preterm birth is defined as a baby that's born before 37 weeks. And we have about 14% of babies are born early. And again, we have disparities across the two groups for preterm births. And then the middle one is not percentages. That's actually per 1,000. So in Mississippi, 9 out of 1,000 babies die. They do not survive. And that number is highest in the nation, and it is too high for the state of Mississippi, and it is higher for non-white families than it is for white. And all of these could be partly addressed with access to prenatal care, but the taller bars on the left, those represent access, women who access prenatal care during the first trimester of their pregnancy. And about 25% of women do not access prenatal care in the first trimester. They may not know they're pregnant. They may not have access to prenatal care. They may not have health insurance for a variety of reasons, but that is a problem that is fixable. And we know that health risks for moms can have profound impacts both for their mother and for their children. So children who have underlying health conditions during their pregnancy, their kids, they themselves are more likely to have health conditions that put them at risk for maternal health, and their children are more likely to have health conditions that may result in asthma or cardiovascular disease. It also can result in behavioral and developmental challenges as well when the kids are born. And so prenatal care can really pay off in the long run. In that, across the nation, the negative health outcomes for moms and children are super expensive. We spend $21.9 billion on kids, mothers and their children between conception and age 1. And then all the way, those don't go away as children turn from 2 to 5, it's another $32 billion that we spend as a nation caring for moms and their babies, particularly when those moms have underlying health conditions. And those can be heart conditions, preterm birth, developmental disorders, as well as non-medical concerns like loss in productivity or behavioral and developmental disorders. And so supporting moms and their babies can really decrease these costs. And now I'm going to turn it over to Lori. Good luck with that.
Hi, my name is Lori Elmore Staten. I'm a Mathis scientist, extension specialist, and an associate professor in the School of Human Sciences. I've spent the last 25 years studying children and family development, and the last 10 of those have been here in Mississippi. I currently collaborate with Dr. Alicia Hardman, who is the State Extension Family Life Specialist, on a project called Protect and Connect that is funded through MDHS, and it's a parent education project. We also have collaborated on developing a certificate in child advocacy studies trainings for Mississippi State University, and it's called TICA for us. But that program is actually designed to help prepare pre-service professionals to meet the needs of children and families in the welfare system. Dr. Hardman and I, as well as Dr. Parker, also collaborate with the Division of Early Childhood Care and Development on early child care workforce development in the state. That's a lot of child cares, sorry. So overall, I'm very happy to be here today to really discuss with you our shared obligation to foster every child's potential. That means shoring up ways that we can support families. So that means every policy we set, from tax credits to paid leave, should reduce financial pressures on families and increase the time and capacity for supportive family relationships. Our policies can help create safe, stable, nurturing environments and reduce stress and promote overall child well-being. So we are an agricultural state. So I think this graphic is a great depiction of what some of the stresses that we see in childhood and how they contribute. So I'm going to give you a little bit of an analogy here. So we recognize the importance of nutritious soil and sufficient water for healthy crops, right? Using the tree as the analogy, think about the soil as the community that provides the nutrients to the roots of the tree. When the soil is rich with well-paying jobs, ample access to quality food, housing, education, and healthcare, the health of the family, represented here by the tree, and its members, which are portrayed by the leaves, all prosper. So, however, when communities experience substandard wages, food insecurity, and lack of access to quality education and healthcare, it creates unstable and unreliable foundations for families. These rocky foundations result in challenges to the families that ultimately can perpetuate a negative cycle of ever worsening soil that often can result in poor outcomes for both children and adults. So adverse childhood experience like these are common. Actually, in the nation, it's reported that 50% of adults report having experienced at least one adversity when they were in childhood. And what we know about adverse childhood experiences is in the absence of support, they can cause long-lasting harm. So they include experiences such as witnessing violence or growing up in a household with a family member with a serious mental illness. When children experience multiple negative events like these, and they do seem to kind of pile up on each other, their bodies can be flooded with stress hormones that increase their risk for later health outcomes like heart disease, diabetes, and depression. We know that Mississippi has high rates of those health problems. Heart disease, we're the 43rd in the nation, according to the American Heart Association. We have a 40.8% obesity rate, according to the CDC, and our life expectancy is short with 74.5 years, according to the CDC. So it's really something important to think about. ACEs are really costly to our system, with recent estimates in Tennessee suggesting that experiencing multiple adversities as a child actually resulted in adult healthcare and workforce costs of $5.2 billion in 2017 alone. And that's in Tennessee. Recent research suggests that even reducing ACEs by 10% could save North America $56 billion in a year. So policies such as those that strengthen family financial security can go a long way towards reducing childhood adversity and enhancing the relationships that help children thrive. When families face financial hardship, it sets the stage for more stress and less tuned in interactions between parents and children. So boosting family incomes can relieve some of that pressure, helping to head off childhood adversity before it happens. So the next portion of our presentation really focuses on some of the systems that we have in Mississippi that are supposed to be protecting children. And I'm going to start with the Child Protection Service. So that's one system that's in place to help children who are in crisis. And the foster care system is charged with protecting children when their family has failed to be able to do so. Unfortunately, MDCPS has continuously failed our most vulnerable children, as evident in the Olivia Y lawsuit. This lawsuit was filed in 2004, and it was first settled in 2008. However, the monitoring report in 2020 or 2021 using 2020 data still identifies critical deficits in the CPS workforce, safety precautions, and record keeping. So if you look at the slides, you will see that our caseworkers have workloads that far exceed the standards. And part of that is the instability of the workforce. There's a lot of turnover in those positions. That's a hard job. You see a lot of things that you may not be prepared to see. So we really need to do a better job at preparing that workforce. And Commissioner Sanders indicated that it costs about $30,000 every time we have the high turnover rate. So if somebody comes and doesn't stay very long, there is a constant cost to the state. We also have some severe issues with safety. So in 2020, 117 children while in the care of the system were maltreated. That's 6 times the agreed upon rate, according to the settlement. So part of that has to do with children being placed in homes prior to having background checks conducted. Some other reasons may be the fact that we have insufficient numbers of licensed foster care homes, which I'll discuss more in a minute. We also have a big issue of surveillance of the data. I think some of you are aware of this, that record keeping has been a major concern. And this is particularly problematic when you're talking about youth transitioning to independent living, because when you aren't able to access your birth certificate and your social security card easily, that creates a problem for you continuing your education or entering the workforce. So As I said, these data are like a snapshot from 2020. There has been progress made. Commissioner Sanders was put in place in November of 2020, which is right before these statistics were based on. And, she indicated through a conversation that these are still some of the concerns that she has, but she is definitely working on trying to mend the system. But in addition, we really need to help her through prevention, because if we don't prevent further children from entering the system, then we're never going to be able to fix the broken system. So to give you a little bit of an idea of what that looks like, here you see the number of youth in care. There's not a lot of good information out there as to why we see a pretty significant drop over years. Now, we can say in 2020, there was a pandemic. There are children who did not go to well visits or attend childcare outside of their home. And this definitely contributed to a lower rate of reporting. However, that's not the whole picture. But we do see that we're starting to see an uptick again in 2021, where we had, I think, 134 new cases. So at the same time, we are seeing a dramatic decrease in the number of licensed foster care homes that we have available. These numbers result in a ratio of 2 youth in each licensed foster care home, underscoring that policies need to prevent the number of children who are entering the system, but also support families who are willing to open their homes to children in the system. Currently, we have 1,384 children awaiting adoption in Mississippi. The largest share of children waiting for adoption in 2020 were between the ages of 3 and 5. Most of the children waiting for adoption fall under the age of 7, so it does become more challenging to find a home for children when they are older. But it's important to also recognize that the largest share of children adopted in 2020 also was in that same younger age range. Okay, so these data really underscore the importance of supporting families in the early years, because that's where we seem to have a higher number. So prevention of child maltreatment through parent education reduces the burden on the system and results in a substantial return on investment. Recent estimates from MDCPS suggest that it takes about $40,000 a year to care for a child in the foster care system. Based on that estimate, MDCPS needed more $5 million extra dollars to provide basic care in 2021 than it did in 2022, with that small increase of 134 children. Well, small in relative. While Washington State reported saving $7 million by preventing 244 youth placements a decade ago, we estimate on today's in today's dollars that Mississippi would save almost $10 million preventing the same number of placements with today's cost. However, it's important to recognize that in order to do prevention, we need to do it well, which means that it needs to be implemented using evidence-based practices, and there needs to be evaluation in order to actually understand the return on investment. So good programming is important. So I leave you today with some building blocks for how you can prevent child maltreatment at all different levels, because I truly believe that that is a shared responsibility that we all have. We can prevent harm just by how we interact with other people, but also through policy. So child maltreatment and prevention and mending the broken foster care system are important to focus on simultaneously. We can accomplish these goals by creating policies that support safety of all people, financial and workforce stability, and programs that meet the needs of families experiencing stress or crisis. Thank you.
Good morning, Senators. My name is Julie Parker. I'm an associate professor in the School of Human Sciences at Mississippi State University. I also serve as the graduate coordinator for the only early intervention program, pre-service program in our state. And then I also serve on 2 governor-appointed committees, one being the State Early Childhood Advisory Board, or CCAC, and then the State Interagency Coordinating Council for our Part C programming in the state, which is what I'm here to talk to you most primarily about today. I have over 25 years of experience in early childhood and early education, primarily working with, as a practitioner with very young children and their families, and then as an academician, being able to teach those students in pre-service programs to do the same thing. So I not only come here with just a couple of years of experience, but also a significant passion for the quality of life for children and families in Mississippi. I'd like to share with you today, though, more information about our early intervention program. There we go. So early intervention is an opportunity to serve some of our most vulnerable children in the state of Mississippi, and under the federal law of IDEA, we have 2 parts to an early intervention program. We have our Part C program that serves our children birth up to 36 months. And then we have our Part B program that serves our children 3 to 5-year-olds. Our Part C program is currently administered by our State Department of Health here in Mississippi. And our Part B program is administered by our State Department of Education. Throughout the nation, the Part C program can be administered by different agencies because it's a discretionary program under federal law, but Part B is always administered by the Education Department in each state. Early intervention is a really important program, not only to me from a professional standpoint, but also recognizing the significant impact that it has to children and families in our state and throughout the nation. So early intervention Part C programming, providing services for children and families in our state, does several things. I skipped too far ahead there. Wait, where are we going? I need to go back. Back is front. I don't know what's happening here. I think we're out of sequence here, I'm not sure. Anyway, let me get back to where I was. So there are 3 primary reasons why. Callie, can you get it back there? Thank you. There are 3 primary reasons why early intervention is so important. One is to enhance the child's overall development. So when we have a child who is demonstrating a delay or a disability, then being a part of early intervention is critical because it helps to make sure that we have a surveillance component in regard to how the child is progressing. Also is to provide support and assistance to the family, and also to maximize the child and family's functioning and their benefit to society as a whole. Yeah, better at it than I am, apparently. So the earlier that we address the concerns in regard to development, the easier it is to effectively provide services for those children and families who need those services. In Mississippi today, or actually from a 2021 report, we had 3,360 children who are eligible for referral to early intervention services in Mississippi. So this was that these children were either identified through a pediatric visit, through maybe their child care provider, or maybe even the parent recognized that there was not a typical trajectory of delay, and so they were referred. And out of that number, there were 1,621 of those children served in FY21. Mississippi typically serves around 1.5 to 2.1% of the overall population of infants and toddlers. That is considerably lower, as we will note in some coming hearings, than the rest of our nation as well too. What you see here is a 5-year trajectory of the children that were served in Part C programming. And you can see that there definitely was a dip in the 2021 year, certainly because of the pandemic. The pandemic actually rendered a lot of issues when it came to early intervention throughout our nation. I have the privilege of serving on several committees that are national committees. And so I work with early intervention providers throughout the whole state. And this is not anything inherent just to Mississippi, that our numbers dipped in 20 and 21, but we see this throughout the whole nation. However, what we know is that our numbers are trending back up. So children are being identified more and more, as they should be, for eligibility, to see if they are eligible for services, and then for service provision as well too. What we do know is that even though we have a potential range of about 1.5 to 2.1 children that we serve in our Part C program, we are still much lower than the national average. And we're much lower than many of our southeastern states as well too. So hopefully in the coming opportunities for your sessions throughout the next couple of months, we can deliver more information about specifics as it regards to potentially why we're not serving as many children as our neighbors, and then how we can actually increase those services. But it's important to recognize that we do have the highest rate of poverty in our state. Poverty, as my colleagues have just noted, lead to lots of very systemic issues, and the trajectory of development is definitely one of those issues. So when we think about what early intervention leads to, we know that it leads to benefits for families, communities, and the state as a whole. When we look at our data suggests that early intervention services are based on evidence-based practice. And so as I prepare students in pre-service programs, one of the things that's very important to our program is to send our students out with as much evidence and as much data to base their practice on as we possibly can generate for them, so that they become those providers who really understand the needs of the community. So we have programs, we have personnel that go out through all areas in Mississippi to provide services, but we also need more of those. The intervention strategies that our Part C providers provide to children and families are built into what we call daily routines, which is a really important concept. The IDEA federal law stipulates that these services need to be rendered in natural environments. There's so many important reasons as to why, because children are more comfortable in their natural environment. They're more comfortable at their home, they're more comfortable at their childcare facility, or somewhere where they spend a large majority of their time. And additionally, those individuals who care for them in those natural environments need to be a part of this programming process, so that the things that the professionals do for them are done on a daily basis, even when the professional's not available to them. So our early intervention practices increase the child's rate of growth in key developmental areas. We also use it to multiply the opportunities for the impact of intervention, like I just noted, during daily routines, and to increase the return on every dollar spent. So we know that if we can serve children early, if we are able to track their developmental trajectory early, if we're able to provide them with the kind of intervention services that are needed to help to eliminate the gap and or the delay, that our monies up front go a lot further than their monies will be on the back end. Some of those outcomes, and this is a really important one that I want to note for you all. Some of the outcomes our data suggests from a very highly rated national study, the NEAL study for early intervention, is that almost 46% of children who go through early intervention services do not need to go into early childhood special education, which is Part B services. That's significant, but let me tell you about the most significant part there. Well, I'll get to the most significant part in just a second, but 36% of that 46% identified at the end of early intervention no disability. So they didn't qualify. There wasn't a delay or a disability noted for that 36%, but here's the real lagniappe. 10% of that 46% had a disability, but did not qualify because their disability was so minimized that they could go into an inclusive setting. So that's exactly where we want our children to be. We want our children, our young children with disabilities, to be included with their typically developing peers. We want them to have opportunities just like they're typically developing peers. And we want them to be in those educational placements that are most appropriate for their needs and educational opportunities. So that 10% is the percent that, all 46%, but specifically that 10% is the percent that we really are very proud of. As we think about the importance of what our Part C program does here in our state, this gives you a little bit of indication of where we are in regard to our southeastern states around us. Outside of Arkansas, we really won't talk about Arkansas, right? But outside of Arkansas, Mississippi serves fewer children in our Part C program than any of our neighboring states. There's several reasons for that, and I hope when we have continued hearings in October with a special emphasis on early intervention, we can bring more data to share with you there. And one of the main issues that we have in regard to Part C is what I would suggest is our brain drain. So again, I facilitate the only graduate program in Mississippi that prepares individuals to work in our Part C program here. However, not all of my students actually are from Mississippi. They're from other states as well too, because it's a fully online program. So I have students from Louisiana and Tennessee and Alabama, all the way up to Connecticut and New Hampshire. So not all of those that we prepare are going to stay here in Mississippi, but there are other opportunities to prepare students to be service providers in our state. One of the things that I feel like is a significant obstacle for Mississippi in regard to our workforce development in Part C is that our neighboring states, both Alabama and Tennessee, hire our undergraduates for their Part C program. However, our Part C program does not identify them as being eligible. So that's a really significant issue to address in our hiring criteria. We need to address our workforce development. We recognize that our institutions of higher education are sending out very highly qualified professionals who have an extensive background in early childhood, child development, and family systems. And we need to be using those brains to serve children and families in our state. In the coming hearing meetings, we hope to be able to deliver more information for you in regard to the overall system of early intervention and provide you with the data that will help you make the best decisions for our state moving forward. Thank you.
Good morning. Thank y'all for sticking with us and having us here today. My name's Callie Poole. I'm from the Social Science Research Center with Drs. Brenner and Hannah. Before coming to the Social Science Research Center, I worked for 14 years in the early childhood and youth education and mental health fields, and 6 of those years were as a child care provider. So I'm really excited to talk to y'all today about some ways that access to affordable, quality child care really makes a difference. So let's start by looking at how it can make an impact at the individual level. We know that in the earliest years inside of our baby's brains, they are making 1 million neural connections per second. So how do we foster those connections and make sure that those brains are built? It is through warm, responsive, consistent relationships with adults. So when our families are participating in the workforce, having that nurturing childcare provider can make a huge difference in their lives. And some of the outcomes that we see are increased kindergarten readiness. We see more rapid cognitive brain development, so language and literacy outcomes on those 3rd and 4th grade assessments. We see these outcomes going all the way into high school as well as adulthood. And not only does access to childcare benefit our little ones, but it benefits parents, as Heather talked about. You can see that top line there is the workforce. Actually, that is children who, no. It is young children whose parents are not participating in the labor force. So they're not in school, they're not working. And so you see that our rate is higher than that of the national rate. So just imagine what our state's workforce could look like if there were abundant, affordable childcare options, providing nurturing environments to our little ones during their parents' work hours. And on the next slide, we're going to see a similar trend when we look at unstable work rates. So again, Mississippi has that higher rate. What can Mississippi do to address some of the issues that cause workforce instability for families? Well, we see here on this slide that 41% of Mississippi's parents who were enrolled in school or a training program actually postponed that participation due to childcare issues. And this ends up costing our state money. So when we look at what employees lost based on, or what employers lost based on their employees' turnover or absences due to childcare issues, plus the tax revenue loss, it adds up to an estimated $673 million for our economy every year. So this really affects us at a statewide level. And what are some of the barriers that families face to accessing childcare? Why are they missing work? You know, why don't they just drop their kids off and go to work? Well, childcare in Mississippi is not affordable. If you look at this map, even in the areas where childcare costs the least, so that's the lightest counties that you see here, it's still 14% of household income in those counties. Now, the U.S. Department of Health and Human Services advises that childcare should not cost more than 7% of a household's budget to be affordable. So when we think about all the different expenses that families have, we see how these costs can really add up and not be affordable for families. Okay, let's go to the next slide. So on this slide, the first statistic is a parent raising 2 children by themselves without financial support from another adult. So this is a woman who is earning the median income. She has 2 children. That childcare cost is almost 40% of her income. Now imagine if this mom was making minimum wage, what that rate would be, what that percentage of her income would be. And we do have the Child Care Payment Program, the CCPP, that is in place to help make childcare more affordable for parents who have the fewest resources to pay for childcare. And these vouchers cover just over half of what it costs to care for children. So that's just over half of what the centers are charging the families. So when you look at that percentage, if a mom is paying almost 40% of her income, she has the voucher, she's still going to end up paying about 18% of her income for childcare for those 2 kids, which is more than twice of what the Department of Health and Human Services said was affordable for families. So while we do need to ensure that our working parents with the greatest need can access that child care payment program, we also just need to look at measures to reduce the percentage that all Mississippians spend on childcare. And so let's look at who is getting these childcare vouchers. So in 2020, in the Mississippi Department of Human Services report, they said that they are serving 31,605 children. And in 2019, there was a national report that estimated that 166,820 children were eligible in Mississippi for the program. That's from the Center for Law and Social Policy. So either many families who qualified didn't apply, or maybe they did apply and they weren't accepted. So let's take a look at what could be happening there. Why aren't all families who can afford childcare getting vouchers? One of the first reasons might be that in order to receive the vouchers, in order to qualify, you have to be working or attending school a certain number of hours. So as we learned, and as we know from our life experience, that can be really difficult when you are needing childcare in order to go to work or school. And then not all families can meet the child support requirements. Let's say you have parents who have split up, one parent is raising that child, they need to be able to provide documentation that they've attempted to collect child support from the other parent for their application. And that can be really hard to do. On the next slide, we have a couple more barriers. The application can also be time consuming and the notification process is lengthy. So let's say that I go and spend, hours uploading my information, I make an error or I forget a document. My application will actually expire in 30 days. So the Department of Human Services has to review it, has to get back to me and notify me of what I need to do to correct my application. I need to sit down and get that corrected. If I don't do that within 30 days, the whole process starts over. So technical assistance for families to complete the application could help reduce some of these barriers. And then in addition to the affordability issue, there's also a capacity issue. So we can see from this map that childcare is not widely available in all areas of our state. And in 2017 to 2019, only 54% of our 3 and 4-year-olds were enrolled in a licensed childcare program. And we did a market rate survey of childcare directors in 2021. And 59% of those center directors told us that they had a waiting list. So there are families trying to get their children into childcare centers that are turning families away. So on the next slide, we'll see some of the reasons that some of these childcare workers might not be able to accept children. These results are from some focus groups that the Mississippi Early Learning Alliance recently conducted in conjunction with the State Early Childhood Advisory Council. And so directors were telling them that they can't accept as many kids as the health department says that they're licensed for because they can't staff all of their classrooms, so they don't have that staff-child ratio. And also staff that they're hiring may not have a background in early childhood development, and they may not be committed to staying in the field. So why might they not be committed to staying in the field? Well, childcare providers do not make a living wage in Mississippi. When we look at this map, we can see that childcare providers in Mississippi make one of the lowest annual mean wages. And the annual wage average for childcare providers in Mississippi is about $19,500 a year. So cashiers and dishwashers have about $1,000 to $1,500 more per year. And also we see that a fourth of our early educators in Mississippi live in poverty, which is more than twice the rate for Mississippi workers in general. We know how valuable childcare providers are to children's outcomes and parent workforce participation. So if we can grow the childcare workforce, we can grow the Mississippi workforce as a whole. Next slide. So we have about 0.4% of our state workforce who participate in childcare. And when we see that annual wage broken down hourly, it's $9.37 an hour, the mean wage of childcare providers in our state. We see that's much less than the living wage for one adult with no children, which is $15.66. So imagine if you're a childcare provider who has children of your own, maybe you're raising the children on your own, what those expenses would be. So when we think about how we can bolster the childcare workforce, it's really important to note that childcare providers cannot always afford to pay staff a living wage, especially those who serve a high number of families participating in that childcare payment program. On the market rate survey that we conducted in 2021, directors told us that those childcare payment program voucher reimbursements don't always get to them in a timely manner from DHS. They don't always know what day of the month it's coming on. So imagine doing your payroll and your monthly expenses, not really, having that reliable income. There's also families who can't afford to pay the difference between the voucher amount and the childcare rate. So providers who live in areas with a high population of low-income families might really have to think about, do we turn that child away and lose that voucher payment, or just only receive the amount that the voucher covers? So really, when we see those waiting lists in some parts of the state, and then in others we hear that providers are struggling with enrollment, it just really depends on what families in each area can afford to pay for childcare. So additional supports are needed. We got to increase our staff wages. We have to increase the childcare payment program participation. We have to incentivize growth in the childcare workforce to bolster our state's workforce and economy. And now Dr. Brenner is going to close us out.
It's a lot of data. It's a lot of upsetting data. It's a lot of worrisome data. We thank you for sticking with us for the last hour. We know there are a lot of bright spots in the state. We've been investing in early learning collaboratives. We have COVID relief funding that's making a real difference. Our universities and colleges are designing new programs to help prepare people to meet the needs of children and families. Where at the SSRC, we're partnering with the Mississippi Department of Health to provide better training for childcare providers to help address things like ACEs, where we've increased the number of developmental and health screenings for young children in this state, and so we can figure out what their needs are. So we have a lot of bright spots, but we also, next slide, know that there's a lot more that we can do. And these issues that we've been talking about, they're super intertwined and they can be very overwhelming. But what we know is if you make a difference in one area, it will have an impact in all of the other areas. So decisions that you might make to make healthcare more available or to make childcare more available, those can help untangle the knots in some of the other areas that we have been talking about. So even if it seems overwhelming, there's a lot we can do that will make a big difference. And will you keep going? And we know that investing in children and families can really make a big difference. And so there are some estimates that suggest that spending $1 on high quality early learning childhood programs can yield $4 to $9 in savings over the long run in outcomes for health and education and social well-being and participation in the workforce. Next. And an economist, James Heckman, has estimated that really making the investment, the younger you make it, if you're going to invest in people, the sooner you do it, the greater the impact over their lives. And so returns on $1 invested really make a difference when kids are very young, when families are getting started. It doesn't mean we should stop investing in things like post-secondary education, K-12 education and services for young adults and adults, but that early investment really does pay off. As we were collecting all of these data to share with you, it underscores for us, some of these data were a little tricky to find. And so our state data systems and how we're measuring, how we're doing as a state for women and children and families can really make a big difference. And we need to be using data to evaluate whether our programs are working. And then our last two slides. This is just how to get a hold of us if you have questions afterwards or you want to learn more about any of the sources or the information or the programs that we have shared with you. And finally, the very last slide is a QR code. Across this presentation, we've been showing our own data from our work on programs with state and federal funding and in extension. We've also shared data from national and state reports and national and state agencies and through our partnership with the Children's Foundation and the Kids Count Data Center. But what we have shared with you over the last hour is really just the tip of the iceberg, and there's a lot more information. And this QR code will take you to a website with links to these reports that we've been citing. So we thank you very much for your time. Senator Boyd, I'll turn it back over to you.
First of all, I want to thank y'all. This is hours and hours of compilation. And I thank y'all so much. We've met with y'all a number of hours as y'all have been preparing this. So I want to thank y'all very much for the time that it took to do this and really kind of help us get the data points and the metrics that we'd like to kind of see moved and changed. But at this time, I want to turn it over to questions from our committee. Sure. Do you have any questions?
Of course. Thank you. First, thank you, Chairwoman Boyd, for all the work that you've done. A little bit of a comment here. A lot of times us Republicans are portrayed as not doing a lot for the social part of policy. And I look forward to the media kind of putting out there that the Republicans led by the Senate are looking at this, a super majority, lo and behold, we're actually doing it. So I have two questions, General. The issues that were brought up about childcare workers, and y'all mentioned the Early Learning Collaborative, and I just have to bring it up, but that law was literally designed or has written into it to address the reasons that you're talking about, childcare workers, because it's expensive, because there was a turnover. It's also written that private childcare centers can get the funding through the Early Learning Collaborative, which from what I know, there's no other program. But what I've seen is that private childcare centers aren't joining up, so to speak. Have y'all looked at why that is and what can be done? Because the vehicle exists and the legislature, if I may say so, has put money into the collaboratives. And so the vehicle is there to address those concerns that you're talking about. So why isn't that happening?
Yeah, go ahead.
I'll take a stab at this, and I'm pretty sure I'm not going to answer it as well as many others could, but For one thing, of course, the childcare collaboratives are very limited in the numbers of children that they're able to serve. So a lot of private childcare providers would not have an opportunity to.
They've increased.
They have,
dramatically,
and
since
that's
its
wonderful.
inception.
Yes, and that is wonderful. I do know that it can be costly for childcare providers to meet the types of regulations that are required through the collaboratives. And so that may be a little bit of a
That's why,
barrier.
I'm sorry, but that's why it was written, the matching part of it was written very broadly
Yeah.
to allow them to do it. So for example, that people can donate to the collaboratives and then that can go to pay for childcare centers. I mean, for the childcare teachers. And I
Right,
know
but
I'm
it's still
interrupting you, and I'm
dependent on
sorry.
the community being able to
sorry.
support that.
What's that?
I said, but the donations would still be dependent on the community being able to support that. Yeah, come on, Julie. You can do better.
So fair question. Senator Wiggins, is that correct?
Yes.
Yeah, thought so. Fair question. Here's the thing. So the collaborative is just what it is. It has to be a collaborative. So that means the childcare provider has to have a collaborative LEA to participate with. Not every local education agency in the state has actually applied for application there.
Correct.
That is a significant component. The childcare facility can't go out there independently and apply for a collaborative. So we need more of our lead educational agencies to step up and partner with those childcare providers to actually make that collaborative classroom work in many more different areas of our state as well too. Dr. Hannah was absolutely right. It is pretty costly. We know that the overall quality of community-based early care and education is quite low for our state in regard to looking at the high tier metrics of like NACE accreditation and those kinds of things. So that's one issue. But if you have that collaboration with your LEA, then you can raise that standard as well too. So we really just need to get, more of our public school systems, county school systems on board with collaborating with our community-based early care and education providers.
Yeah, and the qualities, we've been rated #1 in the country in quality.
Significant outcome.
High quality is what leads to the better outcomes.
So why don't we make it universal?
Talk to my colleagues in the legislature. Every person I've ever talked to in y'all's area has said that. So it's convincing my colleagues to do that. My next question is, and is going to slide 11. That is the one that says % population below poverty. Is that easy to pull that up?
Turns out it was a lot of slides.
It's at the very, very start, number
There we
11.
go. And I have it here in front of me.
Okay, it's the,
Sure. They were in order once. There we go. I have it right here. 10, 11. Yeah, that one.
okay, where it says % population below poverty.
Yep.
And
It's,
many of you know, so the darker colors
Mhm.
is very high and high. And I'm generalizing here, but what that shows is that's the Delta area.
Yep.
Okay, and many know that I'm from the coastal part of the state, which are very light. So my question is, there you go. And North Mississippi's, relatively speaking, is light. So what's going on in my part of the state? And what do that's not going on in the Delta or vice versa? When that is showing the % of population below poverty, I know there's no numbers here, but from what I'm looking there is certainly in the Delta, that area, the dark areas, there's more people in poverty than there are in my part of the state. And so what's going on and how do we address that?
think there's a lot going on, and that's part of what we were alluding to a little bit when we were talking about the disinvestment in communities over time and the toll that it can take on the resources, and Lori's metaphor about the soil and over time and so forth. So one thing is our funding formulas that we have for schools. This is getting out of the early childhood realm, but we do depend so much on local funding to compensate. Obviously, schools in your part of the state are going to have a lot more local funding that they can contribute to the local school. And so you wind up, even though it's an equal formula where schools get the same amount, you wind up in effect where you have schools that don't have as many resources.
But that didn't happen by accident that I know of. I mean, decisions were made, were they not?
You tell me.
I mean, to your point, you're saying if we're talking about school and that, a mill in Jackson County is worth more than a mill in whatever the county in Tishomingo County or something.
Sure.
But there's things that have driven that to be the case, and yet we fund schools and those programs off of property taxes. Okay. And we could go back into the history and all that, but I don't know that that's the only thing. I guess my question is, what is going on in the Delta that's not going on in the coastal regions and I guess DeSoto County or vice versa, that puts more people in poverty in the Delta area than in those areas?
Yeah, so one thing that let's just take it down to the early childhood level. When a child grows up with nice museums, with a neighborhood, like a rich local library, incredible schools, when you have those resources available to you, then obviously your brain is more, what's the brain architecture has more opportunities to develop neural pathways.
Your neurons are firing.
Your neurons are firing. And so you are able to have a trajectory where you do excel in school and you have perhaps better opportunities for employment, and then you can give back to the community. Furthermore, there's access to high-paying jobs, and we know that those are not always present in the Delta area. Now, all this being said, we have a Delta expert coming behind us to speak. That is not us. And you can ask her these questions and she could probably do a better job of answering.
Thank you.
Senator McMahon, I think you had a question.
Thank you, Senator Boyd. I've got several questions. So appreciate all of you doctors taking time to be here with us today and share this information. I've learned some things and I'm trying to wrap my head around some others. My question is for Dr. Poole. And on page 19, slide 57, it stated that childcare in Mississippi is not affordable.
Hi, I'm not a doctor, but I can try to answer your question.
Did you stay at a Holiday Inn recently? You can answer this
No.
question. You'll be qualified. Okay, you're an associate professor?
I'm a project manager.
Okay, so you said that childcare in Mississippi is not affordable. So what's the right figure? So
Well, when we look at, it really depends on what people's incomes are, right? Because that's why we're seeing those disparities with some childcare centers that have these long waiting lists of families who can't afford or are waiting versus other centers who are really struggling to find parents who can afford childcare to enroll. So I think that's why the U.S. Department of Health and Human Services does a percentage rather than like just a straight figure. So it should be 7%. It's kind of like that housing cost, you know, that people say it should not be more than 30%. So the figure for childcare would be 7% of a household's budget.
So if child, you said in 57 that childcare is not affordable in Mississippi. And then on slide 64, you said childcare providers do not make a living wage in Mississippi. So if we increase the cost of the wages, then what do we do about, you say it's already not affordable? What's the outcome to that?
Right, because the childcare centers are not able to necessarily charge more because of how it affects families. So that's why that universal comment was good.
you
The public support would
Do
be.
you support universal childcare vouchers for all families?
I don't know if I'm allowed to say what I personally support as a university employee, but I guess the data would point to just public support being beneficial for families and childcare providers, and then in turn, our economy and workforce.
What should that universal voucher, like, let's say the state of Mississippi had a policy that we were going to try to come up with. What do you think that amount should be monthly?
We did a market rate survey in 2021 with the Department of Human Services, and that's where we interviewed childcare directors about what their costs are. So that, I think, that document would probably be the most helpful when making those decisions, or at least the one that I know of.
And so you don't have a figure in mind? Anyone? You don't have a figure in mind?
We just collect, we have such limitations as our, as university employees, but we collect the data, and then the Department of Human Services kind of.
Well, I'm trying to rectify my mind. Your team says that healthcare is unaffordable already. And then you say the wages are too low. Well, if the private sector raises the wages, then it's going to go up even higher. So I'm trying to understand if there's going to be, and I think you skirted the question. I think you do support, your group supports a universal voucher. I'm trying to figure out what that figure is.
Senator, I will tell you, I just asked them to present the data today, not really to state their position. We'll have DHS. We'll also have workforce development in October when we just look at childcare data. So so to be very specific, my charge to them was just to present the data.
Sure.
So I'm gonna.
I'm just,
And I
and I'm trying
appreciate
to
y'all
learn.
staying in that box.
Yeah,
So
and I'm
thank
trying to learn. I mean, they have all the data. So I was asking if we're going to have a policy, they're here testifying as professionals and policy advisors. So I was trying to come up with that. So
And I think
I'll
what we
move.
do know is that the current voucher, the amount of the current voucher covers about half the cost of what a center provide, like what it costs to provide high quality childcare. So, so either centers have to decrease the quality of their care in order to, if they just accept the voucher. So if I'm a family, that's all I can afford because I'm still a student or I'm looking for work. The center has to reduce their services, or in order to provide high quality care, the family makes up the other half of that difference. And so that amount that we are paying right now in our voucher system is about half the cost of what high quality care really looks like.
And then my other question was on slide 39, there are 1,384 children currently awaiting adoption in Mississippi. Do y'all know do you have the average cost of what it costs to adopt a child in the foster care program in Mississippi? Okay. And that was, I think that was all my questions, Senator Boyd.
Okay, Senator Turner Ford.
Thank you, Madam Chair, and I think you may have answered my question. The purpose of the presentations today was just to present the data. Will there be any perhaps recommendations that will be presented to us at some point during the process?
Yes, ma'am. We will have the different agencies and some different people make some recommendations to us, but then ultimately we will make recommendations from the committee. So, but we will have a number of experts that will be presenting in these particular areas from our state agencies and outside state government that'll kind of be looking at these particular issues and giving us what they've seen as best policies in other states, what they've seen and promising practices. So I think we'll kind of, as we go through, we'll kind of
hear more of those things. Thank you. Senator Hickman.
Thank you, Senator Boyd. And thank you guys for presenting this data and doing the research that you've done. I want to start by saying thank you. I'm excited as a minority member of this committee to be involved in it. And just piggybacking off what Senator Wiggins said, I hope that we'll do more than just look into this. I hope that we will be able to make some good changes for the state through this committee. I had a couple of questions. My first question starts around slide number 43. And I can't remember who it was, but we were talking about Part C of the IDEA. And I guess my question is kind of comprehensive. I think you started getting into what are the issues and why are we not serving more children? I think it's an amazing program. You presented the results that once children are served through Part C, the outcomes are very great, and a lot of them don't even have to have Part B. I think you started talking about workforce. We don't have the people to provide the services. It's one of the reasons why the number of individuals that we serve is so low. What are other issues, or what has your research shown that are other issues as to why we're serving such a low percentage of our population?
Great question, Senator. So a couple of things. One is definitely workforce in regard to who's eligible to be a Part C provider in our state, primarily from the perspective of special instructors. So as Senator Boyd noted, there will be some additional hearings that will really drill down and provide a lot more data and specifics for you on the Part C program as well as early childhood. But to your point today, the way our system is currently designed, unlike some of our neighboring states, our design is to contract with the majority of the professionals who are providing services in our state. We have a group of service coordinators who are actually state employees that do the service coordination for families and work with what we call the related health professionals and the service providers. In other states, the system is a little bit differently designed, giving more employees a full-time work placement. So I'll just give you an example of my students in our early intervention program. When they graduate, if they wanted to come and serve children in Mississippi, children and families in Mississippi in Part C, they would do so as a contract worker. That means there's no benefits attached to that. The salary is fairly nice, but when you're a young professional trying to make it on your own, having those benefits can be really essential for you to get your footing started in your career. So that's one of the issues, is that we have a very high percentage of our professionals as contract employees as opposed to employees of an agency who is providing these services. The other issue is, as I noted in my initial comments about Part C, we have neighboring states who actually employ early care and education professionals, child development professionals. So Mississippi State University, the university where I currently have a position, University of Southern Mississippi, Alcorn State University, Delta State University, all have programs that have licensed pre-service programs for child development professionals who are licensed specifically to work with children birth to 5 and their families. Those students currently in our state are not eligible for employment as a service, as a special instructor in Mississippi. We have a significant need for special instructors in Mississippi, and we do not have the eligibility for that workforce right now.
But in our neighboring states, they do have that ability. And so what I'm hearing is not all of it, but a majority of our issues are basically capacity due to workforce. It's the reason why we're not serving.
Well, that pipeline to workforce certainly needs to be addressed.
I had another question. I think it was another speaker, maybe you, that is also able to answer my next question. And this is around slide 62. And it talks about how childcare is not widely available in a lot of areas in our state. And as you can see, there are what I would say maybe even childcare deserts. There seem to be some places that have very small percentage of where you can get good childcare. I guess my question is, does the data lend to the fact that if we were able, or if we did provide access to 3 and 4-year-old pre-K, would that alleviate some of this problem as it relates to childcare? Because I think the statistic there says that only 54% of 3 and 4-year-olds are enrolled in licensed childcare. And so those children are either at home and their parents are not able to work, but wherever they are, it's very likely that they're not even getting any educational training at that point. So does the data lend to the fact that there would be some ROI if there was access to 3 and 4-year-old pre-K across the state?
Take over my colleague's point. So yeah, to your question, Senator, absolutely. We recognize that more access to higher quality early care and education is really important for children in Mississippi. You're absolutely right. There are pockets throughout our state that are considered childcare deserts where there are very limited opportunities for families to find childcare in general, but specifically high quality childcare. And so if we did have more supported childcare classrooms where access was available to all children in those communities, then yes, those children could be receiving higher quality services.
And one final question, if I can, Senator Boyd. I think this lends to what you guys were here for. I didn't hear, but does the data, when we're talking about the child care payment program, I know they said there's a gap in people who are not receiving that. Does the data show that the implementation of the child support cooperation policy, that skew the data any, or make it more difficult for families to receive child care assistance or child care vouchers?
So yes, the child support requirement currently for the child care payment program, there is a lot of discussion and actually a resolution from the CCAC Advisory Board to repeal that for the CCPP programming. We recognize, based on many reports from both providers and for families, that is a significant obstacle specifically for single parent households.
Yeah, because I mean, and I don't know, like you guys didn't present the data, but I have data that says, you know, the numbers are astronomical for the people who no longer qualified or wasn't able to get CCPP after this policy went in the state. And so you're saying that your group's recommendation is to repeal that. Is that correct?
So there has been a request from the state Early Childhood Advisory Board. Yes, sir.
Thank you so much. And thank you, Senator Boyd.
Thank you. Senator Buckle.
Thank you, Madam Chairman. I'd like to go back to slide 11. I don't know who wants to answer this, but Senator Wiggins hit on this. And just to make a comment, Senator Wiggins, I think part of the reason that the Delta looks the way it does is the lack of economic development that's down there. But more specifically to the slide.
I'm just trying, I'm trying to get to understand why. I mean, seeing the numbers, yeah.
Right. But have you ladies done any study on the traditional, and probably hesitate to use the word traditional, but having a male in the family from the Delta versus some of these other areas, such as the coast or North Mississippi, the percentage of families?
Families, but I don't have that at the tip of my fingers, but we can certainly look for it and send it to you.
All right, thank you. On slide, your healthcare slides, 26 and 27. We seem to have a number of barriers that we create in our workforce development programs, whether it be a simple license for a cosmetologist or even a physician. We've been trying for some time to try to move past a collaborative agreement that nurse practitioners have with physicians. if we were successful in doing that, I would imagine there'd be more nurse practitioners who, in fact, I know of some that train but then leave the state because they can't practice the way they've been taught. If we were to remove those barriers, you think have much better access for these folks?
I think probably that's a really good question for some of the people who are waiting for their time at slot at 10:30 to answer. So I would really like to let them, the experts really speak to that.
Okay, I'll let you pass. On slide 51, and this sort of goes to what Senator Hickman was talking about.
Sure.
Do all we need to do is pass some legislation that removes this barrier that prevents these students from being hired here? Or is there more to it?
So yes, a little bit more to it. There's some reimbursement issues that are connected to that as well too. So there are some policies from Medicaid as well too that have to be addressed. I know I've had some extensive conversations with Senator Boyd in regard to what that looks like currently in our state and what it looks like in other states as well too. So it's a little bit of a multi-tiered issue, but definitely addressing eligibility criteria is important.
But if other states are doing it, they've got Medicaid as well. So it should be something we should be able to
There's a lot of good
accomplish.
programs out there, Senator, that are working well. Yes.
And then lastly, the question on the vouchers, the application process, are other states doing it differently? Is that some information we can get then so we can compare our process with those?
Look,
All right. All right, thank you.
and we'll be discussing that on the 25th and 26th of October. Thank y'all so much. I cannot thank you enough. We really appreciate you providing this data. And I've had texts from a number of you. I will provide the sheet that has the QR code so that you all may access this data. So if y'all will all take a 5-minute stand-up break, and we will have our next speakers that will come up before us. Thank y'all. If everybody will make their way back to their seats, please.
Good morning.
Senators, if you will make your way back to your seats so we can start, please. I'm gonna go ahead and start. Dr. Woodward, we're going to go ahead and start. I'm going to keep us on, try to keep us on track. So
Admirable.
today we have with us Dr. Lou-Ann Woodward, who's the Vice Chancellor of Health Affairs at the University of Mississippi Medical Center. And we look forward to your presentation. Thank you.
Thank you. Are you ready for me to start? Okay, very good. First, I'd like to introduce the team that I have here with me on this front row. They are content experts, in some cases, much more than I am, and here to assist with questions and other information as needed. Dr. Alan Jones is here in the green scrubs. He is the Associate Vice Chancellor for Clinical Affairs. Seated next to him is Dr. Pham, who is the Chief of our Newborn Medicine and one of our key physicians, lead physicians in our neonatal ICU, frequently referred to as the NICU, and you will hear us mention that unit a good bit during this. Next to her is Dr. Jermaine Gray, who is on faculty in our OBGYN department, and then Dr. Charlene Collier, who is also on faculty in our OBGYN department, and I'm very thankful that they are here with me today. So thank you to the committee and the group for having us and giving us the opportunity to weigh in on these issues. As the only academic medical center in the state, the only children's hospital, the only level 4 NICU, and the facility that in many cases takes care of the sickest patients in the state of Mississippi, this particular issue and these patients, this patient population, maternal fetal population, the women, the children, the families, this is very important to us. And you know, the punchline of what I'm going to say really is we feel our purpose and our mission and our vision is to do all the things that we can do to improve the health in this state. If you've heard me say many things or read many of the things I put out, a healthier Mississippi is kind of always the tagline. And that starts with the children. I wouldn't really look around this room and say it's too late for us because there are some people in here who are pretty young, but in many ways, our path is charted, you know? So really changing the health of the people of our state depends on what we do for children. And in so many cases, what we do for children really starts with the health of the mother. It's critically important. So this is another one of the examples or another one of the instances where as a state, we're in the wrong place on a lot of the list. We've got the highest fetal mortality rate in the country as a state, and that means stillbirths, the highest number of stillbirths. We've got the highest infant mortality rate, and that is for children that are born and then under a year of age. Highest preterm rate in the country, and then very high in the top decile of maternal mortality as well. And there are a lot of these things are interconnected. There are a lot of reasons for this. And in particular, when you look at the infant mortality rate and you think about what causes that, why is that? What are the reasons for that? A lot of it has to do with the health of the mother and whether or not the babies are born too early and too small, preterm and very small, low birth weight babies. And when you think about low birth weight babies, some of the children that we have in the NICU are 2,000 grams, 1,500 grams. And so just a visual on what does that mean as we think about normal baby size, 1,500 grams is a little over 3 pounds. So, you think about, and this kind of sounds terrible in a way, but it's something that I think we can all visualize. You think about a small package of hamburger meat that you are going to prepare hamburgers for 3 or 4 people. And that's in that weight range. So we are talking about babies that are really, really very little. When you're looking at the maternal mortality, 86% of the maternal deaths in Mississippi occur postpartum. That means after the baby has been born. And again, why? Because many times the mother has pre-existing medical problems, whether it's diabetes, hypertension. Another big risk factor is back-to-back pregnancies and back-to-back deliveries and a lack of health care in between. So these are all challenges for us. I know from the team that just presented, our colleagues at Mississippi State, in many ways, they talked about the components of this triangle and how really, when you think about a person growing and thriving and, growing up to be all that they can be, there's a triangle that is very important. And the sides of it are very much connected one to the other. That is health, it's education, and it's financial, having some stability in your finances and your socioeconomic position. And if any one of these pieces is disrupted, then it really affects the others and affects the person's overall ability to grow up and to thrive and to be all the things that we all want to be and we want our children to be. The one that we clearly focus on the most is health, but it is important, and we think about this a lot, how much it is connected to these other two pieces. Nothing happens in isolation. So when you look at the maternal infant health care at the medical center, and a lot of these numbers that I'm going to share with you are from the medical center, not necessarily statewide. One of the things to realize is that there are many women that, particularly during the ages of, late teens up into 50 or so, their primary care really happens through their OBGYN. So for many women, a good 20, 30 years of their life, the place where they have their blood pressure checked, have their blood count checked, all the things, primary care happens a lot with the OBGYN and the relationship that the OBGYN has with the mothers. So at the medical center, we've got a department of OBGYN. We've got the only maternal fetal medicine clinic in the state. And that is a clinic that brings together, it's a program that brings together the specialists and the subspecialists that are needed to care for a lot of patients. So it's the OBGYN specialists, the high-risk doctors, the pediatric specialists, very often special pediatric surgeons, and others that come together to treat things that may be diagnosed even before the baby's born. Heart defects, some sort of genetic defects. So we've got the only one of these in the state that brings these specialists together. We have the only dedicated urgent care emergency space for OBGYN in Mississippi. And in our department, we've got a wide range of all the specialists that are needed for all the aspects of OBGYN care. And in our Department of Pediatrics, we have the only level 4 NICU. Again, that's neonatal intensive care unit, and that division of newborn medicine, that group of physicians and others that take care of patients in this NICU. It's a large group. It's a very important part of our Department of Pediatrics. In November of 2020, when we opened the Sanderson Tower, the new Sanderson Tower, that included 88 NICU beds. That was in comparison to the NICU that we had before, which was an open ward, sort of an open unit, just really a large open room. Now we have these 88 NICU rooms that allow for the patient and the patient's family to be in a private space. It helps with the ability of the family to be at the bedside, to learn how to take care of the patient. It helps with infection rate. It helps with noise levels and all sorts of things that are really important. So that has been a fantastic addition to the services that we offer. In the PICU, the Pediatric Intensive Care Unit, we've got about 30 beds. So you put those two together, we've got around 120 intensive care unit beds for children. And you can think about hospitals in this state, all across the state of Mississippi. There are some whole hospitals that don't have 120 beds. So it is really impressive and something that we're very proud of, and we are honored to take care of some of the sickest and most at-risk children in the state of Mississippi. And it's not just the physicians and the nurses and the nurse practitioners, but we also have on that team social workers, therapists of a whole variety of types. It is a multidisciplinary care team all the way around. When you look at births, and again, this is just at UMMC, we took a 5-year look back to be able to provide you some information. And over the last 5 years, for this year, for 2022, these are calendar years, so we really just have about half a year's worth of data. But for the last 5 years, we've had 14,495 births at the medical center. And you can see here the breakdown between Medicaid and other payer sources. And so about 2/3 of our births at the medical center fall into Medicaid payer source. Now, this does not include babies that were born somewhere else and transferred to us. And it's not talking about mothers that may have delivered somewhere else and then are transferred to us. So this particular number are the moms and the babies that are at the medical center when the birth occurs. And this kind of gives you that, that picture of what we see. We have at UMMC the highest number of births for Medicaid mothers and babies in the state. This breaks it down by year. And again, this is just our data. I know you heard from the team before us with data, and then people will follow us with other statewide data, but this is the data at the medical center. Just breaking it down by year. One of the things to note in both the total and then the specific Medicaid payer category in 2020, the first year of the pandemic, we saw all across the state a lower number of babies being born that year, rebounded a little bit the next year, and then you can see we're on track probably to tick up a little bit more again this year, but a slight decrease during the real beginning and heat of the pandemic. When you look at the moms that deliver their babies at UMMC and you think, okay, where do they come from? Are they all just in this Tri-County area? You'll see this is a little bit of a color graphic that shows different counties, and the larger the block is, the more patients are from that particular county. So we've had moms deliver at the medical center from 79 of the 82 counties in Mississippi. Again, this is that same 5-year look back that I mentioned before. And it's probably not surprising that the highest numbers are indeed from the counties that are kind of right around us. The top 5 are Hinds, Madison, Rankin, Grenada, and Scott counties. So that gives you a picture of where did these mothers come from? And it helps make the point which we like to make and want people to understand is that we provide services and provide care for patients from all over the state. We are located here in the capital city in Jackson, but we provide care for citizens from all across the state of Mississippi, and we're glad to do so. So when you look at the preterm births, so this would be the babies that are delivered before 37 weeks. So these are before 37 weeks. And look at the number of the preterm births. And out of our 14,495, of those 4,367 were preterm. And you can see the breakdown here again with the Medicaid and the non-Medicaid. Low birth weight babies and preterm very often goes together, you know, being born too soon and too small. Low birth weight is technically defined as less than 2,500 grams, and that's a little over 5 pounds, 5.5 pounds. And about 30% of our patients fall into that category. But then I mentioned earlier, there's a different category called very low birth weight babies. And of the patients that we see in our NICU, about 25% of them fall in that very low birth weight, the less than 1,500 grams, you know, the little 3-pounders. So, and our NICU has one of the highest rates of low birth rate babies in the country. So we have a very high rate. It's about 25% of our census year over year in the NICU, but that is a very high number for us. It's a very high number for the country. So what causes this? Why do we have these preterm births and low birth weight babies? And it is, you know, some of the things I mentioned earlier: poor maternal health care, lack of access to prenatal care, coexisting illnesses, diabetes, hypertension, lots of things like that. Just the mom being unhealthy, substance abuse. There's a lot of things that are associated with this. So this is just a slide to show you over the last 5 years of our Medicaid moms. So just of the births and deliveries that were in our Medicaid population, how many of them received prenatal care at UMMC? So they had their baby at UMMC and received prenatal care there. So this does not reflect the bigger picture, because there may well be moms who deliver at our medical center, at our hospital, but then received their prenatal care somewhere else and just came to us for the delivery for whatever reason. The next slide is looking at postpartum care, and the same thing happens there. Somebody may have their delivery, but then get their follow-up care somewhere else. So when we're looking at the prenatal and the postnatal postpartum, we know that there are some moms for which we just see in a very small slice of the whole time frame. They may be seen somewhere else, sent to us, have the delivery, and then follow up somewhere else too. But this gives you at least the picture of how many of them received prenatal care at UMMC. And you would note, if you look at 2020, 2021, and 2022, the no line, which is the blue bar, meaning they did not receive prenatal care with us, that is going up. And again, I think it will be quite a while really before we figure out things like this that we're seeing and how much it's related to the pandemic. Is this a pandemic effect or is it not? Is it just that maybe people wanted to get their prenatal care elsewhere and didn't want to travel till right at the time of delivery? There are a lot of questions like that that we just don't know. but we did see a decrease in prenatal care at UMMC during the pandemic time, or the worst of it. And on the postpartum piece, it's a little bit of the same thing. So again, we don't know if they return to their home hospital, home clinic, et cetera. And if what we particularly saw during the pandemic is going to be a trend, or if it is, just related to that. We don't know. So when you look at the postpartum time period and which states have extended Medicaid coverage to primarily 12 months, this map gives you that idea. We've got the blue states that have a 12-month extension. The green states are considering it. And then the light blue states, there are two where there is a more limited coverage. So, I would say to you that I advocate us in Mississippi extending our Medicaid coverage to that 12 months postpartum. I am for that. I think that would be positive for the moms, positive for the babies, positive overall in our healthcare indicators. Like I said earlier, the statistic that I have is 86% of the maternal deaths occur postpartum. So there is a lot going on in that postpartum period after a lady has a baby. There's a whole lot going on. Health issues, mental health issues. Many of the pediatricians in our state, when they are seeing the babies in for their checkups when they are infants, actually do some screening for the moms for postpartum depression and other things. So there is a lot happening in that 12-month period. And I think that there are opportunities for intervention to improve maternal health and to have then subsequently healthier babies. I've mentioned it a couple of times, but one of the big risk factors are back-to-back babies, having deliveries very rapidly, one after the other. That puts a strain on maternal health and is a very high risk factor for things like babies being born too soon and too small. So when you think about, the health of adults and the health of the citizens in our state, so much of it really starts at childhood, and so much of that depends on the health of the mom. I view the health of the mom in so many cases being kind of ground zero, and anything that we can do to intervene there and intervene early will pay dividends, for the future for all of us. When you look at NICUs across Mississippi, the neonatal intensive care units, I mentioned that we're the only level 4. That means we've got expertise, both in the standpoint of physician training and capabilities, as well as many times facilities and equipment that others don't have, things to take care of those sickest of the sick babies. But you can see across the state, there are a number of level 3s, level 2s across the state. And we at the medical center, our NICU is pretty much all the time full. We are running at capacity, running at full census. And the best thing we can do for our NICU and all these others is to just not need them as much. These are expensive units. The staff and the expertise and the equipment needed to maintain them at a certain level, it's an expensive endeavor. It's important for our patients. But, the best case scenario is we don't need all of, these NICU beds. When you look at the patients in our NICU at the medical center, just to give you an idea of kind of the lay of the land, the average length of stay is 30 days. But I only put that on here because we wanted to include the average length of stay. It is really, honestly, not a helpful data point, to be honest, because some babies only stay a day or two, but some stay more than a year. So it is really a wide range. As I said, we have, high census levels, issues with capacity. There's always a demand. When you look at an annual average number of admissions, we have about 1,000 admissions a year. For those babies admitted to the NICU, the predominant payer is Medicaid. And again, this is an average just to give you a flavor, but there is a wide range, but the average reimbursement for an NICU stay is a little over 34,000. So if you just kind of did some simple math and just some, projections, and you thought, okay, if we could do something, if we could intervene and maybe decrease that by 25%, what would that look like from the standpoint of the reimbursement just for the NICU care? That's north of 8 million. But what I would share with you is that is the tip of the iceberg. Because these children that have prolonged NICU stays, they very often require ongoing therapy, ongoing surgery, ongoing intervention, special care for years as a child and sometimes even into adulthood. So the difference it would make to just on the front end prevent some of that is probably not even measurable. I mean, it's not only in the quality of life of the individual, but if you're just looking at dollars and cents, it's a tremendous impact that we could have. So a couple of things I want to touch on. We're an academic medical center. Research is an important part of what we do. I didn't mention this, but I think it goes without saying for all of these things and all the specialty areas these people represent. We train students. We have health professional students of all sorts. We train residents and fellows in all of these specialty programs. But research is also an important part of what we are doing here. And I want to just touch on a couple of these things. Remote patient monitoring. So we are trying to extend our telehealth capabilities. Most of you've heard me brag on our telehealth program and the good things that we're doing and how that helps us reach people that have a hard time getting to us. It helps extend our services where needed. So through our telehealth center, we have a remote patient monitoring program to help with pregnant moms, particularly with hypertension. That is a big, you've probably heard of eclampsia and other complications of pregnancy. So hypertension is an important risk factor. It is an important threat to the health of the mothers. Then our CHAMP grant, which is funded by HRSA, that is a way that we are able to extend the access to mental and behavioral health for our pediatric providers across the state. When I, in my role as the dean of the medical school, talk to our alumni, one of the questions that I frequently ask is, what do you need? How can we help? As your medical school and your academic medical center, what are the needs that you have? And there are a lot, but over and over again, the most urgent thing, the thing at the top of the list is we need access to pediatric behavioral health. That is just such a need in our state. And this is one way that we are trying to help address that. The Teen Mom Project is again another telehealth project with lifestyle coaching for a group of moms. This Be Hip grant allows us to do some screening in our NICU inpatient setting and then our high-risk clinic follow-up to help with ongoing issues that are behavioral and that are mental health and just continuum of care really for these moms and the patients. Express Yourself is funded by the Kellogg Foundation, and that is focused on improving the supply of breast milk for our patients. And then preeclampsia research. I mentioned the hypertension and the eclampsia. We've probably all could name a relative or a friend who have had this and had to have an urgent or emergent delivery for issues with their blood pressure. I want you to know that at the medical center, we have a very robust program that is doing research on this. In fact, it is one of the largest basic science groups in the country. And when you look, we've done some analyses of the impact of research and research papers. And the University of Mississippi Medical Center, right here in Jackson, Mississippi, is in the top 4 in the world with the largest number of publications related to preeclampsia. And the basic science researchers that are working on this partner with our clinicians. They partner with the physicians and the fellows, the maternal fetal medicine fellows, the people in training. So it is very much a basic science, clinical science research project. This sort of enhances and adds to our expertise and our strength that we already have in hypertension and cardiac diseases. And then the last slide that I want to have for you is about our STORK program. So it's STORK. And what that stands for, as you see on the slide, is stabilizing OB and neonatal patients, training for OB and neonatal emergencies, working as we always are to improve outcomes, outcome improvements, resource sharing, and kind care for vulnerable families. This is also through a grant by the Kellogg Foundation. And what we are doing is providing training to emergency responders, nurses, and other providers across the state so that they are prepared and they have the tools needed to stabilize a mom or a baby in distress until that patient or patients can be sent to a higher level of care. So you're going to see just a short video here that you'll hear from Stephen Houck. He is the clinical director of our Mississippi Center for Emergency Services and gives you a flavor of what the program is all about much better than I can. So I want to play the video, and somebody's going to have to tell me if I push the button or say again. Okay. That's not going to be something I can fix. So I'm hoping we have, I'm hoping we have somebody here that can make that happen, fix that. That'll be a shame if you don't get to see his short video because it's so good.
Give us just 1 second. We think he has the link for it.
You can see, you'll see through this video what our Mississippi Center for Emergency Services is doing. And, you know, I touched on some of the things that we're doing in telehealth. So we are trying to kind of hit on all cylinders to see where we can not only receive patients at our medical center and take care of patients, but also extend some of this expertise and research out to others to have an impact all across the state.
Dr. Woodward, while he's looking at that, I'm going to go ahead and ask a question if that's okay. So hopefully he can bring this up in just a second. Interesting that you mentioned preeclampsia. As someone who had preeclampsia with her first child and had some significant health issues, I know you've got some subspecialists here. But as y'all are the experts in this area, I think it's important to kind of talk about this with the committee. I'm going to go ahead and ask this. One of the things that was incredibly important, I remember after I delivered the first child at 31 weeks, was my maternal fetal specialist looking at me and looking at my husband and said, it is incredibly important that you do not get pregnant right now. And so for a year, I had excellent postpartum care. I waited, I spaced my children out and was able to have a second pregnancy, very healthy, without any of the problems that plagued me in my first pregnancy. Can y'all talk a little bit about that? Because I think we'll have people that will testify later today that that is very much key in diminishing our maternal mortality rates and reducing our infant mortality rates. Can you have your specialists kind of talk about that just a little bit?
So I'll say a couple of things and then come on up. What we want is, Senator Boyd, what we want is for all of our moms in Mississippi to have that same experience that you did. And the problem is not all of them do. You know, I mentioned it a few times. Dr. Gray's going to say a lot better things than I've said, but I've mentioned it a few times that spacing, you know, back-to-back pregnancies, a shortened time in between pregnancies, spacing pregnancies out can make a big difference. But what you described is exactly the experience we want all of our moms who have preeclampsia to have, to be educated, to work with their OBGYN specialists to understand the importance of waiting so you can have that second child and that healthy child and that you have good outcomes. So that's exactly what we want. You want to touch on?
Thank you, Dr. Woodward, and thank you to the committee for allowing me to be an expert here today. I think what you pointed out is exactly what we tend to see. We tend to see, particularly at our medical center, a large number of patients who come in with preeclampsia. And the one thing that is lacking is that inter-pregnancy spacing. And I think that is one of the biggest risk factors for recurrence risk of preeclampsia, and also making sure these moms are taken care of in the terms of cardiovascular health between pregnancies. Some of the other things we tend to do to reduce the risk of preeclampsia is things like baby aspirin in the subsequent pregnancy. But I think what you have touched on is most important is spacing those pregnancies and making sure you get the appropriate postpartum care up to and even beyond a year postpartum.
Would you talk a little bit, expand a little bit more, because I know this from a personal experience, what that year looks like of really good postpartum care? Can you expand and kind of share with the committee what that looks like and how that's different than just going to see your regular primary care doctor?
Absolutely. Thank you. One of the things that the American College of OBGYN has recommended is not just the random 6 weeks postpartum, because I think most people tend to think that 6 weeks is a magical time. And it really isn't. Dr. Woodward has already mentioned that more than half of all maternal mortality happens in that 7 days to 1 year postpartum. So I think for many reasons, it's important to sort of space those pregnancies and make sure that postpartum care is as meticulous as the antenatal care. So for example, we tend to see, and what's recommended is that patients within the first 3 to 4 weeks after delivery are seen for acute things like exacerbation or elevation of their blood pressure, control of diabetes management, any things that might point towards heart disease or heart failure in that period of time. The other things that we tend to stress are mental health. Mental health can be a huge problem in postpartum patients, especially when you add in a new baby, the stress and anxiety that goes along with taking care of a brand new human and you have no idea what to do with it, right? And then patients who already have a baseline mental health problem, these problems tend to be exacerbated or made worse just by the stress of that delivery and that new baby, even if all circumstances were normal. So within the first 3 to 4 weeks, we tend to check patients for emergent or sort of urgent issues. And then up to about 12 weeks, we like to make sure that mental health is stable. We like to make sure that comorbidities such as high blood pressure and diabetes are managed appropriately, and that patients have the appropriate tools to sort of space their pregnancies a bit more.
Because of the nature of our rural healthcare system,
Thank you so much for the opportunity. I'm Dr. Collier. So I wanted to emphasize, I can give examples. I think people need to understand like what we mean. So standard of care very much has been 6 weeks postpartum, and that has been it. So it's really been a desert in the field of obstetrics of what happens beyond that period. But once nationally we began really looking at deaths in this time, we see people who we've worked really hard during pregnancy to take care of their heart disease, to identify diabetes, or they may have a perfectly normal pregnancy and then go through an emergency cesarean delivery, lose half their blood volume.
many patients have different.
So they can have traumatic events in pregnancy. We know pregnancy can be very dangerous. And then at that 6 weeks, if they're on Medicaid, let's be clear, they cannot see their doctor 2 weeks later if their blood pressure is higher to get treated for that condition. We do already have contraception, family planning, Medicaid waiver in the state of Mississippi, and it has not solved the problem. So I don't want to give the impression that it's birth spacing, that's the main driver for this increased mortality. We see moms who, if they were continued on their blood pressure medication that we started in pregnancy, they would not have hypertensive cardiac arrest 3, 6, 9 months later. Pregnancy is like a stress test. It's like having a major cardiac stress on your heart, and then we don't provide the adequate follow-up in that year postpartum. And we have the highest preterm birth and infant mortality rate in the country. So imagine your baby being in the ICU, barely holding on to life in Dr. Famiuti's NICU. You don't prioritize your health in that time. Those moms are there at that baby's bedside. And then imagine, despite all of that effort, 6 months later, that baby passes away. And you can't even go back to your OBGYN to start an antidepressant or to be seen to talk about what you just went through. And that's what a lot of our moms go through. When we review these maternal deaths, a lot of them are among mothers whose babies were born preterm. So this is like a double impact to that family. That family will lose a mom and a baby in the same community. And that disproportionately affects Black moms in the Delta. We see that stress kind of impacted and impounded over and over across generations. So the one ask, yes, is expanding this Medicaid postpartum because it's a really legislatively tied thing. It won't solve everything, but our hands are tied as clinicians when we know that we can see you for birth control 6 months postpartum, but we can't take care of your hypertension. We can't take care of your depression. So that's just one of, a couple of the examples.
Dr. Tu, I believe the statistic has been quoted that 36% of these maternal deaths occur post that 6 weeks. Is that correct?
Yes, that was after that 6-week period. And those are often, if you could put 3 big categories, often moms already with pre-existing hypertension, which is related to lifelong, when we talk about those social determinants of health, access to healthcare, family medicine, as they're growing up as children, they're becoming healthy adults. So when you enter pregnancy and you're not healthy, we can't fix it in the short time as obstetricians. We think we're pretty great doctors, but we can't fix what happens when you enter pregnancy already unhealthy. And that has a lot to do with their lived experiences, where they're growing up. Do they have access to opportunities, access to healthy food, safe environments, low stress? If they don't have that, very little we can do to reverse that. We can control it. But what we see in that delayed postpartum period, complications related to hypertension and heart disease, suicide, and overdose. Mississippi is getting hit now, where other states were much more impacted with the opioid epidemic affecting pregnant and postpartum people, but those numbers are increasing, and we're seeing increasing deaths in that delayed period. Because these moms get care when they're pregnant, they get their drug use under control and their depression under control when they're pregnant, and then we're not able to do much after that 6-week period.
Doctor, let me ask you this question too. There's been some confusion. We know, I think there's been some articles published in the paper that patients that were on Medicaid, even though the pandemic extended their coverage, that some patients were very confused by the letters that they received. Have you had any patients where that has been a particular issue?
Yeah, I personally had patients that got a letter, thought they were disenrolled, and then didn't know there was an opportunity. There wasn't a lot of marketing or advertising around that. Many doctors I know didn't know that the emergency order was still in place. And there's still a push to need to restructure postpartum care. As I mentioned, the standard was that 6-week visit. So a lot of docs were kind of like, see you next year. They weren't even building a system to check on that mom, do a transfer to internal medicine or family medicine. That's why we need more family medicine and primary care, so those OBs can hand off to primary care to take up taking care of that long-term diabetes or hypertension. But yeah, there definitely was confusion, and I had a lot of moms that just didn't even know they could come back in.
But I just want to reemphasize, you just said there was a lot of practitioners that did not know this as well. Okay, thank you. Are we ready to go on the video? All right, thank you.
Our rural healthcare system. Because of the nature of our rural healthcare system, many patients have difficulty getting access to the medical resources they need to address their life-saving and critical conditions. UMMC, Children's of Mississippi, and the Mississippi Center for Emergency Services have attempted to address this by developing a robust critical care transport system. Our nurses and paramedics are able to transport patients by both ground and air. However, some parts of Mississippi are still 2 hours or more away from these critical resources. Because of that, we've given our paramedics and our nurses advanced protocols, procedures, and equipment to address some of the most critical life-threatening events so that we can move ICU level care into the field, to rural communities specifically. We have partnered with the Kellogg Foundation to start the STORK class. This class allows our transport personnel and specialty physicians to go to rural communities and work with physicians, nurse practitioners, nurses, paramedics, and EMTs and teach them the life-saving skills they need to address some of the most commonly seen maternal and newborn emergency issues. For this class, we provide not only didactic education, but hands-on skills with a high-fidelity simulation. So they not only get lecture time, but they also get experience so that they're familiar with the emergencies when they occur or when they see them. At the conclusion of the class, we leave them a medical bag with patient-specific equipment so that when they see a newborn patient, when they see a pregnant mother, they already have both the knowledge and the tools to start addressing those emergency conditions. And then by the time we get there, we're just continuing the care that they've begun, and we move them to a higher level of care so that they can get the medical care that they need. This class is being taught statewide, and our goal by getting both this education, by having these tools in the field, by having a robust transport and communication system is to help decrease mortality in the state of Mississippi. Thank you.
I was just going to piggyback on what my OB colleagues have talked about. I'm a neonatologist, so I do the babies. Preeclampsia does not just impact the mother. When mom is unhealthy during pregnancy, then I get a very unhealthy baby. Dr. Woodward talked about 1,500 grams, but there are every year about 256 babies that are born less than 1,500 grams. We have babies as small as 400 grams. Those babies come to us unhealthy. And unhealthy doesn't just mean being preterm, but they have other complications. Many people talk about something called necrotizing enterocolitis, NEC. It's a word that's all over Google. When you Google it, the first thing that comes is a dark, dusky bowel, and that can be attributed to the hypertension that the mom has. That's not the only reason, but it's one of the primary reasons. Unfortunately, I'm not proud to say that our NICU at UMMC has one of the highest rates in the country. When we benchmark ourselves with the Vermont Oxford Network, which is a network of about 1,076 neonatal intensive care units across the country, we unfortunately come up in the highest percentiles. So taking care of the mom does not just deal with the mom's health, but it impacts what I get in the NICU. As Dr. Woodward said, our vision is that the number of very low birth weight babies goes down. The NICU will still be there to serve other babies that have other malformations and several other different things, but there are things that are modifiable. Preeclampsia is one of them.
Thank you, Madam Chairman. Thank you, Dr. Woodward, for presenting today. Just got a couple of quick questions. We do plan on having a hearing later on this fall, specifically on postpartum care. So we'll have you guys back. But you talked about the remote monitoring for hypertension. Do you do anything for diabetes?
So using telehealth, is that?
Or remote monitoring?
So you want to talk about that, Dr. Jones? That's your. We do. He'll tell you more.
We have a robust program for remote patient monitoring across the spectrum of diseases, both pediatric and adult. Diabetes is one of the ones that we have gained some national attention for, the ability to control patients' blood glucose, keep them out of the ER, keep their hemoglobin A1Cs down, make sure that they're compliant with their medications. We've seen some remarkable improvement in outcomes among patients in the Delta, which was our initial pilot program associated with that. So it's a pharmacy-driven program. So the pharmacists and the nurses do a lot of education, and then the management of the medications in consultation with a physician.
Thank you. And then, Dr. Woodward, you had a slide that talked about preterm births, low birth weight. And the Medicaid population is almost 2 times that of the other. Have you seen a drop since the public health emergency has gone into place? We've extended some things.
So, we have not. And, I'm not 100%, or seen a drop in deliveries or a drop in,
This is low birth weight.
in the low birth weights.
I'm just wondering, why is Medicaid twice? Because these ladies are receiving care. So what's happening that their low birth weight is twice that of the non-Medicaid?
So I think a lot of this ties back to what you heard in that despite the fact that the opportunity for care to be expanded and extended during the pandemic was there, it wasn't broadly understood on the healthcare professional side as well as on the patient side. There was confusion about that. So it is hard to tease out the reason why we have not seen a drop since the opportunity to have coverage for 12 months was extended. Is it because we're in a pandemic situation and people are reluctant to seek care? We've seen that in many areas. Even things like cancer screenings and whatnot, people have put off care or they have not gone to the doctor. So we don't know how much it is that patients just didn't understand that coverage was available, versus being a little uneasy about really seeking out health care. We just don't know the answer, but we have continued to see low birth rate babies and preterm babies during this pandemic time.
Thank you, Madam Chair.
Senator McMahon.
Thank you, Dr. Woodward. Thank you for what you've shared here. And I just wanted to take an opportunity to publicly thank you and your team for your help during the last 2 years. I've sent you some very difficult cases. Your team's always has responded quickly to my telephone calls and helped the constituents that needed help with prenatal care and then some other very difficult situations. And I just wanted to thank you.
Thank you. Thank you. That we want to be that resource. Thank you.
Senator Hickman.
Thank you, Madam Chair, and thank you, Dr. Woodward, for the presentation that you have given us. I have just a couple of questions. One, I'm going to ask a follow-up question to Senator Blackwell's question. I think his question was concerning low birth weight and things of that nature has a drop since this 12-month postpartum. My understanding of the way Medicaid works, many mothers go on Medicaid. It's not until the point that they become pregnant, correct? And so many of them, opposed to people who are not Medicaid recipients during pregnancy, have not had access to a primary care physician or family doctor over this period of time. And so they could or could not have underlying issues that lead up to that the postpartum care can't speak to. Is that correct?
That's right. And I'll ask my OBGYN colleagues if they want to add into this, but Dr. Collier mentioned, by the time that they get the patient, very often there is already many years worth of a lack of being healthy, whether it's a lack of access or whatever it may be, but many years of being anemic, diabetic, hypertensive, all the different illnesses that we see patients present with that have either been partially treated or untreated or just kind of ignored, So I don't know if there's anything either one of you would want to add to that.
You're correct. So policies extending postpartum are really going to impact mother's health afterward, child development, breastfeeding. It's before pregnancy. So 65+% of births are covered by Medicaid in Mississippi. That means 65% plus of people giving birth did not have access to insurance before they got pregnant, and then they have to sign up, and many practices don't begin seeing patients until they're fully signed up. So that means they have to wait until they get their Medicaid before they make that first prenatal visits. I think the prior team presented 25% not starting prenatal care in that first trimester. So those are all things that, if they're entering the pregnancy unhealthy, healthcare in pregnancy is just kind of putting Band-Aid on it, trying to correct it as much as possible. It's not reversing it. We don't make people lose weight in pregnancy. We can't complete, it's not a goal there. We're able to treat hypertension, but you're not, able to do the impact. But hypertension, if you look in Dr. Famiude's NICU, almost 50% of the babies born preterm have some degree of maternal hypertension. And hypertension can be improved and controlled with, long-term primary care and better health before pregnancy, but also things like the low-dose aspirin during pregnancy, which isn't adopted even universally now. We see a lot, Dr. Gray works overnight at UMC, gets lots of transfers. He sees plenty of moms come in from around the state who should have gotten low-dose aspirin, who should have seen a high-risk OBGYN early in their pregnancy and just didn't have access to it. So a lot of this is about getting plugged into services early.
I have another question, Dr. Witter. As the academic arm of UMMC, I have data that shows out of our 82 counties, 45 of them don't have an OBGYN, or they have very low maternal health. And my question around this is, do you have any advice for what's the solution of that? And the issue is that while a mother, I serve 4 counties, and 3 of my counties don't have a single OBGYN in the counties. So a mother where I'm from has to travel an hour to her OBGYN appointment, where someone who has an OBGYN down the street, they can take off a break from work to go see their OBGYN for their appointment, while someone where I am would just have to take the day or half a day off. And I think a lot of time they say, well, I'm not going to go to this appointment because I can't afford the time off work. What's our solution to solving these maternal health deserts, or do you have any suggestions at how we can solve that?
So just a couple of things for context. I grew up in Carroll County. We have no doctors in Carroll County. So I get that a lot. For a long, long time, we had one. He was a family doctor. My background is emergency medicine. Dr. Jones is emergency medicine. Dr. Gray, as you heard, works a lot of nights and he runs our hospitalist service. So he kind of is the intake for a lot of the patients that come in. And so many times, hundreds of times, we have all seen patients that presented well advanced into whatever their issue was. And when you try to inquire gently on, why are you just now coming in for this, but to try to say that in a nice way, so often it is, I didn't have a ride. That whole issue that you're talking about of where they live, it's not easily and readily accessible. So this is a big challenge that we have in this state, not just for OBGYNs, but for lots of different type of physicians. And in many cases for, like I said, back to Carroll County, for a doctor in the county, not just, not even a specialist. So I think that that it is a big problem. There's not just one solution. There are lots of potential solutions that all factor into this. Looking at workforce, physician workforce in the state. We are last. Mississippi is last in physicians per capita. At the medical center over the last decade, we've been working very hard to grow our class size, and we have done that successfully, to grow residency programs so that we can graduate our students and train them here, because we know that plus that gives us the best outcome of having them practice in Mississippi. The Rural Physician Scholarship Program, which all of you support, has been tremendous. Part of our challenge is medical education is a long pipeline. You make a tweak today and it may be 15 years before you see that change. I am confident in telling you that whoever's standing in this place in 20 years, talking to the legislature, will not be saying we are last in physicians per capita. We will not be. I'm not sure where we'll be, because since the time when we did our analysis, all the variables have changed, but we will not be last. But it's not just a physician workforce thing, it's nursing workforce, it's all of the pieces. And and the medical center and a number of the nursing programs around the state, we're all working to grow to meet that need. But it's a big hill to climb. In the meantime, what can we do? Our telehealth program, where we are extending our services and our reach to help support primary care physicians and others across the state in some of those areas where it's a challenge. So I don't have a single magic silver bullet for that problem. It's, the factors are, it's multifactorial, and it will take many different efforts to address it.
And just one last thing, I just want to say, I really didn't ask you that to put you on the spot or to think you had the solution. I
That's
kind
my
of,
favorite question.
I
It's
kind of,
okay.
yeah, I kind of wanted to make sure that those facts were out there. And I think any way that we can help you, if you come up with a solution and there's something we can do, I think the people here would be apt and ready to help you or assist you to do that. But my one final question, you made a very interesting remark on your slide about NICUs, and you said the best solution is to not need, all of these beds and all of this. We've talked a lot about postpartum extension of Medicaid and those type of things, and I think that's an easy conversation in this room. But from my first question, I think the point of the matter is that only solves a few of the problem. It's a very small slice of the issues that we have. What are some suggestions you have for us not needing these NICUs as much? What are some other things that we can do or we can look at as a legislature to try and solve some of these problems and issues?
So and again, from my own background, being from a very rural part of the state where there's limited health care and many people who have challenges with things like getting a ride, to my background in the emergency department, where you truly see all the failures in the system. When you're working in the ER, you see all the things that didn't go right. And being in Jackson at the medical center, you see all the things that didn't go right from all over the state. So I have a personal passion about access to healthcare and the importance of that. And I think that all of my team does. We see the sickest patients in the whole state at the medical center, and everybody realizes the challenges that we have. So it boils down to access. But again, that's so many things. That is providers that are available. That is patients having the resources to see those providers. It is the education component, people understanding that it's important to maintain your blood sugar, and it's important to try as best you can to prevent from having diabetes, all the things. So, access, the promotion of health, anything that we can do to prevent patients from needing the NICU, prevent patients from needing the emergency department, will be good for our state all the way around. Thank you.
Senator Turner Ford.
Maybe my blood is cold. Thank you, Madam Chair. Dr. Woodard, thank you for your comments, and you may have touched on my question during your dialogue with Senator Hickman. For years, we heard it said that Mississippi was at the bottom of several statistics, education being one of those. And then with I would say the efforts to improve, implement early learning collaboratives, scholarship programs, et cetera. I think we've heard that in some categories, Mississippi has made gains. Going to the second slide that you presented to us, where you show that Mississippi is #1 in a lot of damaging areas. Have you noticed any progress in any of these statistics that you've mentioned here?
So I'll say a few things and then I will ask others if they have something to add on this. So yes, we've seen progress in some areas, and we've seen encouraging pockets of progress, maybe the better way to say it. When you look at, for example, that remote patient monitoring project that Dr. Jones mentioned related to managing chronic diabetes, that pilot project that we did with a group of patients, we saw remarkable outcomes. So the challenge is to take something like that and then ramp it up and scale it up so that it can have more of a statewide reach. And, you know, you've got to think about all the things like technology infrastructure that it takes to do those sorts of things. So we have seen pockets of progress. We are seeing, you know, like I said, our number of healthcare physicians and across the board healthcare workforce, those numbers are going up. So we're seeing progress. It's not at the point yet where we're no longer number one on the list of, you know, where number one's the wrong place, but we're seeing encouraging pockets of progress where efforts are paying off.
And going over to one of the other slides, I think it may have been the slide, Medicaid postpartum coverage, the map with the blue states versus the green states. I'm having some difficulty making out the print. What is the distinction between the blue states and the green states?
So the blue states are the states that have extended 12-month coverage. So all the blue states have already extended 12-month coverage, 12 months postpartum Medicaid coverage. The green are in planning for a 12-month extension. And then there are 2 blue states where they are looking at some extension, but maybe not 12 months, 6 months or some other limited piece. And, you know, it is, I think, notable that at least mostly around us and in the southeastern region, some states have already made this move, and or like Alabama and Georgia, very close to it, making that consideration. I'd love a year from now if we show this slide for us to be blue.
So is it a matter of for instance, Alabama and Georgia, they're considering the change, but legislatively it has not been passed yet?
That's right. My understanding is that they are planning to implement a 12-month extension, but it has not been passed yet.
Thank you.
All right, thank you very much. And I have lists that I'll pass out to the committee that kind of show where the 34 states are that have, that are in the, trying to have the 12-month process. And then I think there's 3 additional states like Texas and that have a 6-month issue in there. So I have that, I'll pass out to the committee. Thank you so much. And thank you to your team today. We very much appreciate it. Wait, and we have one more question from Senator Wiggins.
Response on that, as we heard during last session, that, ooh, if we do postpartum Medicaid extension, that is Medicaid expansion. That was coming from down on the other hall, particularly by the 3rd floor. So what is your response to that?
So I think when you look at those initial statistics that I started with, you know, where we're number one on the list of all those things, the preterm delivery, the fetal mortality, infant mortality, and have such a high rate of maternal mortality. You look at that, it is clear that efforts we have made up until now have not really moved the needle on that. I think that no matter what somebody's opinion is about expanding Medicaid at a broader level, if you carve out and look at this 12-month period, it is clearly a vulnerable group of patients. And the impact that these poor health outcomes have on these patients and their families and the future of these kids is tremendous. And I think that in and of itself makes a tremendous argument that this limited carve out is well worth the efforts and what Mississippi needs to do.
Any more questions? Okay. Thank you so much for today. We appreciate y'all taking your time, and we will look forward to your testimony with Senator Blackwell's committee as well.
Yes.
Thank you.
Thank you, Chairman Boyd, and thank you to the committee. We appreciate the opportunity to be here.
just a few minutes. We want to welcome as our next panelist, Dr. Daniel Edney, the Executive Director of the Mississippi Department of Health. And we are welcoming you to this position, and we're glad to see you here before the legislature today. Thank you so much.
Thank you, Madam Chairperson. If you would allow me to, I'd like to introduce my team, subject matter experts. I think y'all probably know a lot of them. It's Jim Craig, our Senior Deputy and overall water extraordinary expert. And Dr. Beryl Polk, who is over our Health Services Division, which is very important for the issues we're talking about today. Dr. Victor Sutton, Preventive Health and Health Equity Department. Ms. Sharon Dowdy, who is our Chief Administrative Officer and CFO and knows all the numbers. And then Dr. Justin Turner is our Chief Medical Officer. And I appreciate them being here. And I'll refer all difficult questions to them. If you notice Dr. Thomas Dobbs, and if you've seen him anytime recently, you've seen a smile on his face. And I keep wondering why he keeps smiling a lot more than he did 3 months ago. But he remains in active service with the Department of Health and will be as long as I can convince him to do so. So I appreciate the time today for allowing us to testify on this extremely important topic, and especially an important topic to the Mississippi State Department of Health. I want you to know, as we are coming out of COVID pandemic response, COVID obviously is still an issue, but we are out of the pandemic response, that we are pivoting back now that we're able to our most important public health issues. And for us, the number one priority of the agency will be getting us off the bottom. And I'm going to share with you thoughts along those lines, give you whatever information you need. But the number one health disparity issue and poor health outcome that we're most concerned about is maternal infant morbidity and mortality. And our major focus is in that area. If you let me just share with you. slides quickly. You have those in your workbooks, I believe. Let's see. Okay. So I have in your slides in your packets, the first couple of slides will outline each of the critically important public health outcomes that we're attacking with the programs in the Department of Health that are engaged with those. And it also will show you whether it's home-based, if it's county health department-based, if it's hospital or population-based, and that's there for your information. And for the sake of time, I want to go ahead and start walking through these disparity issues. So first and foremost, maternal mortality and morbidity. I know y'all had a good discussion with Dr. Woodward from UMC, and I will be showing you our information from a public health perspective. But as I look at these issues, I'm looking at three distinct categories of impact for the agency. Number one is prevention, which in my opinion is the most important, it's the most cost-effective. It's not easy, but it's doable. Number two is concurrent care services. I'll share with you, that's basically taking care of people. And then number three is evaluating where we are. And for us, that's postmortem analysis of mothers and babies who have not survived. All three of those buckets are extremely important for us to do our job. So in the first bucket with prevention, we have our family planning program. And for many years, we've been under Title 10, federal government grant. We're transitioning off of that in April. And my intention is that we will fully partner with the experts at Converge and also with our partners at the community health centers to augment the ability for every woman who is in need of comprehensive family planning services to have access to that, irrespective of where in the state she lives. So we will not be providing comprehensive statewide, but there are deserts that we predict will occur where it will be difficult for women to access family planning services. And in all those areas, there's a county health department. And so we're committed to do what's necessary to provide those family planning services, because the best way to keep a mother from dying in pregnancy or in the postpartum period is to help her not have an unwanted pregnancy. So that is critically important. We are going to leverage another federal grant to help us have access to lower cost medications. And I'm committed to using agency funding, which when I talk about agency funding, I'm talking about what we generate with revenue and fees, that our own agency funding as much as needed to support the access to care for family planning. It is critically important. We also, I know you'll be interested, we will have access to LARCs through our 340B program. And I'm a big believer, my family planning experts, Dr. Polk, is big believers in LARCs if we can get the usage rates up. And we'll be working on that. But we will make sure that those blank spots are covered until somebody else is able to do it. Remember, health department is the provider of last resort. We're not here to compete. We're here to plug holes and be that safety net. Just to highlight the importance of this for family planning. As we have the discussion, coming after the Roe decision with the Supreme Court, we don't know the number of increased live births we're going to have. I think a conservative estimate will be about 5,000, maybe more. And these are 5,000 pregnancies that otherwise would have been unplanned and unwanted, which puts them in a higher risk category. It's very different a pregnancy that's wanted and worked for and a woman's prepared for versus the surprise pregnancy. So we're very concerned that out of those 5,000, there will be an increased number of low birth weight babies. And the University of Colorado has estimated that nationwide, we're looking at, among the general population, probably about a 21% increase in maternal mortality. And among Black women nationwide, more like 33%. Now, if you take those numbers nationwide and you apply them to Mississippi, it's scary because we're already 50th in the nation for perinatal morbidity and mortality. We're 50th as we stand today. And if things are getting worse and we're not prepared for it, you know, I'm frightened about what those outcomes will be. Another key issue in preventing perinatal morbidity and mortality is the AIM initiative, which evidence-based safety bundles, the state of Texas implemented them and has shown significant decrease in their perinatal mortality rates. And we already are working with the AIM initiative, that's the Alliance for Innovation on Maternal Health. And these are safety bundles that are for specific subjects such as hypertension in pregnancy, such as hemorrhage in pregnancy, such as sepsis in pregnancy. And we are working to deploy those safety bundles to our birthing hospitals around the state. The evidence is clear. Hospitals that deliver babies who implement these AIM safety bundles have lower rates of maternal death. And so that's prevention. This is, go ahead.
Doctor, could you explain to us what safety bundles is just a little bit more?
These are protocols. These are evidence-based protocols developed by the obstetrical world that say these are best practices. That if every hospital would do perinatal services this way, then we'll have better outcomes. I apologize, Dr. Think. But these are extremely important. We're in the midst of that. The funding for that is a small HRSA federal government grant of about $27,000 a year. I've got to get that funding higher to be able to implement these AIM bundles. And I will be deploying the resources I have, but of course, I'm always open to help. Other efforts, if we move from the prevention category to the concurrent care category, this is where our Healthy Moms, Healthy Babies program will come into play. I put a brochure at your desk, and this will be a concurrent care initiative where we will have nurse case managers assigned to every pregnant mom referred to us. If she is pregnant and has no insurance, she likely will qualify for Medicaid, and we'll work with a division to get her eligible as quickly as possible and get her first prenatal visit done with her OB, get her an OB and get her in as quickly as we can. That nurse case manager will be in the home. This is not in the county health department like Premise or PHRM. This will be in the home. And I've already given the instructions that when my staff are in the home, I want them looking and listening. I want them to see what barriers are in front of our moms that are preventing them from accessing care as they need to. All of these moms have Medicaid, so they have access through insurance. But as you know, there are many social determinants, depending on where you are in the state, that are interfering with access to care. So this is an equity issue rather than equality. These women all have insurance, but they're having difficulty deploying that insurance for their benefit, for the benefit of their unborn baby. We will be in those homes and we'll see, is it transportation? Is Medicaid transport not working? Is she eligible for TANF? Is she eligible for SNAP? We will certainly get her signed up for WIC. We will get every benefit that we can for her, but we will be looking at the struggles that mom is up against, whether she's in the Delta or in Southwest Mississippi or Metropolitan Jackson or Northeast Mississippi. We're going to be looking at the struggles that these moms are having that are impacting our high rates of morbidity and mortality. We'll be in that home up to a year for a year after delivery till the baby's 1 year of age. So we'll be with her through her pregnancy, through her delivery, and with her infant until the baby's 1 year of age. We know if we can get that baby to 1 year, then that baby has a chance. And we're going to work hard to get that mom through her pregnancy and through her first year of postpartum care safely and get that baby through his or her first year of life safely. And I've already told my folks, if you're identifying an issue that's a barrier to care and there's no payer source, we'll be the payer source. We're committed to getting these numbers better. And I truly believe the concurrent care model of Healthy Moms, Healthy Babies will help get us there. This is a Medicaid program. I do want to remind y'all, when I say a Medicaid program, the agency does provide our own match. So It's a combination of federal and state dollars together. All right, just quickly for infants, we have our newborn screening program and early hearing screening programs, which are looking to detect genetic diseases or hearing difficulties in babies at a very early stage, so they can get the proper care that they need. The genetic services are through fees at the agency, and the hearing is through a small federal grant. Our lead poisoning prevention and healthy homes, which is very important, is a federal grant that allows us to help monitor in coordination with primary care doctors if there are any hotspots around the state with children being exposed to lead, and if it's identified, then to try to eradicate that lead source. That's through a federal grant. And then EPSDT, early periodic screening, detection, and treatment, extremely important. I think it's going to be very important moving through these extra 5,000 births, because I just don't see any way around a significant percentage of those births having complications and needing more services. And this is a great service that I agree with Senator Boyd is way underutilized. We do provide this service in the county health department as we're able to, but we try to do it in cooperation with the primary care docs in the community and work in a collaborative arrangement with them. This is another Medicaid service, but this is for children 0 to 21 years of age. And as we do identify developmental issues, then they can be referred to our early intervention program. And with early intervention, we're able to take those children and work to habilitate them properly through private providers around the state. And that's a mixed funding model between federal dollars, Medicaid dollars, and state dollars. It's a very effective program, and we made a significant increase in investment last year and will continue to invest in this really important program. Children and youth with special health care needs, another federal grant program is just looking at children and teenagers that have special needs issues that there's not another provider for, that we step in and help them for. The third bucket I shared with you is the postmortem evaluation. We have the Mississippi Maternal Mortality Review Committee that's state mandated. It's not funded, but the agency takes care of that. There is the Child Death Review Committee, also mandated, but there's no federal funding or state funding for that. So we cover that. We also, depending on where you are in the state, have the fetal infant mortality review. That is not state mandated. That may be something that y'all would consider, is requiring that the same as maternal and child. Infant is different. Fetal infant is different than child. So it has its own review committee, and we need to be looking at that data, I think, more thoughtfully than we currently are. And again, there's currently no funding for that, but it is important work. And those are basically where we take every death and they are reviewed by a panel of experts, multidisciplinary team, to look at why it happened, was it preventable? And remember, 80% of maternal deaths in this country are preventable, 80%. So if was this mom in the 80% category? And if so, what happened or what did not happen? And was it a systemic issue that failed her? Was it health? Was it social determinants of health getting in the way of her care? Whatever it is, we look to see, is it preventable, and what needs to happen to try to prevent them in the future. This is going to be incredibly important work for us to get off the bottom with maternal infant mortality. We have to understand the problem. I don't want to wait until it's a death review, obviously. But, and you can imagine how hard that work is for our employees to look at every child who dies in this state, every baby who dies, every mother who dies perinatally. That's pretty dark work, but it's incredibly important, very, very important. So, and Chisburg, that's the programs as we stand. I was trying to be respectful of your time and would be happy to answer any specific questions.
Thank you. I'm going to ask a couple of questions that we talked about in our earlier meeting, just kind of follow up through with that. First of all, thank you. You told me y'all were going to take a very strong, different approach really and look at your Healthy Moms, Healthy Babies program. And I see that y'all, really made some strong strides in that. Let me ask you this, with the nursing shortages that are facing our state, do you feel like you're going to be able to really expand that using nurses in those particular roles? Do you feel like there's the workforce available to do that?
There is, and in fact, coming from the private sector, what I'm seeing a lot from hospital nurses that are burnt out are looking for alternative careers. And we've actually been promoting public health nursing as a wonderful alternative career. I tell folks, it doesn't pay as well, but the benefits are great. And you get to go home and you get to enjoy your family. We have had a lot of interest of nurses coming on. We're onboarding, I'm sure you hear from other state agencies, is difficult. It's very hard to hire a nurse. If I have to wait 2 to 3 months to get her on, they find another job. But outside of the onboarding process, we've got great interest, and I do believe we'll be able to staff it. We've committed financially to staffing up to whatever we need, and of course, it'll generate revenues, which we'll put right back into the program. But we need those strong public health nurses, our social workers, community health workers, is the whole team approach for this.
Several of us have been on a committee and several different kind of national work groups that we've been looking at these programs, and they really have strong efficacy rates, right, throughout the country when they're used effectively.
Right.
All right, I'm going to talk to you about something we talked about. I'm going to ask actually other state agencies this question. It'll be kind of a reoccurring theme that I know y'all are working on. But one of the problems that we noted as we were meeting with most of the state agencies is they're siloed. And some of the programs that you mentioned today, as you send these nurses out to make sure that they are making sure that people are signed up for TANF, to make sure they're signed up for Medicaid. Can you tell me a little bit about the work and tell this committee a little bit about the work y'all are doing to make sure that agencies are not siloed right now?
Absolutely. I'm going to give kudos to Mr. Anderson, who's led the way with our MALT leadership meetings among state agency heads and other community partners. And the conversation among state agency heads is absolutely, we have to collaborate and cooperate. I don't have enough resources to do even what we're talking about now, much less to expand the scope of that work. A good example, getting out of the silos, early intervention, that's cooperation between us and Department of Education. When we're talking about prevention, I mean, that's got to be Department of Education involved. We've got to get as far upstream as we can for public health education on behavior changes. As I said, partnering with other community partners is extremely important. The health department, community health centers, the other family planning partners. We have community partners around the state that we subgrant to that get out to help us do this work. And my staff knows that those have to be held accountable for these very limited resources, that we had to have deliverables, and that we are going to be a good partner to other state agencies as we hope they'll be to us. But that's very much a serious conversation that I'm hoping will bear fruit. And it's not just siloing of the agencies, it's siloing within the agencies. And my team will tell you, they seem to shake, they're nodding their heads. We have been banging the silos down at the health department. And we've got to get our own house in order as we work to get outside the silo to other state agencies. Thankfully, we're experts at working with community partners. We know how to do that, but it's being cooperative and collaborative with other state agencies. Mr. Snyder and I have had thoughtful conversations in terms of leveraging Medicaid funding for improvement of population health outcomes. We have 3 managed care organizations that are well-funded that, in my opinion, they need to help us with these indicators. It's their populations. And, so it'll take a cooperation between us and Division of Medicaid and others to get this work done.
Thank you. And we're going to continue to ask all that question.
Absolutely.
Because we think because we have a number of resources that are out there, but oftentimes they're not being used. And it's because there's this communication barriers that we kind of see over and over again. On that same note of communication, And I want to compliment the health department because y'all had to really cartwheel during COVID, and you had to develop new methods of getting out to the communities and really communicating messaging. But one of the things that has come up repeatedly from the state agencies, and when you then get out into the communities, is particularly with our providers and then our consumers of information, is that there's a lack of kind of, I'm going to call it one-stop shopping, a website that really would, where someone could go. If you're a provider, you could go to look to see if you have a mother, you have an infant that has an issue, of where all they can go, whether it be Medicaid, whether it be human services, whether it be the health department. Would we understand from your agency that y'all would like to see something developed that where that there could be this kind of one-stop shopping for mothers, for infants, I mean, for families that really want to go access this information?
Absolutely, which is what I alluded to with the healthy moms, that, you know, we make sure she has everything she's eligible for to help her. Remember, I came from the provider world before I came to the health department. And before COVID, there was a large wall between public health and private medicine. Dr. Dobbs, through the midst of the COVID pandemic, worked with us in the private world because there's no way public health could do it all. And there's no way private providers could do it all, but together we could. And that partnership was very powerful, I think. And that's why he recruited me to be the first chief medical officer, to be that liaison outside of the agency to providers of all types. And now Dr. Justin Turner is following my footsteps, and that's his number one job, is customer service to the provider world. So these are really important issues to us, and we will always take constructive criticism when we're not doing it right.
Well, and I really kind of want to make sure there is a need, y'all feel like, for this type of website or type of communication.
Texas has this. We can look at the Texas model. If we copy what Texas is doing, it'd be so easy. You go to the state website and everything's listed there. And you put in your demographics and it tells you what you should be eligible for, just irrespective of the agency.
It's impressive.
It is.
Okay, and then one final question that I have is, did you say fetal mortality review? That is something that is needed within the state?
Fetal infant.
Fetal infant, okay.
We call it FEMR, fetal infant mortality review, which COVID has been devastating on fetal death rates. And we are just now going through our COVID data, which is going to make everything look worse. As you can imagine, we had increased mortality for our pregnant moms with COVID. But we'll be teasing through that as best we can, but we have seen a significant increase in fetal mortality over the last 2 years. Infant has improved a little bit. I'm so excited to see some improvement.
I said it was the final question last time, but this one is, during our meetings earlier, you said there were two things that you thought we could do that we needed to do to diminish our maternal mortality rates and our infant mortality rates. Would you repeat those things for our committee, please?
Now, Senator, I'm 61 years old. Well, and I'll be honest, the first thing that I would recommend, and in my opinion, it's absolutely necessary. It's not sufficient, but it's necessary that we extend Medicaid benefits to continue through 12 months. When I look at the case narratives from our deaths, I see time and time again, moms who are dying in month 4, month 5, month 9. I reviewed a death that she died month 9. So I was told by our maternal mortality review committee chair that about 36% of the deaths occur after the 2nd month postpartum. So that's a significant number. And and as a physician, as an internist, if there's a woman who has pregnancy-induced hypertension that's requiring 4 medications, which is not uncommon, to control her, and then month 3, she loses Medicaid, she loses her medicine. As an internist, bad things are about to happen. We have women with perinatal cardiomyopathy, that young women with heart failure that need aggressive care. If they lose access to their insurance in month 3, we'll have very bad outcomes. There are other options. Texas decided to go 6 months, and Texas is very conservative as they've extended 6 months. Discussion about, if maybe just look at the high-risk moms, which would be a lot of them, but making sure our high-risk moms are tended to throughout the whole 12 months, I would be open to any considerations, just as long as those moms are at the highest risk, don't lose access to care at month 3. I've seen too many bad outcomes. And these are cases from 2017 that from before the emergency order. So these were moms that lost their Medicaid at month 3. So these are deaths without Medicaid.
And I believe you said increasing the time between births.
Yes. All right. So thank you. So going back to the prevention care with family planning, first thing is to educate a young woman to delay pregnancy as long as appropriate for her, to not have an early unexpected pregnancy, to be more mature in all respects, but certainly physically, and also be prepared to be in as good a health as you can be. Know what your blood pressure is running, know if you have diabetes or not before you get pregnant. And then, with healthy moms, we're going to be in that home for probably a year and a half. We'll be educating her on these things. And the first thing we're going to teach her is now, as soon as we have this baby and as soon as your OB clears you, we need to get your family planning going and make sure that you don't get pregnant for at least 18 months. And we'll help you get the care you need and do what we need to protect you from getting pregnant too soon. We know those short intervals increase the rate of low birth weight babies and increase mortality.
All right, thank you very much. Senator Turner Ford.
Thank you, Madam Chair, and thank you, Dr. Edney. During your presentation, you mentioned a number of committees that were mandated but unfunded.
Yes, ma'am.
And I was not able to record them all. Are they in the slides that you provided?
They may not be.
And if you could, in your explanation of the committees, if you could indicate if that mandate is state statute or if it's federal.
Absolutely. First is our maternal morbidity review committee, and Dr. Pope, get me straight. That is required by statute. And this is the multidisciplinary team that the statute determines who serves on it. And they're the ones who review every mortality case and make the determinations of why it happened and what we can do to prevent another one from happening in the same situation. I think most of the individuals bear most of the calls. The agency provides the staffing and the mechanics to make it happen. Any funding that you're able to provide for things like that allows me to shift funding to another area in need. We're going to make sure it happens, but definitely could use help. Second is the FIMR committee, fetal infant mortality review. And that's where we look at fetal deaths and infant deaths before 1 year of age. And that is not mandated. That's happening, like Tougaloo has a program with a FEMA project. There, how many? 2 in the state. Again, they're not funded. They're getting their own funding, and we certainly will support them. But I would love to see a statewide FEMA project, just like we do for the other 2. And then thirdly is the child death review committee. And it's the same thing, looking at the death of children and making the same determination. That's a statutory requirement. So maternal and child are mandated by statute.
Thank you. And none of them are funded.
That's correct. Just agency funds.
Senator Wiggins.
Thank you, Dr. Edney. I want to explore this 5,000 number. So if I heard you right, as a result of the Dobbs decision, the Department of Health is planning on, at a conservative number, an extra 5,000 births this year.
Yes, sir. That's the number that I'm hearing and I think is reasonable. Of course, we won't know. There will be a certain number that go out of state. So it's not going to be every previous pregnancy determination is going to be a live birth. But I think we should look at, some people are quoting 7,500. I'm using the 5,000 number until we know really what the numbers are.
And I think if I understood you right, you said based on y'all's analysis, those fall into a category, your terms, unplanned and unwanted. Is that right?
Yes, sir. I'm referring to pregnancies that pre-Roe decision would have been terminated in Mississippi, who now are not going to be terminated. And so by definition, those are unwanted pregnancies, which put them in a different risk category.
Okay, different risk category and meaning high risk generally.
generally. It's a higher risk. It may not wind up being a true high risk, but I mean, any pregnancy that's a oops, surprise, I wasn't ready for this, kind of kicks determinants in place that get in the way.
We know that just based on our numbers and stats, that higher risk pregnancies or births cost more to the state.
They do.
Be it Medicaid or anything else. Is that right?
Yes, sir. Especially the low birth weight babies that wind up being in the NICU, as UMC testified, I'm sure. Very
So,
large dollars.
do we have a number of what those high risk pregnancies cost in general, or so where I'm going with this, you may know, is 5,000 times the cost of these high risk pregnancies that may end up falling on the state.
And Senator, I would say, they're going to be likely 5,000 more live births. They won't all be complicated.
I understand, but how much is I know that may be a hard number, but
The lower birth weight, the higher the cost, and the sicker the mother, the higher the cost. So, if I were king of the world, I would be getting as far upstream as I could to teach young women how to be healthy before you get pregnant and how to stay healthy and survive a pregnancy and not die. And I would work hard that those women had appropriate access to care before they got pregnant. Right now, if you get pregnant, you get access, but for a 23-year-old with hypertension who doesn't know it, to get pregnant right there, once it happens, that's by definition, a high-risk pregnancy.
okay.
So
But what I'm trying to get at is if the cost of a normal pregnancy, healthy, not high risk is, I don't know, I'm making up a number, but let's say it's 10,000. Okay.
Right.
Then the high risk is going to be 10,000 times another factor, which would be, is it 100 times? Is it 50 times? Is it 10 times?
Yeah, for a 24, 25, 26 weeker who survives, I mean, those can be multi-million.
Okay.
Depending on how long.
One child?
Depending on how long they're in the NICU, I'm sure you can see.
So one child on a high risk because they're in NICU and all that, you're talking multi-millions of dollars.
It's not uncommon that they're at least $1 million hospital stay.
So going conservative, if we're taking 5,000 children and let's just say divide that, whatever, I was 5,000 and $1 million conservative, that's $5 million of high-risk pregnancies that the state is going to be looking at.
Yes, sir.
Okay, understand that. And it can be higher because of the things that you're talking about. And most of I would argue most of our high-risk pregnancies are covered by Medicaid.
Yes, sir.
Is that right?
60% of all live births in the state are covered by Medicaid.
60% of all live births are covered by Medicaid. So 60% of 5,000 is, let's just say 3,000. So 3,000 times $2 million, we're looking at another $6 million to Medicaid.
I'm sure Mr. Snyder will have better numbers, but I don't think that is unreasonable. It's going to be
not unreasonable.
It's going to be significant.
Okay, thank you very much.
Yes, sir.
Senator Hickman.
Thank you, Madam Chair. Dr. Edney, thank you for this presentation. I do have just a couple of questions. One is starting with the Healthy Moms, Healthy Babies program. I don't think you advanced the slides, but in the slideshow that we have, it says that the current caseload is 551.
Currently, I checked with Dr. Polk this morning. We're up to about 550 moms in the program, and we're working to get to 1,000 by the end of the year.
And would 1,000 be capacity, or would 1,000 being everyone who needs the program and eligible for the program is being served in the state?
It will not be capacity because we will continue to staff to what capacity needs will be. The biggest hurdle is getting the word out and so we're educating the medical community, but we're going past the medical community into the community to educate community partners, pastors, faith leaders about the program. So if you know a young lady who is pregnant, if she has no insurance, refer to us and we should get her eligible quickly. If she's on Medicaid, refer to us and we'll get services started. So, we're going to be launching a significant communications campaign to get the word out, especially to impacted communities who need it the most.
And of these 550 50 some odd mothers who are currently being served, do you have like where they're located, the majority of them in the state?
I will defer to Dr. Polk.
They're actually all across the state. We have more probably in Hines and more in some of the rural communities. And as Dr. Edney said, we're contracting with nurses to help us with this program so that they can actually do the work and be able to refer them to the appropriate resource.
And I don't know what you call the individual that would go in the home, the case manager or whatever the title would be. Are these all registered nurses or what qualifications?
These are all registered nurses.
Okay.
And of course, we have social workers who, work in tandem with the nurses.
And I ask these questions because I think it's an amazing program. I would just like to see, it expanded till we reach a point that everyone who needs the services are provided those services. And I think what happens there, so important, especially for first-time mothers who don't know certain things. So thank you for that. My next question is around one of the slides. You talk about how there's early periodic screening and detection and treatment. I think that's very important for early intervention and things of that nature. What screenings do children 0 to 21 currently have access to? And how are we gathering data to see how many children are actually going through the screenings that are being provided for them?
First of all, I would say that's a Medicaid program. We are a provider. And so, as Dr. Edney mentioned earlier, we want them to have a medical home. And so when we can screen them, we're screening them, and they have all the various screenings based on their age, their hearing screening, vision screening, looking at BMI, which is your body mass index, looking at all those things, and then all the way up to age 21.
And is this screening process for those who have access to it and do all of the screens that they have access to, is that a good preventative care measure? Or is there a good ROI on what we're doing there?
I would probably say it's probably not used to the extent it should be. Some providers may not be doing the screening in the medical homes. We do it as we need to. So I would say if the uptake was increased, it would be a really good investment, not just for the money, but for moms so that they'll know to continue to do preventive care with their kids and for welfare. And that's why we want them in a medical home so that they can get their sick care and their preventive care as well.
Thank you for saying that, because I did have some data that says that we don't do a very good job in making sure everyone sees those screenings. And also, it seems that we only have access to, and this may be in the Medicaid world, you may not be able to speak to this, but it seems that we have access to Healthy Steps, but there are other screenings that we could be using that could view other things and could help for a preventative measure and overall make a healthier state and healthier children in this state. So thank you for saying that. One final question or one final area of questioning, family planning. I think you talked about preventative measures there and family planning and all of those types of situations. How do 60% of our children born are Medicaid, mothers are on Medicaid. How do mothers who did not qualify, the 60% who did not have healthcare insurance prior to this and were not on Medicaid, how do they get access to these family planning services, and how do they get access to preventative care and things of that nature?
Will y'all please speak in the mic a little more? They're
So
understanding they're not hearing us on the web.
Sure. So our intention is to do our public health duty of always trying to plug gaps where needed. We do see good partners coming online who will dedicate themselves fully to family planning, which we're fully supportive and will cooperate and collaborate. The community health centers, not only doing family planning, but providing a medical home, which is incredibly important for access to care. But we will be that provider of last resort. If Scott County does not have family planning services and the Hispanic population's in need, the Scott County Health Department will provide family planning.
And one final thing, I said that was my last topic. On this demonstrative here, it's talking about looked like it says state public health funding per capita.
Yes.
And so basically Mississippi is providing $15.77 per what?
Per person per year.
Per year. And of the states around us, we're a little bit above half of the lowest state around us. So how do we get to where we need to be, in your opinion, there?
The same way we did with education. We followed it. I mean, you're going to hear, my folks are hearing over and over, we're going to invest in success. I'm not just going to throw money to community partners without a ROI. If I have limited resources, that investment needs to pay a return for population health. And so follow what works. Our work in education, our state leaders, the legislature, the citizens of the state made a decision that we're getting off the bottom. And through y'all's leadership, y'all thoughtfully invested in education in a way that worked, got teacher pay rate up. You know, teachers in Mississippi make more than my daughter in Alabama. I tell her, come home and teach. So it worked. And now we went from the bottom up to the mid-30s. I think the same thing will happen in health. And public health has to lead the way. So I apologize for time, but when I was looking at our health disparity numbers and how bad our scorecard was, I started looking at why. It's not personal responsibility alone, because Alabama and Arkansas do the same thing we do. They don't have personal responsibility. So I looked, we had this with the same region, pretty much the same population demographics. We have the Delta, but so there's the Louisiana Delta and Arkansas Delta. When I looked at the differences, Louisiana and Arkansas have expanded Medicaid, Tennessee, Alabama have not. So that's not it necessarily, but I looked at public health investment, and that's where the glaring difference was. Everybody around us, if you look at the Commonwealth scores, they're well above us. Alabama is higher, Tennessee is higher, Arkansas, Louisiana, their scores are much better than ours. Their outcomes are better than ours. But look what they're investing in public health. And that is, we're talking about state dollars going into public health. Look, I think we've proven to y'all very well that we can perform our public health duties as you expect us to do it with what we have. What I am going to be begging for is make an investment in our ability to get us off the bottom with your help. Let's work together as a society. Your leadership, your support, will provide the elbow grease, we'll get our hands dirty, and I just know we can get off the bottom. And when that happens, there will be less dead mothers, there will be less orphans going to CPS and foster care, there will be less mothers grieving a dead baby, there will be less diabetics in the Delta with only 1 foot. The Delta has the highest rate of amputation in the nation. There will be less older women living alone because their husband died at 55 from kidney failure. These are all real things in our society. And I believe we can do it. As a physician, I'm not being naive. I know we can do it. Y'all proved we can do it. And I'm just putting forth the challenge. It's time for us to do it. And if you're willing, I am.
Thank you for taking my question. Thank you for your passion concerning these matters.
Senator Blackwell.
Thank you, Madam Chairman. Thank you, Dr. Edney, for you and your staff for being here. You spoke earlier about postpartum care, the importance of continuing that on, and you weren't here earlier, but we do intend to have a hearing later this fall on postpartum care.
Okay.
But I think not only the postpartum part is important, but also when can a woman start receiving benefits for her care? And we do have presumptive eligibility, but I believe it only you can only sign up in the ER. But would you agree with me that it's important for a woman to start receiving prenatal care somewhere early in that first trimester period?
The earlier it's very clear, the evidence shows the earlier she engages with professional prenatal care, the better our outcomes. And in my previous life as an addiction doctor, I took care of pregnant women with opioid use disorder. I remember the last one, and they all qualified for Medicaid. The last one, it took me 5 months. She was pregnant. It took me 5 months to get her active. So that meant, and I couldn't get anybody to see her. during that time until she was active. So presumptive eligibility makes a big difference. It's scary to have a high-risk woman not get prenatal care for 5 months.
Thank y'all so much. We really appreciate everything. So,
Thank you.
Thank you.
Thank you so much. Always available for you.
Director Snyder, if y'all go ahead and make your way up here. Director Snyder, we appreciate you being here with us today. Go ahead.
Well, Chairman Boyd, members of the committee, thank you for inviting me to participate in today's hearing. At Medicaid, we want every child to have the opportunity to have timely access to preventive care and necessary treatment that may improve their health and their quality of life. We want Medicaid's provider network to offer the same choices of quality health services, that our own children have, and those on commercial health insurance. And I can say from personal experience that the physicians, dentists, and other clinicians who treat my child also treat Medicaid and CHIP beneficiaries. In Mississippi, for the most part, we are fortunate that access to our young children in the Medicaid program is access to a good provider network is not that much different than it is if you're in the state employees health insurance program or a commercial program. It's not always like that in every state. And as a state, we also have a vested interest in healthy mothers and newborns. Unhealthy mothers and babies impose a cost on the entire community, squander human capital, and generate costs for treatments that often would have been unnecessary if mothers got the care they needed during pregnancy. We also have a duty to Mississippi taxpayers and American taxpayers to manage resources prudently. And I recognize government, if executed well, can be a source of good, but it's not the source of good. We realize that Medicaid has because of its cost and complexity, plays a hugely significant role. And we also recognize that we are partners, with a whole host, of other government agencies, other branches of government, other levels of government, and it, most importantly, private citizens, in determining the path, that our state will take. When it comes to Medicaid beneficiaries and their caretakers, the Division of Medicaid needs to do more to demystify the process. And I'll be the first to acknowledge that the division can do a lot more there. During the COVID-19 public health emergency that's ongoing and, before the COVID-19 public health emergency, a lot of our communications to beneficiaries have been clunky. And just because Medicaid is highly complex and Medicaid employees are well-intentioned, that doesn't absolve us of a duty to communicate clearly. I think it's also important to acknowledge some of the good policy work that's been done around women and children, in the recent past at the legislative level. Through legislative appropriations, the Mississippi Medicaid program spends somewhere in the ballpark of $500 million annually on pregnant women and children ages 0 to 3. In 2018, then Senate Medicaid Chairman Wiggins helped ensure a base rate increase for OBGYNs to 100% of Medicare, which at that time was among the highest state plan approved rates for that physician type in the country. That same year, the legislature also provided a mechanism to expand access to certain physician administered drugs as a medical or pharmacy benefit in an effort to drive more use of long-acting reversible contraceptives and long-acting antipsychotics. And before 2018, the legislature allowed the extension of expiring ACA provision that allows state Medicaid agencies to reimburse primary care providers at 100% of Medicare. This year, Senator Blackwell led the way on a new directed payment initiative for emergency transportation providers that should infuse $15 million into needed emergency transportation without impacting the general fund. My testimony today will be presented loosely in 3 parts. Initially, I will explain Medicaid and Children's Health Insurance Program as they relate to children under 3, pregnant women, and postpartum women, the criteria for eligibility, the benefits that are available, the delivery system options, and unique conditions during the COVID-19 public health emergency. I'll talk about what we see down the road for children and pregnant women in Medicaid, and I will try to provide you some other considerations as you move forward and answer any questions that you have. The division administers health benefits funded through the Medicaid and the Children's Health Insurance Program. Medicaid, as all you know, was established in the 1960s through Title 19 of the Social Security Act and mandates coverage for certain low-income children, parents, pregnant women, the disabled, and some elderly Americans. The Children's Health Insurance Program is a very similar program to Medicaid, but originated at the end of last century, is funded through a federal allotment rather than the open-ended financing structure of Medicaid. With CHIP in Mississippi, children up to age 19 with families of incomes up to with 209% of the federal poverty level who aren't eligible for other forms of insurance can qualify. And unlike Medicaid, which uses both the traditional fee-for-service delivery system and a managed care delivery system, CHIP is administered exclusively through managed care by 2 contractors. For the non-disabled, eligibility for pregnant women and children under 3 is income-based. The federal government uses an IRS standard called Modified Adjusted Gross Income, or MAGI. And for a newborn and a pregnant woman, the MAGI income limit is 194% of the federal poverty level, plus a 5% income disregard, or 199% of the federal poverty level. For a first-time single mom and her child, her countable family income can be over $36,000 annually. If the pregnant woman was married with 2 kids in her household size of 4, family income can be up to $55,236. One of your handouts includes the federal poverty level thresholds for Medicaid. For pregnant women, some women who become pregnant may already have Medicaid benefits because they are covered as low-income parent caretakers, which is a category of eligibility for a parent or a primary caregiver who has a child under 18 living in the home. less common. She could be a teenage expectant mother, already enrolled in a category of eligibility for children. But most for expectant mothers who aren't covered under Medicaid, she follows a relatively straightforward process. The applicant submits a Medicaid application. She can go in person to one of our 29 regional offices or 50 outstations. She can also submit her application online through the new common web portal. That's available at www.access.ms.gov. She can also apply through the federally facilitated marketplace, which has one single application for all insurance affordability programs. The marketplace will assess her potential eligibility and then return the application to the division for a final eligibility decision. Medicaid eligibility rules do not mandate proof of pregnancy. Self-attestation is sufficient. She is notified by mail and she has been approved by Medicaid. The notice indicates the expected delivery date that she's provided. And if she was also approved for family planning benefits that traditionally come after the 60-day full benefit program. That letter, also notes the date that her eligibility for the family planning waiver, the dates that those will start. Initially, the pregnant Medicaid beneficiaries enrolled into fee-for-service Medicaid. The beneficiary may also receive some retroactive months of Medicaid coverage if she meets income eligibility requirements for those months. So retro eligibility means that if you go to a Medicaid enrolled provider, but you haven't submitted your application or it's pending, that Medicaid enrolled provider can get reimbursed if the claims are submitted to the Division of Medicaid's fiscal agent for those months. Once the pregnant woman is enrolled in Medicaid, she's entitled to various types of medical assistance, prescription drugs, tobacco cessation counseling, EPSDT, if she's under a certain age, family planning services and supplies, FQHC services, freestanding birth centers, home health, inpatient hospital services. The list goes on and on. She can also be enrolled in the Healthy Moms, Healthy Babies program, formerly known as Premise, that Dr. Edney talked about. There's also, she can be enrolled in the SBIRT program, which stands for Screening, Brief Intervention, and Referral to Treatment. That's an early intervention approach that targets pregnant women with non-dependent substance use to provide effective strategies for intervention prior to the need for more extensive or specialized treatment. The benefits to a Medicaid eligible pregnant woman with full benefits are not different during the COVID-19 health emergency than they would be under regular conditions, unless we made adjustments that were emergency specific and would have applied across the board to other eligible populations or enrolled populations, within Medicaid during the PHE. Early in the eligibility period, the pregnant Medicaid beneficiary has 30 calendar days after the determination of eligibility to make a voluntary selection of managed care contractor. And the beneficiaries who don't make that selection within the 30-day time period are auto-assigned to a managed care contractor. And at the end of that period, the expectant mother would be placed in the Mississippi CAN program, which is our managed care delivery system within Medicaid that is currently administered by Magnolia Health Plan, Molina, and United Healthcare. A few years ago, we highlighted this selection process as a potential barrier. And I think there's a feeling that during pregnancy, pregnant, non-disabled pregnant women, Medicaid eligible pregnant women are a mandatory category for the Mississippi CAN program. So, with that, they're probably better served, getting them in sooner. We will take I think a good step in that direction to speed up the election process as we switch over to a new MMIS vendor in the coming weeks. We've looked at ways to speed up, that process so that it, takes, 30 days and not much more. But I think, it's important down the road that we look at, can we make some adjustments that may require federal approval, but can we get that selection at the point of application so we can go ahead and make those assignments and not lose a potential member month because someone is in fee for service, that we can have that seamless enrollment into the managed care delivery system. Pregnant individuals enrolled in Medicaid are entitled to continuous coverage through the last day of the month, in which a 60-day period beginning on the last day of pregnancy ends, regardless of changes in income that would otherwise result in a loss of eligibility. So when you hear 60 days postpartum, it's actually more like 61 to 89 days. That is for non-emergent, non-public health emergency conditions. During the public health emergency, which began in March 18th of 2020 and will continue until the federal Secretary of the Department of Health and Human Services allows the emergency declaration to expire, anybody validly enrolled as of March 18th, 2020 maintains full benefits until the end of the public health emergency. And then in normal circumstances, I will say this, what we see is about, after that 60-day postpartum period, about 80% are going to maintain some type of Medicaid coverage. 50% would be enrolled in the partial benefit family planning waiver. 30% are going to maintain another full benefit of category of eligibility. So that may be category of eligible, the low-income parent caretaker category, it may be a disabled category, it may be one of those children categories, the category of eligibility 73. You're going to see about 20% lose coverage. There are, because it's 194% of the federal poverty level, those individuals that are 100% or over do have another insurance affordability option through the healthcare marketplace. Subsidies and cost sharing reductions for the marketplace start at 100% of federal poverty. I ran some numbers back in June for Ambetter, who's the largest marketplace insurer, for a 28-year-old woman earning $18,311 a year. The most affordable silver plan monthly premium was $5.63 a month with a $150 deductible and an annual out-of-pocket maximum of $900. Now at around 199% of FPL, the most affordable marketplace plan was $82.63 a month with a $5,300 deductible and a $6,300 out-of-pocket maximum. But for those that are not interested in the full benefits coverage, and after that 60-day period under non-PHE conditions, they're going to be enrolled in our family planning waiver. And that is a partial, as I said, partial benefit category. I believe it started, correct. I will be corrected later if I'm wrong on this, early 2000s. Many of the enrollees are those postpartum pregnant women that didn't qualify for that full Medicaid coverage. But Many are also just individuals who are within the age range who need family planning services. Enrollment in September 2022 was 25,853. 86% of the enrollees are female, 14% are male. Family planning benefits include 4 family planning benefit visits annually, FDA-approved methods of contraception, laboratory tests done during an initial family planning visit for contraception, including blood counts and pregnancy tests, pap smears. Additional screening tests can be performed depending on the method of contraception desired and the protocol established by the clinic program or provider. Also includes drugs, supplies, devices related to women's health services that are prescribed by a healthcare provider that meets Mississippi Medicaid's provider enrollment requirements, and that can include oral contraceptive agents, topical patches, injectable contraceptives, birth control, implants, and finally contraceptive management, patient education, and counseling. Those benefits on the family planning waiver are matched at 90% by the federal government. The federal government also provides the regular FMAP that's 84% during the public health emergency will drop to approximately 78% when it ends. These family planning related services are a separate group that are provided as part of a follow-up to a family planning visit. So there's another set. There's another set there. We've seen overall enrollment in the family planning waiver, I think drop slightly over time. I would say that some of that though may be attributed to the continuous enrollment condition. In the public health emergencies, we've seen more women stay in those full benefit pregnant women groups, category of eligibility 88 or the extended coverage category of eligibility 88. For infants, you're also looking at 194% of the federal poverty level. Infants can also be eligible for CHIP. So there's going to be a small group that are from families with incomes too much for Medicaid, but still under 209% of federal poverty, and they can get that CHIP coverage. Unlike the pregnant women, infants are retro enrolled in managed care coverage. So they are given, but like pregnant women, they have that continuous eligibility for a certain period. For children, it's 12 months. So your child's born, mother's on Medicaid under COE 88. Child's going to be eligible for Medicaid. It's going to keep that eligibility for a 12-month period, even if income changes. My understanding is this was continuous coverage for children was put in Mississippi quite a while ago, and we were, I won't say we were among the earliest, but it has not been something that's been universally adopted across the board. They'll be enrolled in the managed care plans. They have an opportunity to pick a plan they can change after 90 days, and also should add for anyone that's in managed care, whether it's pregnant women, whether it's postpartum women in that 60-day period, or non-disabled children. They have from in October of every year, they have a 2-month period where they can switch to managed care plans. Now, at age 1, the Medicaid eligibility threshold drops from 194% to 143% of the federal poverty level. You're going to see some people that were above 143 and under 194, they're going to go to CHIP, but what you will see in overall enrollment after that we have to review initial eligibility every 12 months. We can sometimes do it automatically with, by running the information through, databases, and we can get a confirmation that establishes eligibility. If it can't be, verified several months before the eligibility period ends, we send out renewal forms and that they send back. But what we do see is before the public health emergency, I looked at January, January, May, I think it was in 2018. We saw about a 20% decrease in overall enrollment in Medicaid for those infants after that, in that 13th month, after that full year. And you see some that go to the CHIP program, but overall, you're going to see that drop to about 80% of what it was. What you'll then see several months later is the enrollment starts to creep back up because people realize, oh, my coverage lapsed, so I need to go back and fill out the paperwork and get enrolled. That concept is churn, and it frustrates health advocates everywhere because it creates that unnecessary break in coverage, and does create challenges with transitions to care. People that are eligible for Medicaid, we want them in Medicaid and staying current with their eligibility. Obviously, people who are ineligible, need to find other options. Infants and children in that 0 to 3 category can also be enrolled in categories of eligibility for, if they're disabled, if they're getting a Social Security payment, they can be, they would be enrolled in what we call category of eligibility 1. And then there's also a category for disabled children needing an institutional level of care. That this is referred to in Mississippi as the Disabled Child Living at Home Program, or our acronym DCLH. In some states, if you're in some discussions, if you're at a conference around the country, you may hear it referred to as the Katie Beckett waiver. We've got about 2,000 children currently enrolled in that DCLH category of eligibility. I think it is important to note that this is not just for special needs children, but for special needs children that meet that institutional level of care criteria, that they meet the criteria to be for nursing home admission or admission to an intermediate care facility for individuals with intellectual disabilities. Children who, for whom foster care, maintenance payments, or adoption assistance payments are made, they're also covered under Medicaid, and their eligibility is certified through the Department of Child Protection Services. Disabled children and foster care children have the option to participate in Mississippi can. Participation for eligible infants, non-disabled Medicaid eligible infants is mandatory. I will say, just touch briefly on EPSDT, or early periodic screening, diagnosis and treatment. Essentially has been interpreted to mean that a Medicaid beneficiary under a certain age is entitled to any medically necessary service. So while an adult might encounter a 6 prescription drug limit each month, children can utilize unlimited monthly prescriptions, but they do have to be prior authorized and medically necessary. EPSDT is a feature that's, I don't believe you see in commercial insurance coverage, and these Medicaid specific nuances like EPSDT are one of the reasons that we're not able to reuse commercial IT systems in Medicaid CHIP space, and it's also has really opened the door for medically necessary behavioral health services for children, and has paved the way for unique programs that address SED and and other conditions. We do have early intervention targeted case management that we fund that involves activities carried out by a case manager and enable a child 0 to 3 to gain access to needed medical, social, educational, and other services. We have seen about, we're looking at enrollment increases now above 150,000. I think one of your handouts will show, some of the changes since 2020. That the continuous enrollment condition of the public health emergency is largely, responsible for that surge in enrollment that we've seen in Mississippi and across the country since the beginning of the public health emergency. Public health emergency is currently slated to end October 15th of 2022, but the Biden administration is committed to giving states 60-day notice. We are obviously past that period, so there is some expectation that the PHE will be extended to January 13th of 2023. At that point, we might receive notice in mid-November. And I think we're probably looking at a coin flip on whether it will end at that point or the public health emergency will continue. Looking down the road, I think, one of the things that we are encouraged by is that, we're still we're finishing up we're about to enter into a new managed care contracting cycle. The existing contracts expire June 30th of 2022. We released a coordinated care solicitation late last year that really focused on elevating quality and really took a good hard look at the ways that we can drive improved outcomes and improved quality of life for Medicaid members. The internal feeling was that, the managed care program was at really an inflection point, and this upcoming contracting cycle would be, pretty crucial in seeing, advancements. And I will say this, the offers that we received this year were vastly stronger than what we got in 2017. And what's important about that is because the offers are incorporated into the contract, and when you make commitments, you're contractually required to keep them. That procurement process is still in a protest phase, so I'm probably limited in how much I can say. But what we're seeing here with using child health coordinators to work directly with members and their families to address gaps in care, outreaching a week after birth to provide education to mothers on newborn care, postpartum follow-up, well child visit recommendations, the AAP periodicity schedule. And one plan is going to do in-home visits during the first 90 days to moms enrolled, provide education about services and help select that primary care physician. Care managers that specialize in pediatrics acting as main point of contact to provide education and outreach, monthly, answering questions on the EPSDT well visit, trying to schedule immunizations and providing detailed information about what's available at each stage. I think what you're going to see and what we're encouraged by, and I think will be pretty critical during any readiness period, is the using some of these items that have been committed to the AI-based platforms that allow them to use claims data and other sources of data to identify women who are pregnant before Medicaid learns about that, to get to those interventions earlier, platforms to that specifically, address health disparities, specific interventions for communities of color. And we've also seen a number of other, similar but unique programs to help women and caregivers navigate the process and get connected to medically necessary care, group trainings prior to birth, and really some of the health literacy aspects that I think probably don't get discussed enough around healthcare. I did say earlier, I did talk a little bit about communications, and I think we'll kind of give you a little rundown of where we've fallen short on some of that. I've had a chance to look at this, and for most of the public health emergency, a woman, a pregnant woman she's making a notice letter, informing her that she's approved for full Medicaid benefits and then approved for family planning benefits only after a certain date. Often that date can be months in the future and outside the period of the end of the public health emergency. But then she'll get a separate letter informing her that she will maintain continuous enrollment till the end of the public health emergency. What we've encountered in some situations, I think where pregnant mothers who are in that category of eligibility 88 might not have eligibility under family planning after the postpartum period. They also got a letter that was sent out about their managed care transition. And what it said was Mississippi can, it's our managed care plan. And then it says you're being disenrolled from Mississippi can because of a loss of eligibility. Now, while that is technically correct, that during the public health emergency, you can lose eligibility for Medicaid, the continuous enrollment condition is in place and coverage will continue till the end of the public health emergency. That, that kind of nuance is not what we need. Our beneficiaries don't need to be able to have to parse out the difference between eligibility and enrollment. So, we're looking at ways, and not just as a patch for this particular issue, but going down the road, whether it's through the end of the public health emergency, but in the future, is how do we communicate about Medicaid clearly and help, as I said earlier, demystify a process that often is mystifying to the people that live it every day. I know postpartum Medicaid coverage is a big issue. It sounds like we're going to have a hearing on it. So, I'm happy to answer questions on that now. I'm happy to answer questions on that in November, but I'm also happy to give back some of my time to answer those questions or any other questions that you have. I would say right before I end, as you look at different interventions and pilots that are state funded only, that Medicaid may not be may not be the best spot for that because more than likely you're going to want to touch a broader population of members than just, the 60% of pregnant moms in Medicaid and the children that are enrolled in Medicaid. But we're obviously willing to work on anything, but I think, in grant type programs and those types of things, that is Medicaid getting a little bit out of its element. But we'll continue to look at ways to work with you and our agency partners on helping to create conditions for success for children and
Thank you for testifying. I'm going to start with, first of all, I want to thank you, and I want to thank you for talking about the issue with the letters that went out to the women. There was a testimony this morning already that those letters were rather confusing to the individuals, and you've acknowledged that y'all are going to work on that. One of the other things though that came up was there has been great confusion among our providers in the state. If they can extend coverage or not extend coverage. And so it was requested that we do a better job of explaining to the providers that coverage has been extended. And I'm sure this doesn't just apply to postpartum, but when coverage can be extended or what providers can actually cover, they ask for greater clarification on that. And that wasn't the first time I had kind of heard that this morning, because I heard it from pharmacists and I've heard it from other providers across the state, is great confusion on the extension during the pandemic for that coverage. So if that's something I could request, that we just continue to work on that communication. And that's a continuing theme from all agencies as we work out the state, is better communicating with the public on that. One of the issues that I continuously get asked about, and I think we've had some conversations and y'all are directly working on that, but the reimbursement issues that some of the physician administered drug list have, and I know y'all are continuously working on that. One of those is on the long-acting reversible contraception. There's some gaps in there that of what the physicians are, what the actual cost is and what they can get reimbursed for. Some of those are a significant gap there. So I think y'all looked at that last week and are told that we've been told by different people that we're looking at basically an 18-month to 2-year time period and kind of getting that adjusted. Is that something y'all are, is that about right?
Yeah, I think what was being discussed is harmonizing, pharmacy reimbursement, which is based on NADAC or AAC or this wholesale acquisition cost and the different methodology around some of the drugs that are reimbursed on the medical side. I mean, I think the catalyst has been put in place to help alleviate some of that. I thought it was interesting. Someone mentioned that the Department of Health is doing some 340B. It's going to get some 340B pricing, and that may help. Look, if to the extent that the pharmaceutical manufacturers are worried about the doctors getting their drug, I would tell the pharmaceutical manufacturers to lower their costs. I don't think that Medicaid is the role of Medicaid to put more burden on the taxpayers, because the pharmaceutical manufacturer needs to keep an outrageous profit. So, if they want to get coverage if they want to get their products in the hands of physicians to see it to work, there are samples and there are other things that can do that. I do think, though, that it makes some sense to look at how we harmonize, if it makes sense, to pay a pharmacy benefit and a medical benefit similar, and how that fits with some of the administration costs that go around the drug and that kind of thing. It may not take 18 months, but it also, it could take less, but we also could come back and say, we're not sure this is actually going to solve the problem that has been identified. On this, I think what we probably need to do as an agency is have some more conversations with, some of the ordering, referring providers and the physicians themselves to see, how can we get this in your hands? Are we utilizing the, available, pharmacy venue like we need to, or do we need to just really hike up the rates on the physician administered?
Director, make no mistake, I'm not here advocating on behalf of any pharmacy company. I'm advocating on behalf very clearly of the patients and the consumers out there, that when they go to their physician to try to get a LARC, they should not have to get a physician order to then go to the pharmacy and then bring it back to the physician. We need to make this, I agree wholeheartedly with our state health officer, that prevention is the key here. And when we have a product that is 99.9% effective, we need to be figuring out how we make that effective and easy for the consumers and the patients out there, because prevention is the key. So make no mistake, am I lobbying here on behalf of any pharmaceutical company? Now, my next question I have for you, since prevention is, I believe, so important. We have, when we see on page 14 in the information that you've provided us, we have a 41% decrease in contraception utilization. So I wondered if y'all had dug into those numbers to see why there was a 41% decrease in contraception utilization.
Yeah, most likely because many of the women that would have been in the family planning waiver that were getting contraception, in those prior years, were staying in a full benefits category and getting contraception there. I would need to go back and check. My understanding is that those numbers don't reflect the entire Medicaid program, but individuals who are specifically enrolled in the family planning demonstration.
Okay, I'd like to know, as y'all look into that, I'd like to have a further kind of report on that. Senator Hickman, I think you had a question.
Thank you, Senator Boyd. Director, yeah, I just have a couple of questions now. This may be my ignorance, but I heard you say that mothers who give birth or are recipients of Medicaid because they were pregnant, did you say that they were eligible to remain on Medicaid until the end of the health emergency or the crisis?
That's correct. If you were validly enrolled in Medicaid as of after March 18th, 2020, you're going to maintain your Medicaid coverage until the end of the public health emergency. At that point, we will redetermine eligibility again for the population. It's for everyone that's enrolled at the end of the public health emergency. We'll have about 14 months to do that. That's what's been referred to as the public health emergency unwinding. But yes, they'll maintain their benefits until the end of the public health.
And I guess my question is, you talked about the communication that went out, but was there a communication that provided this information to those who were receiving this coverage or the Medicaid providers so they're aware that they had this coverage?
I think when we have sent out notices about eligibility, you would get in those notice letters, there would be there's a part that says you'll like you are subject to, the word is either reinstatement or continuous coverage through the the end of the public health emergency, a follow-up letter will be sent in the coming days that provides that information, and then that's when that will come in. I will say that there was not, we did not do a big outreach campaign on this at the beginning because the expectation was that it was going to end pretty soon. I think the states that took this, the expectation was that this would be a short-term process, maybe calendar year 2020. We didn't think we would be here in 2022, still trying to guess how far we went into 2023. So I think, some of our, we've had to be careful because we don't want to we don't want to claim people are going to have coverage for longer than they're actually going to have it. If we send a letter that says, if we send a letter in, let's say October, that in June of 2020, that eligibility would, that their eligibility would end in November of 2020. Well, maybe at that point, there was still an expectation that the public health emergency was going to end. Look, I can look, there have been a lot of moving parts during this public health emergency, and we make decisions based on the information that's in front of us at the time. Some of it's right, some of it we would like a second chance on. I think in some of these cases, what we found was we had to retool our business rules on the fly, and when that happens, sometimes you get several parts of the system, and you make most of the changes you need to make, but you miss one, and so that's where.
So I guess my question is, I think you said that, you couldn't have sent out a letter that said your coverage is going to continue to June 1st because you didn't know. But I think in your testimony earlier, you stated that you guys would get either, I think, 90 days notice at when the public health emergency would be lifted. Could you guys not have sent something to providers and patients that said your coverage will continue until the end of this health emergency, and we will send you a 60-day notice or what have you at the point that this health emergency is going to end?
Yeah, the 60-day commitment from the administration came later on in the process, but I think that's a fair point. I think at this point too, we've got to look at, we've got the unwinding. The longer it's gone, it's going to be a challenge because people do know that they don't have that they have coverage until the end of the public health emergency, and as a result, they're not completing those renewals when it looks like what we really need. And we're looking at ways to how do we encourage this is the folks that know they're that are going to meet eligibility criteria, get them back in now so we can make those approvals and have that process smoother, in the event it does end in January of 2023.
Moving away from that mode of communication, there was a lot of numbers thrown out there, and I think you have accepted the fact that this is a very convoluted process, and there are poverty thresholds that change from time to time. And I think at some point you said that that sometimes people automatically are carried from one coverage to another after a child turns a certain age or what have you. What factors determine if that happens automatically? And if not, what does one have to do to get their coverage changed from one type of coverage to another?
So if yeah, if you want to be considered for a different category of eligibility, that's you can do, what we call a change reporting, and that's just contacted your the Medicaid specialist in the regional office and saying, hey, this has happened, and I need to be evaluated for this coverage. We also see some of that with disability related coverage. What I think I was probably talking about at that point was we do I think what they call is ex parte renewals, where you can make the eligibility determination based on databases and other sources that you run through and see no income, and you can renew for that additional 12-month period without having to go through the process of submitting more information. We're going to see some changes over the next, probably the next year. CMS, the Federal Centers for Medicaid and Medicare Services has put out a proposed rule that's going to change how some of the processes work with respect to how we maintain paperwork, but also how some of the communications go around renewals and other things. I haven't had a full chance to digest it, but and it's still going through that notice and comment process. But it also may change a little bit about how what we do and how we do some of these processes.
And one of the things you talked about when you talked about that is sometimes children move from Medicaid to CHIP. How does what's the eligibility for CHIP, and how does a child get on the CHIP program? What's that process like?
Oh, so you can have mixed families. Like we still get, we get new applications, and you'll have somebody that's you would have a situation where maybe the 1-year-old qualifies for the newborn qualify for Medicaid because they're at 194%, but then they're under you're in between one of those eligibility thresholds, because when you're 6, it drops to 133%. So you'll see some families where somebody will be in that separate CHIP one child will be in separate CHIP, and one will be in Medicaid.
And finally, I do want you ended by saying, and I think it's something that's been almost every speaker has talked about, is 12 months postpartum. What is your take on that?
So I think, it's a much different discussion than when you talk about it. Should we expand coverage under the ACA? Pregnant women were one of the initial one of the early pregnant women and children were really what's considered part of Medicaid's social safety net. And I think the legislature's had a lot of time to look at this. But I will say, I don't think it's unreasonable for somebody to want to look at this and make sure that before we permanently extend coverage or set this 12-month date, that we feel that there's a feeling that this will actually improve health outcomes and get you closer to where you want to go. I do not think postpartum Medicaid extension is going to be a panacea that gets us out of last place overnight. I think you also though have to look at, the potential problems around not doing it. Because if all of your southern partners, all of your southern neighbors are doing it and we're not, I mean, I do think that that's going to be cited as, even though it won't be the reason that, health outcomes are where we want them to be, it will absolutely be cited as the reason, the reason they're not. Because when lawmakers or governors don't expand, don't make things bigger, don't pay for something, don't increase the scope of government, that decision to say no is always cited.
So I'm sorry, Mr. Director, I really hate to cut you off. But we've heard from a number of health experts throughout the day. And I don't think a single one of them disagree that that this extension of 12 months wouldn't have a positive a positive outcome on health outcomes, particularly for women and children. So I guess the crux of my question is, what is your recommendation? Would you, as a director of this division, what is your recommendation regarding 12 months postpartum extension of coverage?
My recommendation is if you do it, you pass it soon enough in the eligibility in the legislative session that we can operationalize it by that, probably what would likely be a July 1 date. We're going to have to recode E&E systems. We've got to update the automated notices, which is a lot harder, than it sounds. And we've also got to, we need to update capitation rates, and probably look at some decisions if we are in an unwinding period, how we address some of those things. So look, this has been an issue that legislature has, I think, has a good understanding of, has opinions of, and I don't think it's going to help a whole lot one way or another for the division to weigh in here. Now on obscure items like whether we should what we want to do about Medicaid estate recovery if we get additional flexibility from CMS, or talk about reimbursement policy around ambulatory surgery centers. I think Medicaid may need to step in, but y'all have done, and to your credit, you've looked at and you've heard from a lot of people, and a lot of subject matter experts have said, this is a good idea. I don't think it presents long-term financial sustainability challenges of ACA, like ACA expansion would do. And I think, it clearly will lower out-of-pocket costs for, individuals that get those extra months. Do I think that, a shorter time period would probably have been, might be more in line with what ACOG recommended several years ago when they wanted to go from, this kind of, this more of the 6 weeks to 60 days to the, or I guess person-centered in the first 120 days. Would 6 months be better? I don't know. I do know that CMS has put, or not CMS, but the ARPA legislation gives us a 12-month state plan option. That is pretty simple. If you do something below 12 months, you're going to have to get permission. We're going to have to develop a waiver, get a permission from the Biden administration for that. Texas, has gone down that path. My understanding is they've gotten a little pushback because they looked at, there was some feeling that the way Texas drafted their legislation was that it would prohibit, women who had elective abortions from taking advantage of that 12-month time frame. So Now, I think, but there's still, some different considerations out there, but at the end of the day, we're going to implement what we execute. And when you set the policy, we try to put it in. One of the things, we want to be able to do is we want to be able to do that timely. We want to be able to do it well. And I do think that, one of the things that we need to bring up are things like this does have a sunset on the federal statute. So, do you want to set a sunset of 2027 for this and 115, put some language that gives you some open-endedness in the event that the federal government decides to, Congress decides to make this permanent. But now I do think it is a different, if you feel like that this, and if there's confidence, if there's, do this because if you do it, I would say, do it because you see, you think this will have a really good benefit, for moms and children. And I would say, don't do it because, you're getting pressure or you're getting accused of being, cruel and heartless if you don't consider, this, because this whole issue has become probably overly politicized when you could boil it down to just, a question of, all right, is more coverage at this time makes sense.
So I don't think I'm gonna get a direct answer of what I'm asking, but what I heard you say, two of the key points that I heard you say is that this is not the same as ACA expansion. And I also heard you say that if we're gonna do it in the legislative section, we need to do it fast.
Yeah, look, I don't, you have to be careful to get into all these semantics. And expansion means one thing, the dictionary, it means one thing around Medicaid. I mean, there have been the dictionary definition, we've seen expansions of Medicaid throughout time, probably every time a tech bill has come up since 1984. ACA expansion, that's a much different conversation, impacts a lot more people, and we're talking about bigger dollar figures. But yeah, I think if you're going to do it early, and yeah, I mean, I think you can make the distinction.
All right, Chairman Blackwell.
Thank you, Madam Chairman. Director, thank you for coming. You're right, we will have a hearing. We'll be asking some additional questions. Senators Hickman and Boyd hit on a few questions that I had, but I think you can tell from their questions, the communication from the department to providers and as well as beneficiaries is something that probably needs to be addressed or looked at. I saw those two letters, and it'd take you a minute for, I think, the normal person to digest the substance of those. But let me ask you, let me go back. If I recall the last Medicaid report for July, we were about I think it was about 817,000 beneficiaries, Medicaid beneficiaries.
That sounds about right. 816 Medicaid, about 42 in CHIP.
Yeah, I think it was 840 with the CHIP, I think. So, or maybe it was closer to 860 with CHIP. So, yeah. So, but we were about $30 million under expenditure. Is that correct? For this July versus last July?
That's possible.
All right. Well, I think there was we were 30 million under expenses, but yet when we added the CHIP folks, that additional 40 so thousand, we were about 40,000 over what we did. Can you explain or, and maybe you don't know, maybe this is a question for later on. I was just wondering, it's a huge amount of money that we ate up $30 million with those additional 40,000 CHIP members.
CHIP member, I'm gonna have to look at the report because CHIP members are usually, are not a
Huge cost to us, yeah.
Sure, we're looking at somewhere, yeah, probably between around $250 in a capitation payment for a CHIP beneficiary. So take that and multiply it by,
When I saw the numbers, I was just curious.
Yeah.
I was just wondering, you can get back to us on that. Let me ask you about presumptive eligibility, the timeline. I think you were here earlier when asked Dr. Edney the question about it. If I'm not mistaken, we have that ability, but it only exists in an emergency room. It does not exist in the family practice or OB office. Is that accurate?
Yeah, that's right. We have hospital presumptive eligibility after the Affordable Care Act. We haven't done the presumptive eligibility for pregnant women. I think it was set out in that one of those appropriate federal appropriation bills in the 80s.
And so you heard Dr. Edney talk about the importance of getting women on prenatal care as early as possible. And under our current system, what is it averaging before they get approved? Probably about 6, 8, 10, 12 weeks.
No, it's under, it's under a month. Hey, we're, my understanding is we're required by federal law we're supposed to keep a 45-day turnaround on MAGI terminations like one of those. So, yeah, pregnant women are generally shorter than some of the.
Well, that 45 days is going to be about 6 weeks, a little over 6 weeks. So
Pardon?
45 days is going to be 6 weeks.
Right, but yeah, we're, my understanding is we're under that with pregnant women, because this has come up, come up before,
Right.
desire to get these.
Do you see any problem if we were able to move that presumptive eligibility enrollment to the OB-GYNs and primary care?
I think presumptive eligibility is probably, it does create some operational problems. And look, I don't love the fact of, finding another avenue to put potentially ineligible into people on the Medicaid rolls. I do think though that, it may be something that worth having a conversation about, but do we really need to look at, are there some other ways to incentivize the OBGYNs and the provider community through value-based payments and other things to try to, see these patients earlier, because many of them are going to get, you are going to see those reimbursements. They're just going to come when if that retroactive eligibility gets established. And I know they don't, no business likes to run up a tab and risk not getting paid, particularly a freestanding clinic. But it's something that's not has never been recommended from our eligibility subject matter experts, but that's not to say it's not something that we shouldn't explore further and see if there's a responsible way to do it, to get people on earlier, and also, have proper safeguards to, we're not paying for people who don't qualify.
Thank you. I do have other questions, but I know others do, and we're running up against the other presenter, but thank you very much for being with us today.
Thank you, Madam Chair, and thank you, Mr. Snyder. I have a question about the portion of your presentation when you mentioned the children who fall off of, I guess, having available coverage. And your study dates back to 2020. I think you said maybe 20%. There's a 20% decrease.
This would be, we looked at, I looked at 2018, so this was before the public health emergency. In 2020, they wouldn't have, they were just maintained, they would have maintained full coverage because of the public health emergency.
And I was trying to, my notes may be a bit scattered, but my question is, you mentioned that there are several months you see that those statistics start to creep up. Are you in a position to monitor those children who have no health insurance after, I would say, 18 months? And which agency would be best in a position to identify those children who have no coverage? They're not recaptured by CHIPS or any other programs offered by Medicaid.
It's a good,
I can find, I can
yeah,
ask later, but I was just wondering.
Yeah, I'm not sure who would know. It's a small number because you're not over the number of uninsured children because of programs like Medicaid and CHIP. It's and our private insurance. I mean, most of the most do have coverage, but for that number that don't, how we could, that it would be, be ideal if you could make that identification, but just off the top of my head, I'm not sure who would be best to do that.
And in the past, I have requested, I would say, fiscal notes for the expansion of Medicaid. And I've seen that it's been referenced, the numbers or the data would be based on the Millman study or Millman report.
That's right.
And I think that there's a reference in your presentation or the documents presented to us regarding a contract or work provided by Millman up to 2021. Is that an ongoing relationship that that contractor has with the Division of Medicaid?
Yes, they're our actuary, and they set the capitation rates for managed care every year. And when we need to do one of these analyses that require the professional experience of an actuary, and they're excellent. We bring them in.
So is there, and I understand that Medicaid is coming later and there will be a hearing, but is there a reason in particular that if we're requesting data regarding the expansion of Medicaid, that data is only available based on a study from 2010 or years prior to now?
Yeah, you've got that. There was that 2012, I think there was analysis done in 2012. And then I think, yeah, Dr. Jellick's last year in 2017, they did an update, but yeah, I do, you would probably need to, there's more data on take up rates of people that could be eligible that are enrolling and those kinds of things, with more states expanding. So we would probably, I don't think there's I think some of that data looked at things over at 2017, and the earlier one looked at multiple years. But if I'm not an actuary, but they usually like to go back after time, and if their assumptions were off a little bit, they adjust based on the new information that's in front of them.
And so would there be an opportunity for, if I would say any group of the legislature is so interested, to request data that would date back to 2010, 2018, regarding statistics specifically related to women and children? We're not locked into figures from 2020 as it relates to expanding Medicaid postpartum, or any of the, I would say, the positions or recommendations that have been made earlier today are.
Oh, if you wanted to see postpartum data from 2016.
Sure. Would that be available?
Probably not. The way that, I mean, I'm not saying it's not something that we can, work with you on, putting the information together. We've been getting a lot of data information, requests, and Yeah, I say that because questions about pregnant women and postpartum pregnant women, we don't organize our data based on, are you postpartum, are you pregnant? It's based on category, like a lot of our reports and tools are based on category of eligibility. So we can look at one category of eligibility, but not all of those, women end up delivering, that there may be a miscarriage. And then you have other categories of eligibility too, where, so some of that takes, a little bit longer, and we want to make sure what we're giving is, accurate and validated, and not just, a draft that ends up getting treated as truth when there might be some question about the data.
Thank you.
Thank you, Director. We appreciate it. Dr. Matthews, if you'll come on up to the podium. Thank you. We appreciate you. We don't have time.
That one obviously doesn't work. So use that.
If everybody will come on back in, let's get to our seats. We need to stay on. I'm gonna keep us on schedule as much as possible. We're a little bit off schedule. Dr. Matthews, I think our stragglers will come on in just a second. So we're going to go ahead and get started. Dr. Matthews, I want to personally thank you before it starts, meeting with me over various meetings to kind of educate me on a number of things and provide information to this committee. So on behalf of all of us, I say an incredible thank you. Also for extending your staff for us to be able to learn some materials. So,
well, we are pleased to do it, and thank you so much, Chairman, for having me. Thank you so much for the whole committee for having me. This is it's an honor to give information that would help us in any way. So some of you may not know what Delta Health Alliance is, but I've heard the Delta mentioned a whole lot today. So I really appreciate getting the opportunity to stand up here and tell you what I know about the Delta. And this is Delta Health Alliance. We serve 19 counties in the Mississippi Delta, and there's a lot of dots on that screen. And all of those dots are projects that we do in the Mississippi Delta. And I promise you, I won't talk about all of them. I'm just going to talk about a few, but just as a little bit of context. Oh, wait, I did it this way. Oh, right back. This is too good. Okay, there you go. There are about 5,500 people in the Mississippi Delta. It's 19 counties. It's about 19% of the population of the state of Mississippi. I show you how many women and children live in the Delta, which is well over half. And yes, as you've heard before, childhood poverty is pretty bad in the Delta. But Mississippi is among the highest in teen pregnancy, and unintended pregnancy is probably our very biggest problem, as you know. But what I want to talk about is people that have children before they're ready are probably not going to finish high school. They're probably not going to have a good paying job. And they're very, very likely to require a lot of assistance from a lot of social service programs. And so as it's our biggest problem, it's our biggest problem for them, and it's our biggest problem for us. So to try to describe this, I want to show you your typical Delta female, okay? This is your typical Delta female, and she's born at 0, and she finishes college before 25, okay? The typical Delta female is going to make about $1,800,000 in her lifetime. And people like her, about 86% of people like this are going to stay in the workforce, okay? But if your typical Delta female happens to have an unwanted pregnancy, then she's probably going to make about $750,000 in her lifetime. And about 47% of people like her are going to even stay in the workforce. So this is why unintended pregnancy leads to lower workforce participation all the time. Only about half of moms who have an unwanted pregnancy finish high school at all. So we've also worked, when people say teen pregnancy, we think of that as 20 and below. So a lot of these people are in community college. And about 38% of women who get in community college drop out of community college because they're pregnant and they never go back. If these women were instead to finish their degree, they could put into the Delta and into the state tens of millions of dollars back into our economy. So it's really not the greatest thing for somebody to have an unwanted pregnancy for a lot of reasons, but this is a big reason to the whole state. Now we've talked about the mom, so let's talk about the child of that unwanted pregnancy for just a second. The children, you've heard a lot of things that happen to children on unwanted pregnancies and a lot of health things that happen to those. That will be about 75% more health expenditures than a regular child being born that wasn't an unintended pregnancy, that was a planned pregnancy. Those children that are born to that unintended pregnancy are 33% more likely to go to foster care, and they're 40% more likely to go to prison by the time they're 25 years old. So this is not good for the moms, it's not good for the children, and it's really not good for us. But DHA has tried to focus on teen and unwanted pregnancies, anybody below 20. We were able to do this through federal funding in about 14 counties. And over the last 5 years, the teen pregnancy, I know y'all have seen terrible numbers, but it's gone down 19% in those 14 counties, okay? Now, the really good or bad, however you want to look at it, thing about that is you see these really dark green counties up here. Senator Brian's kind of struggling, so I could move that a little bit. The really green counties are the counties where we were able to really go in and educate with very effective education with these students. We were able to go in and talk to them about contraception, and those counties that are dark green, the pregnancy rates went down even more. So that's the good news, is we could even do better. Now, we still had some problems. Even though we did good, I think 19% is good for those counties in 5 years. I think knowing what we could do to do better if allowed would be a good thing. It's a community by community decision. So it, you know, sometimes some communities we can't do those things in. But 36% in that project that we did over 5 years, 36% of the community college participants had a lot of difficulty obtaining any kind of birth control. So I think we could have been more successful if they could obtain birth control. Less than 8% of these folks, when we were doing family planning, talking to them about teen pregnancy, were able to choose long-acting reversible contraceptives. Okay, so that's not good, but they weren't able to, and some of them, this is a number over here that were ineligible because they couldn't afford it. They couldn't get it free. They couldn't afford it, but less than 8% got it because it's not easy to get. It's just not one of those things that you can just obtain easily, as I think y'all discussed earlier. Now, we've talked about this before, and I'm going to go through these pretty quickly, but a consequence of unintended births is preterm birth weight. It's low. So unintended pregnancies in the Delta, we're 13% higher than the national average in birth spacing because of these unintended pregnancies. So not only is preterm birth rate bad for us, but we also are 13% higher than the national average. Unintended pregnancies, there are likely to be people that deliver and have bad birth spacing, if that's a way to put it. And this is kind of what it looks like in Mississippi, but it's a predictor of bad birth spacing, which is something I don't think you've heard quite yet. We talked about how expensive low birth weight and preterm births are. I don't know, it depends on the hospital, but if you've got a low birth weight preterm baby, you can average about 55 days in the NICU. Now, that's expensive. And just the birth alone, just the situation with the birth alone, we estimate to be a little over $131,000. So as we talked about before, it's very expensive. Infant mortality, you've heard these numbers before, but what I want to tell you is it is a key economic health indicator. So if you go into any county in the state or any town, if you go into Oxford, if you go into Pascagoula, if you go into Amory, I don't care where you go, and you hire a health economist, and the health economist comes into town and you say, okay, tell me what my town is going to look like. Tell me what my county is going to look like in 10 years. The very first question that health economist was asked you is what's infant mortality. So this is bad for moms, it's bad for babies, and it's bad for us. It's really not a good thing. And so it's a huge, huge indicator of economic health. So it's sort of an endless cycle that we can't really get out of. And again, that's kind of what the state looks like. Y'all have seen that. Uninsured people, you know, we've talked a little bit about that. Uninsured women are less likely to receive postpartum care. I'll talk about that again in a little while. You know, they have all sorts of problems because they don't seek the care. They don't have prenatal care. They just don't have any of the care that we need, right? If they're uninsured. You've seen this before too, but just allow me for just a minute to give you the landscape. In the Delta, we've got over 4,000 children per pediatrician. We've told you the numbers are low. People before me have told you the numbers are low, but 4,000 per pediatrician. You've also got about 2,000 per pediatrician in the state of Mississippi. So the Delta's got about 20% of the state's children that live in the Delta. We got about 10% of the pediatricians. That's tough. It's tough to handle all those things y'all have heard about all day when you just don't have that. OBGYNs, again, we've got about 2,700 women within birthing age to an OB. State of Mississippi's got about 1,900 average. I think that little picture's covering up. The average for the US is about 1,500 per OB. So 10 of our 19 Delta counties doesn't have an OB at all. That increases maternal deaths. It causes, as you've heard, all sorts of problems. And there's the hospital situation that you've all been aware of. People have told you, so I'll just kind of sort of click through that because you've heard that before hearing it from me. But before I go to the next slide, I want to tell you that that's the landscape that we have in the Delta, and it's the landscape that we have in Mississippi. I'm not here to complain about the landscape because there's absolutely nothing I can do about that. So what we've sort of done in the Delta is said, okay, what are our advantages? What can we do? Instead of sitting around whining about what we don't have, which kind of, you know, nobody really likes that, right? So what we have in the Delta, I mean, most people in the Delta don't say, I'm from Clarksdale, I'm from Greenwood, I'm from Greenville. They say I'm from the Delta. Just like most people on the coast don't say I'm from Pascagoula, I'm from Biloxi. They say I'm from the coast. You know, that's. But I mean, we're a very community-driven group of people, not only in the Delta, but in the state of Mississippi. And so because we're community-driven, we thought, well, why don't we play to that strength? So what we've done is, due to this unique landscape, we have trained a lot of community health workers. I'm really proud of the state for trying to come up with an accreditation for community health workers for community colleges. We've really accessed that, and we have put community health workers in almost 4,000 homes in the Delta. What do they do when they get there? We talk about prenatal care. How do we get prenatal care? What's the problem? Is it transportation? What are you eating? Are you smoking? Are you drinking? All of those things. I don't have to have a nurse tell me that. A community health worker can tell me that. And when we looked at what people listen to, at least in the Delta, they listen to mother first, preacher second, doctor third. And we did a big study on, okay, who are they going to listen to? Because we got to have somebody that they'll listen to. So the community health worker sort of serves as a mother role. Now, they might not only talk to the female, they might talk to the mother. We've also found that this is very important that this person stay a minimum of 12 months postpartum, because there are a lot of issues if they don't. This is a federally funded system. The feds came back and says, please stay longer postpartum. Sometimes we stay 18 months if it's necessary. We've spent, these have been, well, let me tell you the results. So preterm birth has gone down over the last 5 years about 17%. Low birth weight about 32%, very low birth weight about 21%. That's a pretty nice decline. I mean, was it low hanging fruit? Yeah, we're the worst in the state, but that's still a pretty nice decline just because these community health workers went into the homes and helped. And I think that's a pretty good thing. We spent every year about $750,000 on this. The projected savings cost that we had through our statisticians is about $11 million a year. That's a pretty good return on investment. If you took that across to all at-risk people in the state of Mississippi, it would probably be about a $98 million savings. It's not a ton of money, but it's not chicken feed either, right? So let me go back just a minute. We've got that problem. We've got preterm birth. We've got what's going to happen from a health perspective to the moms and the children. And I've sort of told you what we try to do about that. Now, the second problem is, or the second issue is the baby's born and then what happens? Well, if the mother is going to go to work, then the baby's got to have childcare. So we have taken over through federal programs, a lot of health Head Starts in the Delta. We have almost 7,500 children in early Head Start and Head Start in the Delta. Our waiting list right now is over 1,500 children. We project with the projections of children that will probably be born next year at a higher rate than they usually are born, a 26% increase in that waiting list. Now, this isn't the state of Mississippi's problem. It is a Head Start problem. But we and our southern neighbors get less Head Start seats than anybody in the country, and we probably need them worse. Again, I don't think the state legislature can do anything about that, but some advocacy in some capacity could really, really help. But that's what we're looking at from a Head Start perspective and a childcare perspective. Now, what we do when they come into the Head Starts is we do this wraparound service, because mother, baby, everybody in the family of wraparound services. And why do we do that? Because the mother's just had a baby. They don't really understand financial literacy issues. A lot of people don't even have a checking account, never heard of having a checking account. Workforce development is a big part of those wraparound services. We can keep that baby even for the person to go to workforce development. A lot of times those vouchers I was hearing about earlier in a testimony, you know, that you have to be working to have that. Well, you can't be working if you don't have workforce development. So it's sort of an endless cycle. So we help keep the baby while they have workforce development issues. If they've got health issues, we go there. Any kind of legal, economics, family resources. You know, sometimes the child will come in and fall asleep in the middle of class and we don't know what's wrong. So we send one of those community health workers back out to the house and we find out, well, the child's exhausted and not doing well because they slept under the kitchen table last night because there's a lot of drive-by shootings. So those wraparound services try to say, okay, let's try to get you in a better housing situation. And that helps the whole family. So what have those results been with our Head Start communities? Well, childhood poverty in the Head Start communities have gone from 63% to 27% since 2015. That's pretty good. Our parents in the labor force have gone from 72% to 89%. That's not too bad either. So I think the wraparound services really work. They help the children, they help the parents. But another thing that sometimes we overlook is if you see over here to the far right screen, the children's test scores go up significantly. This is 2020 and 21. That was in the middle of COVID, so I really expect them to be a whole lot better than that, but I can't show you those numbers yet. So y'all have done a great job. You've put third grade reading as an important thing. You put early learning collaboratives as an important thing. Children need to be reading by third grade. I will guarantee you that everybody comes out of this Head Start, when they go into kindergarten, they're picking up a book and reading it. They can tell their ABCs. They're way ahead of the game. And so if those children are way ahead of the game, then not only are the parents in the workforce, but these kids are 44% more likely to graduate from high school. They're 23% more likely to have a job still by age 40. So they're staying in the workforce, and they're 53% more likely to stay out of the justice system, period. So the economic impacts of high quality preschool are very, very substantial. I've also tried to run some numbers if we did that, if we could do that with more parents, what that would mean as income, you know, to the economic system of Mississippi. So, you know, you didn't ask me what I thought we should do, but since I'm here, I can tell you what I think we should do. Head Start is like school, and so it ends at 2:30. One of the biggest problems we have with all those parents who have been able to get in the workforce, if we could expand those hours to 5:30, then parents could do more of a job. And I'll give you an example. The owner of Double Quick came up to me and said, what can we do? Because I'm trying to promote this woman from this job to a manager's job, but she's got to stay at work till 5, and she can't take the promotion because she has nothing to do with her children. So that would really help. These maternal home visits, led by these community health workers, are very successful. And healthcare providers, I agree, they're in short supply, but let's do what we can to still help those visits. I think we should expand successful evidence-based pregnancy prevention programs. I think those could be expanded, and they could, I think, do a really good job. Increase in access to long-acting contraception is critical. Part of the issue we found is that medical and nursing staff in rural areas aren't trained to administer long-acting contraception. And then there are some significant barriers to the long-acting contraception. So I think those things could, are they perfect and they could fix everything? No, but I think they could get us a long way down the road. So that's.
Thank you. I want to pick up and go back to the community health worker. We've been at some things, and I know a lot of other states are choosing to use community health workers as opposed to RNs or social workers, because they believe that they have more of a rapport and efficacy in the home. So talk a little bit more about that, because they're also less expensive as a state. If we chose to do that, they're less expensive than the cost of what an RN is right now, given the work market and the workforce that we're in.
Right.
And so I'm kind of a little bit more interested to see what could be done to kind of for us to relook at that in the state.
So, the state of Mississippi, the health department has just credentialed, this curriculum for community health workers. We're churning out as many as we can. Vanderbilt started a system like this about 10 years ago, I think. And it was because there's been a shortage of RNs for a long time. I mean, it's worse because of COVID, but I can't hire an RN in the Delta. I mean, to send an RN into a home, to me, is virtually impossible. I can't do that. So for a community health worker, the other thing is, at least from my experience in the Delta, I told you people listen to mom and preacher and doctor. They're more likely to open up. The community health worker has been trained, but they know that person. They're going to open their home and let that person in their home, and they're going to listen to what that person has to say because they trust them. It's a community person. We never hire someone from a community 100 miles away to come into this community and do work, because the person doesn't know them and they're not going to let them in the home. So they listen to them. Now, are they clinically as well trained? Obviously not. But it doesn't take somebody heavily clinical trained to say, hey, you need to lay your baby on its back. Giving fried chicken to a 6-week-old is not a good idea. That doesn't require heavy clinical training. To say, I know you're frustrated, but shaking your baby, throwing it against the wall is not going to result in a good thing. So let's get all the women in this area that have just had a baby, and let's get the community health workers and form a little group so that when you're frustrated, you can call your neighbor. Or if you have trouble getting somewhere, taking the baby to the doctor, we can do this as a community. That doesn't require a lot of clinical expertise. We had one woman, and this is just a community health worker, but this one woman had been to the emergency room in Greenville twice, and they were going to call DCS and take her baby away for lack of thriving. And she had been in the emergency room, which was probably about a $5,000 visit every time she went. And there's no telling if DCS had taken her child what that would have cost. So the people in the emergency room at Greenville had heard about our community health workers, and they weren't that far away. So they called one of them, and they came to the emergency room, got the woman, took her home and said, okay, let's talk about this. What's going on? And she said, well, and she was very upset. She said, I'm doing everything I can to raise my child, and it won't thrive, and I don't know why. So they talked about it. Well, the doctors had told her to double the formula. And so they said, go from a 4-ounce bottle to an 8-ounce bottle, which she had done exactly as she had been told. What they failed to tell her is when you go to a 8-ounce bottle, you put 2 scoops of formula in instead of the 1 that you would put in when you did the 4-ounce. This poor woman just didn't know. Nobody told her. And they might have thought she should have known. One would think you should know, but she didn't. The community health worker was able to figure that out. That doesn't take an RN degree. That doesn't take, it does take somebody that understands when they need to refer that person, but at least it's a frontline person that doesn't take a lot of clinical experience. You can do that without being a nurse or an OB or whatever.
Senator Kirby.
Thank you. I got one question. On slide 20, you said, or it says, a projected increase in births of nearly 1,000 per year in the Delta. I'm a little confused because the Delta's lost 65,000 people in the last 10 years. They're having a lot of babies if they're having 1,000 increase and losing that many people at the same time.
Right. Well, and you saw the first slide. I can go back to it, but it showed that we have a little over 5,500 people in the Delta now, but not quite 3/4 of those people are mamas and babies, and a lot of them are babies. There's a lot of babies in the Delta. Yes.
It really is. If you're losing that many and having 1,000 increase over each year. Wow. Okay, thank you.
Yeah, and that goes back, I think, to some of the data you've heard from the health department about the number of babies they expect to increase in the state of Mississippi this year.
Thank you. Dr. Matthews, what's the qualifications for a community health worker?
There are qualifications. The health department has set a list of qualifications and courses that that person has to pass. And then there is a certification when they pass those courses, and that you can do one of two things. You can have a certification through a community college, or you can have a 2-year degree, but you can get the certification first, begin to work, and then work on your 2-year degree.
Thank you.
Senator Hickman.
Thank you, Senator Boyd. Just a couple of questions. One is around long-acting reversible contraceptives. You say eliminate the remaining financial barriers. What are currently the financial barriers to women receiving long-acting reversible contraceptives?
Well, the uninsured women simply can't afford them. So that's one of the barriers. The other barrier is, I hope I explained this correctly. It's financial, but it's not. If you are insured, let's just assume you're insured for a minute. Maybe you're a Medicaid patient. You have to go to the pharmacy and get the contraception if the doctor knows how to implement it. I mean, sometimes the doctors haven't been trained, and only the OBGYNs are allowed to do this in the state of Mississippi. They have to go to the pharmacy, get it, if it will be paid for, and then they've got to take it back to the doctor's office and get it put in, which that's a big time lag. I mean, depending on what the doctor's waiting list is, that could be a time lag of, I don't know, a couple of 3 months. And it might be a moot point at that point.
And they're having to have several visits to the doctor because they're having to get prescribed this at one point, go to the pharmacy, get it, and then get back on the doctor's schedule.
Correct. Yes.
Now, I think you alluded to some of the results regarding, women who are able to work through that process. How effective are these contraceptives, and how beneficial is it? What's the return on investment?
Well, long-term, long-acting reversible contraception, they come in several different forms. The least lasts about 3 months, and there's one that lasts almost 4 years. From the research that I have read, they're over 99% effective.
And one final question back to some points that I think Senator Boyd and Senator Blackwell asked you about. Now, these community health persons or what's the
Community health workers.
community health workers, they remain there, I think you said from 12 to 18 months, but they're assuring that these parents as well as the child are making it to their appointments, making sure they have these things scheduled. How effective is that within the community? Just that piece itself?
That piece itself is very effective. And we actually, when we started doing it, we're doing it 6 to 12 months after birth. And the federal government refunds this program every year. And it was so successful, they asked us to go from 12 to 18. Because so many things happen postpartum that could be a significant issue that we've been asked to stay longer.
And finally, the programs that you have, are they only within the Delta region, or are there programs that extend beyond that to other areas of the state or what have you?
We just do the Delta. That's a lot, but we just do the Delta, 19 counties.
Thank you.
Dr. Matthews, we have just a few minutes, but you shared with me a program that y'all had done in Clarksdale. I believe it was Clarksdale with third grade reading day.
Leland.
Yeah, Leland. Would you please share those numbers with the committee? I think there's a few committee members up here who would be pleased to hear that.
In Leland is 100% free lunch community. And third grade reading is obviously very important. If you just looked at statistics, a community that is 100% free lunch, poverty is related to those reading results, okay? And they should be about the 89th school district in rankings of passing third grade reading or doing well, but they should be 89th. So we went in with the program that we have in Leland. And those students last year were third in the state of Mississippi in third grade reading. And so we were really very proud of them. Those students can read. And the great thing about it is they know they can do it. And I don't know if I can mention who they were behind, but they were behind some pretty good school districts, Madison and Oxford. And they came in third. And I mean, we gave them a party. I mean, they were so excited that they could do this. So it can be done, and it can be done with students that are in dire poverty. They can read. So we were really excited about that.
Thank you so much. And I'm sure we'll be back with questions specifically in regards to the Delta. So thank you very much.
Thank you.
Appreciate it.
Thank you.
Ms. Johnson, are you ready? Can you hear us?
Yes, I can now. Thank you.
Thank you so much. This is Ms. Johnson. She's the director of the NCSL Health Program, and we are so pleased to have you today. I'm sorry we're running a few minutes late, but we look forward to hearing what you're going to say in state policy trends.
Absolutely. Well, thank you, Madam Chair, and thank you to the committee for inviting NCSL to be here today. Again, my name is Tara Johnson, and I direct NCSL's health program. While I'm standing in today for my colleague, Kine Nguyen, she manages our maternal and child health portfolio. I do have 15 years of state policy experience and have focused a majority of that time on maternal and child health and public health. So very excited to be here with you all today. I'm going to take just a moment to tell you all about NCSL, and then I'll take a bulk of the 20 or so minutes that I have to share legislative state policy trends around maternal and infant health. And I'll share a few recent federal actions that we've seen and some NCSL resources for your awareness. So about NCSL, we're the country's most trusted bipartisan organization serving state legislators and legislative staff for more than 40 years. We promote policy innovation, create opportunities for lawmakers to share knowledge, and ensure that state legislatures have a strong and cohesive voice in the federal system. We do this because we believe in the importance of the legislative institution, and we know that when states are strong, our nation is strong. So NCSL is the only organization serving all 7,383 state legislators and more than 25,000 legislative staff. Our services include research. We track more than 1,000 issue areas. We cover topics including criminal justice, education, employment and labor, fiscal policy, transportation, along with health and public health. We also bring together legislators and legislative staff from both sides of the aisle to tackle and discuss difficult problems and find reasonable solutions. We provide professional development tailored specifically for state legislators and staff. And many of this professional development, these opportunities are provided at no cost to you or your state. NCSL also provides a state voice in DC. NCSL advocates in Capitol Hill on behalf of all states, fighting against preemption for the 10th Amendment and maintaining federalism. We have 8 committees, such as Health and Human Services, very similar to how states are made up. And then lastly, and very importantly, we provide a lot of meetings for state legislators. We create regular platforms for leading discussions on some of the very pressing issues that states are facing. Many of you have probably heard about NCSL's Legislative Summit. It's our annual meeting that's very large, but that's just one example. We have more than 100 policy-related meetings during a typical year. So with that, I want to start off talking to you about state policy, legislative trends and examples, but I do want to make clear that NCSL does not advocate for or against any state policies. We are sharing these examples and policy levers that have been moved in states based on findings and recommendations within those states. And some of these are recommended by national experts. But again, I'm sharing these as examples. We have seen a steady legislative increase in interest in this topic area over recent years. So in the 2021 and 2022 legislative sessions, we tracked over 120 bills enacted in 37 states and DC related to maternal and infant health. Some of the policy levers that we have seen over the last several years include postpartum coverage, infant and maternal mortality review committees, studies and work groups, looking at scope of practice, payment or licensure, especially around midwifery and doula care. And then there's been a very strong interest in improving maternal mental health, among many other policies that we have seen. So while none of these, not all of these have robust data available at this time, but again, many of these policy levers have been recommended by experts like the American College of Obstetricians and Gynecologists, other research institutions, or again, are based on findings and recommendations at the state level when reviewing their maternal and infant deaths, for example. Earlier today, you heard about maternal mortality review committees. These are considered kind of the gold standard by CDC and perinatal experts in terms of identifying and reviewing maternal deaths. And they are best positioned to make recommendations to prevent similar deaths within the state based on the state's data, context, and needs. So I will share related research and recommendations by experts associated with these levers as we go along. I know you all heard about this earlier, so I'm not going to take any time talking about postpartum Medicaid coverage, but I did want to highlight we have seen a lot of legislation in this area and other state efforts around state plan amendments related to extending postpartum Medicaid coverage. We do have experts at NCSL who know a lot more about this, and so if you do have questions, please feel free to reach out. States routinely pass bills or resolutions to bring awareness to and call to action on maternal and infant health. In 2020, Kentucky designated January 23rd as the Maternal Health Awareness Day. In Missouri, this year, created an annual Black Maternal Health Week. We've seen several other states create either weeks or days specifically around Black maternal health. All 50 states, DC, Puerto Rico, and several large municipalities have some form of a maternal mortality review committee, and at least 28 states have a fetal infant mortality review team. These multidisciplinary teams use data from examining the underlying causes of death within their state and provide specific recommendations for reducing maternal and infant deaths overall. Some studies have shown that maternal mortality review committees, for example, could reduce maternal mortality by somewhere between 20 and 50% due to the number of deaths that are considered preventable. So some states recently have revised provisions related to their review committees to bring in other experts, clarify their powers, or require specific reports to the legislature, and in some case respond to emerging needs or identified gaps in data and care. So last year, Georgia, for example, required healthcare providers, facilities, and pharmacies to provide the committee with access to records within 30 days of a request to help speed up their process. This year, North Carolina required the committee to include community representation, specifically communities that were most impacted by maternal mortality, and they increased the membership from 9 to 20. We've also seen states revise the scope of their existing committees. So for example, Nebraska this year added the review of stillbirths under the Child and Maternal Death Review Act. And South Carolina last year passed a budget bill requiring the Department of Health and Maternal Mortality Review Committee to develop a method of evaluating the effectiveness of 12 months postpartum extension, which was also approved within that same bill. We've also seen states commission temporary work groups or specific reporting to inform the policy work as gaps in data were identified. For example, this year, Louisiana created a study commission on maternal health and well-being to research and make recommendations on connecting pregnant women and new mothers to resources, particularly in rural and underserved areas. And Minnesota required a biennial report on the effectiveness of state maternal and infant health policies and programs addressing health disparities in prenatal and postnatal outcomes. The next trend I'll touch on relates to midwives and midwifery care. This includes actions around scope of practice, licensure, and insurance coverage. So some of the policies I'll touch on that we have seen states look at relate to certified nurse midwives who have medical or nursing training, or they may look at direct entry midwives who do not have a nursing degree but are trained in deliveries for healthy or low risk pregnancies. Certified nurse midwives are licensed to practice in all states, and direct entry midwives are regulated in at least 35 states and DC. States have expanded access to midwives to address perinatal workforce shortages and to provide access to care in rural areas and underserved communities. Studies in the Journal of Obstetrics and Gynecology and several systematic reviews of international data found that trained midwives can provide comparable care and or benefits such as lowering non-emergency C-section rates or lower preterm birth for healthy or low-risk pregnancies. which can save on healthcare costs. Arkansas last year provided full practice authority to certified nurse midwives, removing the requirement for a collaborative practice agreement under a physician when practicing in defined and approved authorities related to prescription schedules and deliveries in accredited facilities. They join about 28 other states where certified nurse midwives have full practice authority. In 2020, Oklahoma provided licensure for direct entry midwives and created an advisory committee on midwifery. And then last year, Louisiana required insurers to cover state licensed midwifery care, including certified nurse midwives and certified professional midwives. We've seen a lot more bills related to doula care and coverage in the last few sessions. At least 20 states have passed legislation related to doula care. Doulas are trained non-medical professionals who provide physical, emotional, and informational support to mothers before, during, and after childbirth. As the previous presenter shared, doulas can be considered community health workers. Increasing research has shown that support for doulas is linked to better health outcomes, such as lower C-section rates, lower probability to have low birth weight babies, and increased maternal satisfaction during labor and delivery. In particular, pilot programs have found that doula care helps decrease health disparities by race. And this is particularly true of programs that are focused on community doulas who come from the same community as the pregnant woman. So some examples of recent legislation that we have seen. Last year, Tennessee recognized doulas as both vital childbirth team members and community health workers, and acknowledged their contribution to ending the maternal and infant health disparities. Several states are taking steps to consider reimbursement for doula care. For example, establishing certification, registration, or boards to determine the infrastructure for covering doulas, who again they're non-professional, non-medical professionals. So Arizona last year established a voluntary state doula certification program. Last year, Louisiana created a doula registry board to determine rules for doula registration and reimbursement. And then this year, Indiana created an advisory board to determine reimbursement rates for doula coverage. And Indiana had previously approved a Medicaid coverage for doulas. I think that was in 2019, but it has not been funded or implemented yet. So they created this new advisory board to help determine reimbursement rates for implementation. And I'll just highlight this map here to show you that at least 10 states have legislatively approved doula Medicaid coverage. 3 states have approved Medicaid coverage for doula services through Medicaid managed preventive services, so not through legislation. And then at least 4 states have pilot programs using some type of Medicaid funds or Title V funds to look into this. Next, I will share a few examples of laws specifically looking at maternal mental health, which is a top cause of postpartum complications as identified by many state mortality review committees. An earlier speaker from the University of Mississippi Medical Center also shared this as a top concern for Mississippi. As you all have heard, maternal mental health impacts bonding with the infant, ability to care for an infant, and healthy work reentry. Some studies published by the NIH and the American Journal of Public Health have estimated the economic costs of untreated maternal mental health conditions can be roughly $32,000 per pair, so per the mother and child, from conception to 5 years after delivery. One other study found that women who experienced depression and anxiety reported worse health at work reentry, and women who experienced medical problems during pregnancy were more likely to report poor health at work reentry. A few state examples I'll highlight. Georgia this year recognized Maternal Mental Health Day, citing that perinatal mood and anxiety disorders are the most common complication following childbirth in Georgia. Last year, Arizona created the Maternal Mental Health Advisory Committee to recommend improvements for screening and treating maternal mental health disorder. And Louisiana required, this year, they required all hospitals and birthing centers that provide labor and delivery services to provide pregnant women and their family members information about perinatal mood and anxiety disorders, including information on symptoms, treatment, and available resources prior to their discharge. And a few other interesting examples that I will highlight for you. Maternal risk screening is one area we've seen some interest in. West Virginia this year required physicians, midwives, and other healthcare practitioners to use a uniform maternal risk screening tool to help discover at-risk and high-risk pregnancies. The screening is to take place at the initial pregnancy exam and to help refer the woman to a specialist after identifying any condition, and also to report results to the state. Breastfeeding support is another area we've seen a lot of bills in over the years. There's a lot of research on the benefits of breast milk for infants and for supports for new mothers after giving birth. And I'll just highlight that Louisiana passed 2 bills this year that require public and private coverage for human donor milk when prescribed by the doctor. And I'm sure you've all probably heard and seen a lot of interest around treatment for co-occurring disorders. Oregon is using opioid settlement funds to finance programs that use evidence-based or informed strategies to treat pregnant women with opioid use disorders or co-occurring mental health conditions. This year, Georgia established a rare disease advisory council to make recommendations on newborn screening and a genetics advisory committee on rare diseases. This includes policy recommendations for new disorders to screen for, as well as recommendations for increasing access to specialists, healthcare coverage, treatment, and telehealth services. And then the last one I'll touch on this slide here relates to plans of safe care for substance-exposed infants. This year, Pennsylvania established a task force on the opioid abuse epidemic's impact on children. And this task force will focus on improving the safety, well-being, and permanency of substance-exposed infants, as well as young children affected by parental substance abuse disorders. The task force will also ensure that the state is compliant with identifying substance-exposed infants and will be developing multidisciplinary plans of safe care for those infants. I know we're short on time, so I won't take much time here sharing what we've seen on federal action, but I did just want to highlight that Congress did pass several bills with bipartisan support that provide funding and provider training to improve maternal health across the country, with a focus on investments for communities of higher need. And the bills do address disparities by race and ethnicity, as well as have a focus on rural residents and veterans. So the last thing I'll share here are NCSL resources. We have a lot of resources related to maternal and infant health. The ones that are on this slide here relate to reducing maternal and infant mortality, as well as improving general health outcomes for pregnant women, mothers, and infants. One that I will highlight in particular is a legislative database that is publicly available. It includes enacted legislation from across the country on a variety of topics that I mentioned today, as well as other topics that speakers mentioned throughout the morning, for things like postpartum insertion of long-acting reversible contraceptives and addressing neonatal abstinence syndrome. So thank you for your time today. Here's my contact information, as well as Kind Winds, who again is NCSL's maternal and child health expert. Please let me know if you have any questions. I'm happy to answer now or follow up with you all.
Tara, thank you so much. We're going to look over this and I'm sure we'll get back to you with any questions that we have. So I don't think there's any questions right now. I think we're going to digest this information and get back to you with any questions. So thank you so much for hanging in with us today. We really appreciate your assistance and the assistance of the National Conference of State Legislators in preparing for these hearings. Thank y'all very much.
Absolutely. Thank you for having me.
And our next speaker, if Terrence will come on up. Y'all will see in the agenda, we were supposed to have Terry hearing from President of Choose Life Mississippi. She was unable to be with us today due to a family illness, and we will look forward to having her in October be with us. So next on our agenda is Terrence Shirley. He's the CEO of the Community Health Center Association of Mississippi. So thank you so much.
Thank you all for having me. And some of you may know us formerly as Mississippi Primary Care Association. So we want to spend a few minutes of your time letting you know what we do in the state of Mississippi and how we are here to serve the residents that we have. We are a 21-member organization. All of the federally qualified health centers in the state of Mississippi are members of our organization. And our role is to do what we can to help them meet the needs of the patients that they serve. Oh. Where? Right.
There we go.
Sorry, wrong one. The wrong one. Thank you. We are often considered to be the largest primary care network in the state of Mississippi. We provide comprehensive services to pediatrics, adult, vision services, dental services, behavioral health, and women's health. Last year, 2021, we provided services to 311,000 patients in the state of Mississippi, located in 263 sites that we have. The last 3 years, from 2019 to 2021, we served nearly 933,000 patients, regardless of their ability to pay. This slide gives you an illustration of where our sites are and where we still have gaps in coverage that we do get addressed at some point. Over the last 3 years, our pediatric operations provided services to 238,000 children, ages 0 to 18. 39,955 of those were children between the ages of 0 and 3. One of our major goals, and we've heard this earlier today talking about EPSDT screenings, one of our major goals is to provide preventive services to our pediatric population. We provided in the last 3 years, 57,000 visits for EPSDT screenings. And we also provided 53,450 immunizations from children 0 to 2. As I previously mentioned, we take patients regardless of their ability to pay. 35% of our women are uninsured, and you're hearing that through the presentations during the day. One slide that I really like to focus on is this one because it addresses the prenatal care that you've talked about earlier today and the low birth weight rates that we have. And these reflect numbers in our particular system. One of our major focuses is the prenatal care for women. And if you look at the numbers, 37% of our women receive their first prenatal visit in the second or third trimester. And that goes back to the issues that we talk about with our low birth weight rates. Our target for low birth weight is 7.8%. That's what we're measured on. But if you look at 2019, our rate was 12.4. 2020, it was 13.8. 2021, 14.3. And you see it's going in the wrong direction. The next three slides will represent the prenatal care broken down by age and broken down by patient seen. And let's look at two levels on this slide. The first one, look at the number of kids that had prenatal care that were under the age of 15. And look at the number of children, 580, that were 15 to 19. These numbers are reflective throughout the last 3 years. 8 were under 15 in 2020. 675 were between the ages of 15 and 19 in 2020. 14 again under the age of 15 in 2019, and 707 between the ages of 15 and 19. These are babies having babies. We had a total delivery of 7,084 deliveries during the last 3-year period. We talked about the scarcities of our resources. We have 10.7 OBGYNs in our system today. That is down from 14.64 in 2019 and 12.73 in 2020. But 1.39 full-time equivalent certified nurse practitioners, down from 1.61 in 19 and down from 1.66 in 2020. But our prenatal services are provided by board certified OBGYNs and other licensed personnel. This slide is reflective of what everybody else has been talking about. Slide on the map on the left gives you the population of patients that were being seen in our clinics by site. And if you look on the right slide, you see the gaps in coverages, and you see the number of FTE, OBGYN FTEs that we're trying to cover the state with. Look at the North Mississippi. We have no OBGYNs in North Mississippi in our system. Look at the Southwest, same difference. So when we talk about how we're trying to provide these services, you see where our gaps are, and you see what the struggles that we're having. We also provide mental health services, and a lot of people have talked about that earlier today as well. Last 3 years, we saw 37,596 patients. We generated 96,000 clinic visits, on-site clinic visits, and 13,000 virtual mental health visits. Each year over year, we have an increase in our mental health patient population, and we don't see that stopping. With that, I'll stop for any questions. It's late in the day. We'll let you have it.
Working, I'm going to ask the first question. What do y'all relate, and what do you've got some, I mean, you've got some people out there that are really working directly with these patients. You've got, I know, a huge group of nurse practitioners that are OBGYN specific related to working with these patients. Why is it just the general reluctance of the pandemic that they're coming in later instead of in that first trimester? What do y'all equate the reasons to that this is happening?
We want to say we are open to everybody, but access to care. You got to think about the distance. And again, if you go back to that map, you see the distances someone would have to travel to actually access care, even though we may have that might be just an organization, but not where that person is physically located 5 days a week. So you're talking about someone having to travel from this location here, because that's one organization. That might be where that OBGYN is actually based. So you're talking about time and distance and access.
Okay, so let me ask this particular question then. Like, say that an FQHC in Clarksdale, if they have a nurse practitioner that is OBGYN specialized, are y'all counting that as a visit within that first trimester? Or are you,
Yes.
okay, you
Yes.
are counting that as well?
Yes.
Okay.
It's associated with the team. So if that service is coded or counted as a prenatal visit, regardless of who provided that service, it will be counted as a prenatal service.
Okay, so that would be counted as prenatal services. Okay. Is there a shortage of nurse practitioners in like that are OBGYN specialized? Is there a shortage of that particular specialty as well?
Yes, the short answer is yes, but we have a shortage, and we're facing the same struggles that the major systems are facing. COVID drove away a lot of our staff as it relates to opportunities to go work somewhere else, travel nursing, nurse practitioners doing the same thing. But we also struggle with not only that level of care personnel, the people at the front desk. Now, if a person at the front desk is working at Walmart, we can't compete with that salary at Walmart. So now you're saying someone else has to step up and do that job. That may very well be a professional. That could be the medical records person that now has to do double duty. They may be an office manager now is having to do double duty. And Lord knows if it's an RN that has to do that.
Do you think also too that culturally, and this will be something we have to trend backwards, do you think people got used to not going, we got used to not going anywhere, much less a doctor's office or physician's office? Do you think that's a cultural barrier we're going to have to break to get these women back into care, much quicker?
Yes, and the other thing is we've talked about community health workers in the system. We actually have a community health worker training program through one of our FQHCs, Aaron E. Henry. What we have to do is understand that that is an expense that those systems have taken on to provide that service. It's an uncompensated expense. So we're bringing personnel on that's not getting reimbursed for service being delivered. As an RN would be reimbursed for services being delivered, or nurse practitioners. We have to think about how do we now compensate the organization for those services, so that is a part of the team approach. And how do we do that?
Does Medicaid provide any reimbursement right now for a certified community health worker? Okay,
That's the problem.
okay. And do you know if other states provide?
I'll have to check and I'll verify that for you and get back to you.
Okay, thank you. Senator Blackwell.
Thank you, Madam Chairman. Thank you, Mr. Shirley. I appreciate you being here. I'd like for you to go back to slide number 8, if you could.
Which one is it?
It's the one with the patients visiting in the various trimesters. That one, yeah. Do you happen to have any statistics on low birth weights relative to the trimester in which the patient first had their visit?
We do know that, and I don't have it for these particular numbers per se, but we do know generically that the later you go into your visit, the worse your outcomes typically are going to be, and it will be definitely as a direct correlation to low birth weight.
Right, but you don't have any numbers to show like the, I think it's, what was it, 441 in 2019 that had their first visit in the third trimester, what the outcome of the birth was?
I'll see what I can find out. No, I don't have that off the top of my head. No.
Right, thank you.
Thank you. Thank you, Madam Chair, and thank you for your participation and testimony today. I have the first question is regarding slide number 7, where you track where you indicate 35% of women patients at health centers are uninsured. Do you have statistics for children?
We can find that for sure. Our overall uninsured rate is right at that number. We're about 33.4 across the board. The women are 35%, but I can find it for children.
And going back to the map, which I think it's slide number 4, locations of community health centers in Mississippi. And my concern in particular would be those counties that are white, where you have no centers.
That is correct.
What would you say are the barriers for entry or impediments to having locations in counties that are not represented?
Funding.
Funding,
Funding.
funding through,
Our centers, and contrary to a lot of belief, our centers receive federal funding from Department of Health and Human Services and HRSA, but it's not 100% of their budgets. So when they write their grant applications, they're actually writing for a certain area, certain demographic, certain census tract, or a certain county. And those funds can only be used for those particular locations. To get into those white areas, you'd have to do a change of scope.
I didn't hear the last.
You would have to do a change of scope and add an additional site. And then HRSA would have to say, yes, we're going to approve it, one, but then we will appropriate the funds necessary to move into those locations.
And those, when you say appropriate the funds, that would be on the federal level? Or
I'm sorry, I didn't hear the last.
you said that the funds would have to be appropriated, but by what agency?
From the Department of Health and Human Services.
On the federal?
Federal level. Of course, now the state would want to help us. We'd be more than happy to have those conversations too. What we've been able to do a little bit with the ARPA funds is several of the centers were able to get mobile units. And so they've been able to go out, but there's still limited access, but they've been able to get out and go to those particular areas, not heavily, because again, they've not been approved for those locations for those funds, but we can put a dent in it with some of those mobile units that we now have.
Thank you.
Do we have other questions? I'm going to ask one final question. You've heard us through several different testimonies today, ask the same particular question. In talking to some of your FQHCs, there was some confusion among some of the population that they were being cut off from postpartum care after 6 weeks due to the letters. Is that something that has been, I know from the ones that I talked to of the FQHCs, was that something that was consistent across the FQHCs?
Yes.
Okay. Thank you very much. We appreciate you hanging with us so long today.
You didn't ask me the question I thought you were going to ask me.
Oh, okay. What is that?
12 months.
We like hearing that.
12 months.
Thank you very
Thank
much.
you.
We appreciate it. This concludes, thanks everybody who hung in with us today and who's hung in with us online. We'll start again at 9 o'clock in the morning. Thank you.